Good morning, everyone. Good morning. A warm welcome to you all. And I would like to appreciate that all of you have joined us overcoming the current natural calamities. Okay, so now I would like to welcome Miss Preeti Pandey for our first session. She is an RCI licensed clinical psychologist associated with various organizations. She has completed her post graduation in applied psychology from Jamia Millia Islamia University, New Delhi. And she has completed her MPhil in clinical psychology from Central Institute of Psychiatry, Ranchi. She is currently pursuing her PhD from Amity University. She worked as an assistant professor of clinical psychology at IBHAS, Amity University, and SGT University also. She's a trauma informed therapist and EMDR expert. I welcome you, ma'am.
Hello, good morning. Yeah, thank you for the introduction, Sneha. Uh, I think I'm one among you guys trying to learn about trauma more and more, trying to go deeper and deeper into understanding the human brain and the nervous system and how to help my clients. Uh, so let's get started. So my topic with trauma survivors, stabilizing and resource building techniques. So I'll start with an example. So this was a girl I had met in a government hospital. All right. Is it okay? This is a 23-year-old girl. I met her around 2 years ago in a government setup, and she was a survivor of incest. Okay. So she comes. It's all about so much dissociation is happening, zoning out at times. She is getting unconscious anytime, anywhere. Lot of nightmares, lot of flashbacks. Okay, so the first session, she talks about her symptoms, what's happening with her. She comes with her sister. She's like a cousin. And when we start to work with her, it's so difficult because there are times when she's zoning out. She talks about things. She remembers what had happened in the past and a lot of flashbacks. Suddenly, those overwhelming emotions. And I think I was kind of new to this trauma work then, had little bit of idea, but not much. So, first session was a bit overwhelming. Then I thought something is happening and this cannot go this way. So the next time she came, we thought, let's not talk about uh, her story. Let's not talk about her symptoms. Let's try to be in the present. So we started with the stabilization thing. What I think stabilization, I understood at that time. So yeah, okay, so she was feeling overwhelmed. Okay, let's do one thing. Let's not do anything. एक काम करते हैं, सर को ऐसे घुमाते हैं, फिर सर को ऐसे घुमाते हैं. So different yoga poses that I had learned from Baba Ramdev, we did all together. And suddenly, oh God, from nowhere she was feeling that calmness. And gradually I realized, yes, this is how I think someone who has gone through such an experience is going to respond. So a little bit of information about like how I perceive trauma work once upon a time, and let's talk about. All right. So traumatic events disrupt life, leaving individuals feeling ungrounded, frightened, and often overwhelmed. Terrifying events strip them of their sense of safety, right? Uh, so recovery from trauma and post-traumatic growth is possible. The first step involves reclaiming a sense of safety and developing or strengthening resources. So there are two things. One is safety, because they aren't feeling safe anymore. that mistrust develops. For many of us, we were not even able to learn how to trust because trauma was like we became a survivor of trauma as soon as we entered this world. And for many, it happened later on. And because it was such a shock that we were not able to get connected to that part of us which could trust people, which could trust even themselves. And the second part is like something which is similar yet difference is resource strengthening. So we have so many resources, like we'll talk about these resources gradually, but little bit of that. My confidence is my resource. My compassion is my resource. My pride is my resource. Even for me, if I have a good relationship with my mother, I think about her when I am going through something troublesome. Maybe she is my resource. All right. So according to Perry Janet, there are 3 phases of trauma treatment. And first is stabilization and symptom reduction. Second is modification of traumatic memories. Third, relapse prevention, relief of residual symptomatology, personality reintegration and rehabilitation. I think in yesterday's lecture, someone would have covered these. So, in a gist, first, we'll try to, all right, so let's take this example. There was a house and it got burnt in fire. Okay. So what am I going to do first? Am I going to build it again? Or I am going to demolish it? Or I am going to first kind of get accustomed with or stabilize whatever is stable there, because it is going to give me more and more strength, or my house more and more strength. All right. So first is stabilization. Whatever is there, I need to stabilize it first. Second, I will demolish, or what is the modification of traumatic memories, because trauma memories get stored in fragmented form. So how to maybe demolish them, or maybe how to modify them. Modification in terms of trauma memories or a human being would be a better sentence here, word here. And then once it has been done, how to reintegrate. Okay, so my topic is stabilization and symptom reduction. Ma'am, this is a beautiful line by Dr. Janina Fisher, someone who has been working in the area of trauma for last many decades. A trauma survivor can have a meaningful, productive life without ever remembering or processing the trauma. But she cannot have such a life without doing the work of stabilization. So that is the beauty of, that is the power of stabilization. Ma'am, all right. So I thought, let me use a Bobo doll here. What trauma does to brain and our central nervous system, like central nervous system, brain being a part of it. So imagine, Bobo doll को किसी ने झटका मार दिया है. No more stable. And now in therapy, I think कि भाई वो झटका पड़ी Bobo doll से मैं बात करूं, कैसे बात होगा? We need to stabilize that Bobo doll first. Ma'am, all right. Not sure whether this window of tolerance diagram is visible. Yes. All right. So this is a beautiful way to explain our own like window of tolerance, how when things happen in our environment, what happens when we are not able to tolerate it, or why we are not able to tolerate it. Okay. So imagine, आजकल दिल्ली में बाढ़ आई है तो उसी की बात कर लेते हैं, यमुना में. ठीक है. यमुना एक जमाने पे बहुत चौड़ी थी, जिसमें सेडिमेंटेशन नहीं हुआ था, जिसमें कूड़ा करकट शायद इतना नहीं पड़ा था. क्या था? शायद it's again a hypothetical situation, nothing to do with Kejriwal. So imagine, उसमें with time, because of number of stresses or maybe because of trauma, what happened, a lot of emotion, like earlier कुछ भी होता था उससे बह के निकल जाता था. बड़ी बड़ी चीज, बहुत सारे clients में, you must have heard from a lot of clients that there was a time nothing could affect me, but now if I see somebody weeping, I just can't control myself. Even if somebody knocks at my door, I get shocked. I do not know what happened. All right. So actually, what happened there? Once upon a time, maybe the window of tolerance was big enough. Okay, it's again Yamuna जो बड़ी थी, जिसमें कि जब भी इमोशन आता था लहर बन के निकल जाता था. Unfortunately, things happened, and we had to go through number of experiences, or maybe one big T, because of which this window of tolerance shrunk. All right, उसमें bottles भी पड़ गई, उसमें रेता भी जम गया, सब कुछ हो गया. अब क्या हुआ? छोटी सी भी चीज आई, लाइक थोड़ी सी भी बारिश हुई और बाढ़ आ गई. All right, so this happens when we are not within a window of tolerance. So what happens? Dysregulation happens. The one in orange above the yellow. All right. So what actually? Let me read about what window of tolerance is. This is where things feel just right, where you are best able to cope with the punches life throws at you. You are calm but not tired. You are alert but not anxious. Okay. अब कुछ ऐसा हुआ जिसकी वजह से हम dysregulate हो गए, and we tend to dysregulate. This is how our nervous system is. ठीक है? So when dysregulation happens, this is when you begin to feel agitated. You may feel anxious, revved up, or angry. You don't feel out of control, but you also don't feel comfortable. All right? फिर उसके बाद क्या है कि dysregulate हम सब होते हैं, ठीक है? But sometimes, or then we come back to our window of tolerance, and again window of tolerance is what? A place where we can be like where we can tolerate that anxiety, where we can tolerate that difficulty and move on. We are alert, but we are able to take it. Okay, but sometimes, especially with trauma survivors, what happens? They move to their hyperarousal zone of hyperarousal. And what happens there? This is when you feel extremely anxious, angry, or even out of control. Unfamiliar or threatening feelings can overwhelm you, and you might want to fight or run away. All right. And the story doesn't end here. There is one more zone, which is called hypoarousal, zone of hypoarousal. And it's here. Not sure whether you guys can see it, but I'll read it for you. This is when you feel extremely zoned out or numb, both emotionally and physically. Times can go missing. It might feel like you are completely frozen. It's not something you choose, but your body takes over. All right. So imagine there's a client who is zoned out in session. He is somewhere else. She is somewhere else. All right. और हम बस बोले जा रहे हैं, पूछे जा रहे हैं, वो है ही नहीं वहां पे, तो क्या होगा? All right. So before we move ahead, we need to bring them back to the session. And maybe stabilization is one way to do that. Or it's the only way to do that, I'll say that. So, ma'am, so let's review the same thing using the polyvagal perspective. So, I think everyone knows, but just to make it a bit more hilarious, how I explain many of my clients about our sympathetic nervous system and parasympathetic nervous system. So a parasympathetic nervous system is that part when we are grounded, when we are calm, where we are composed. Okay, so how I say, para mein Ram shant hote hain. Okay. And then it's sympathetic nervous system. Sympathetic mein sham chanchal hote hain. Just to help all my clients remember what's happening with them when they are at that stage. All right. So, so there are two parts in a nervous system, central nervous system. One is called sympathetic nervous system and one is called parasympathetic nervous system. Okay. So what happens when we are in fight or flight mode? When we are anxious, when we are irritated, okay, we are in a sympathetic nervous system. Okay. And when we are calm, composed, in the present, we are in the parasympathetic nervous system. Acha, All right, all right, all right. So, according to Hindu mythology, God Ram is kind of a very calm person, composed, okay, uh, listening to everyone, just being in the moment, all right. And Krishna Bhagwan, who is called Sham, is Chanchal, all right, clever, notorious. So for many of clients, because many of our clients don't come from biology background, we need to help them understand what's happening within. So I've just made a print, para mein Ram hai, sympathetic mein Sham hai. All right. So what happens in the nervous system when we are in the present, when we are enjoying, maybe when we are with our friends, when we are just calm, composed, we feel safe. We are in a parasympathetic nervous system, which means here that psychologically how we feel. Calmness in connection is there. They feel settled, grounded, curious, compassionate, mindful in the present. And in the parasympathetic nervous system, actually what's happening within our body, because okay, one more example about how our brain works. Imagine there's a all right. So imagine this. So this is the hand model of the brain. I think कल ये शायद cover हो गया होगा, but let me talk about it again. So this is my neocortex, which is or the prefrontal cortex, which is my thinking brain, and I call it CEO because it does all the executive functions. All right. Within it lies the emotional brain, the survival brain. All right. Ideally हम सब reptiles हैं, ठीक है. हम evolve होते गए और हम humans बन गए with this level of intelligence. Yet our body still knows how to survive. जो हमारा बेसिक इंस्टिंक्ट है वो सर्वाइवल है, ठीक है. अब होता क्या है कि जैसे ही कोई खतरा आता है, if there is any threat in the environment, our CEO stops working because our reptilian brain takes over. As soon as our limbic system smells something is off in the world, our survival brain gets activated. And that is why many of our clients at times tell, हमें सब पता है, मतलब why would I always talk about client happens to us too. हमें सब पता है, लेकिन जिस वक्त जरूरत होती ना हम यूज नहीं कर पाती. कैसे? Because the prefrontal cortex had gone to sleep. It was my survival brain, my primitive brain, which had taken over. And what does a reptile do? एक सांप क्या करता है? या दौड़ लगा देता है या डसने आ जाता है. This is what we do. सांप का दौड़ लगाने का मतलब क्या है? It's anxious, it's worried, it's concerned, panicky, and काटने को आ जाता है. It's aggression. All right. And this is what we guys do. And sometimes we go to our freeze mode. And when nothing happens and we feel we just can't, then we go to a collapse mode where we feel it's all hopeless. All right. That depression seeps in. So when the survival brain gets activated, what it does, it actually activates our sympathetic nervous system. And this sympathetic nervous system takes over and our body goes to that fight or flight mode, sometimes that freeze mode too. So let's talk about what happens in our body when we are in parasympathetic mode, when CEO and when the survival brain, emotional brain, and the thinking brain, they are working all together. So digestion in the body is good, intestinal motility is good, resistance to infection is good, immune responses are good. मतलब बहुत सिंपल सी बात है कि जो फिर से मैं मजे में अपने क्लाइंट्स को बताती हूँ, हमें दौड़ लगाने की कभी नाखूनों की जरूरत नहीं होती है. हमें कभी भी we don't need our hair to run or to fight. Even we don't need our digestive system to fight or run. So these are getting best amount of oxygen and blood when we are in a parasympathetic nervous system. When we are grounded, we are calm, we are composed. All right. What happens when there is a threat in the environment? We go to that fight or flight mode. So fight, rage, anger, irritation, frustration. Flight, it's panic, it's fear, it's anxiety, it's worry and concern. All right. And again, अभी हम लड़ने के लिए या उसके लिए तैयार हो चुके हैं. What will happen? Blood will move to all those vital organs which are required to fight or flee. And it won't go to all the organs which are not required, including digestion. That is why most of the times when we are under stress, डाइजेस्टिव सिस्टम गड़बड़ाया होता है, इम्यून रिस्पॉन्स गड़बड़ाया होता है, हमारे बाल बहुत झड़ रहे होते हैं, हमारे नाखून, हमारे स्किन, बिकॉज दे आर नॉट रिक्वायर्ड फॉर दोज वाइटल फंक्शंस. And then it's still a time when we say I can run. Imagine we are in a jungle, all right, and we were just roaming around. Suddenly we realize a tiger is approaching us. We start to run. Okay, our fight and flight response got activated, like our flee wala response got activated. We started running because we are thinking after maybe half an hour we'll reach a point jahan pe ek fence aayega, hum koodenge and we'll reach a safe village. Unfortunately for many of us, that fence never comes, or before that fence could arrive, we are tired. We go to that zone where our nervous system says no more, I cannot. And that is the time when we reach that most, that is dissociation, numbness, depression, raised pain threshold, helplessness, shame, shutdown, hopelessness, preparation for death, and trapped. So imagine हमारे कितने सारे clients हैं जो हमारे लाल zones में आते हैं हमारे पास, and we are just talking to them, and sometimes we are asking them about their symptoms and their histories, and what happens, it triggers them more. वो शायद अभी इतने red zone में थे तो वो शायद double red zone में पहुंच जाते हैं. So here comes the work of stabilization. It begins with a change in therapist's attitude and a change in their role. So, bit change in the role. How? The attitude that nothing, not even the patient's feeling, is more important than safety and stability. So first thing is safety, stability, safety, stability. After that comes listening to their stories. Okay. And sometimes I think that is why taking a trauma history is very different from what we learned when I think we were doing our own training. एक दिन में सारा बना लो, डायग्नोसिस तक पहुंचना ही पहुंचना है, चाहे कुछ हो जाए, चाहे पेशेंट रो रहा हो, धो रहा हो, कुछ भी करे, डायग्नोसिस तो बनाना ही है आज हमको. I think that is how trauma history is very different, because here patient comes first, our client comes first before our curiosity. Ma'am, so the most important tools in stabilization are, okay, so let's talk about how to work as a trauma informed person here, who is not threatening the client, who is just being there with the client. All right. So there are times when our client would say they want to tell us about what happened with them. Okay. We will try to model it. Is it okay for you to? Will it be okay for you if you speak about it? All right. Sometimes, okay, yes, or they would want to. I feel your safety comes first. For me, I can't ensure what happens outside the session, but inside the session, I want you to be safe. It's all right. We can take our time. We can gradually move ahead. It's like with trauma therapy, slow is fast. So how slow I go, it's okay. The most important part is that my client needs to feel safe. I'll tell you, I have been working with many clients for like 1 year, 2 years. So this client, I worked with her for like 6 months. Yesterday week, so sometimes how difficult it is for them to trust. Okay. It happened in yesterday week session only. I said something. Yeah. So what she said, she told me, Preeti, these rape, like, there were times when she would herself say, Preeti, these rapists, they have their own backgrounds, they have their insecurities, they have their own traumas. That is why they become what they become. Or parents who are abusive towards their children had their own traumas. That is why they become what they become. So what happened in that particular episode, I think some part had come where she was, a very angry part had come, which was like, this world is unjust to me. This, like, this world is unjust to everyone who had to go through what I am going through. And she's just said something about rape, like the same sentence. I think I was not in the present or what. I just used the same sentences which she had someday kind of told me. I told, yeah, because they have their own insecurity or something. I don't remember it exactly. And suddenly, I could see a change in her affect. It felt as if she cannot trust me anymore. Imagine someone I have been working for last 6 months. And this happened, I think 2 weeks ago. So last week when she came, Preeti, this is a change within me. Earlier, if you had used those sentences which you used last week, I think I would not have come to you ever again. Now I know there is a part of me which understands what you are like, this is it. Okay. But the other part says, even Preeti could not hear me. I can't trust even Preeti. So imagine that much fragile these individuals are, and how important it becomes for us to build that safety net around them, to make them feel at home, stable, safe. So the most important tools in stabilization are psychoeducation, second, therapist modeling of attention to safety, skill building, empowering the patient by teaching them how to take charge of their therapeutic process. All right. So one by one, let's talk about uh, how different, like what psychoeducation looks like in stabilization. Like psychoeducation, I think is most important in every approach that we use. चाहे वो CBT हो जाए, चाहे वो कुछ हो जाए. So, so what we try to do, we try to depathologize. हम बहुत सिम्टम पे बात करते हैं ना, या हम बिल्कुल एकदम पेशेंट को एकदम पेशेंट बनाते हैं, ठीक है. एंड समटाइम्स वो बिल्कुल ऐसा लगता है, अरे कौन सा बड़ा वो हो गया है. सो उसको उस विक्टिम मोड से हम एक सर्वाइवर मोड में लेकर के आ रहे हैं, ओके, जहां पे एवरी सिम्टम हैज एन एक्सप्लेनेशन. इफ दैट क्लाइंट हैड टू सेल्फ हार्म, there was a reason behind it. Okay, if that client got engaged in some reckless behavior, for sure there was a reason behind it. And because the client is thinking, I'm crazy. And then I'll give you example of a client of mine who was having extreme dissociation, this girl. And after some time, like पहले मुझे नहीं पता था कि ये क्यों, like I could understand this is dissociation, लेकिन हाँ, but she was having a lot of suicidal intent, lot of. So I just try to understand कि हो क्या रहा है ये सुसाइड के पीछे. आपको पता है, it was not because of any other reason, because वो dissociation इतना खतरनाक हो रहा था कि उसको लग रहा था कि यार मैं तो पागल हो रही हूँ, let me end my life. And like this, because there was extreme cloudiness that she was feeling in her head. It felt as if I am there, but I'm not there. There were times when she was having these episodes of derealization and depersonalization in different forms. This dissociation was occurring. And because of that, she felt ki, bhai, I'm going crazy. And now we had to help her get psychoeducated in a way where she is able to understand कि भाई मैं क्यों इतना डिसोसिएट कर रही हूँ, हो क्या रहा है मुझे जो मैं डिसोसिएट कर रही हूँ, या फिर मैं क्यों सुसाइड की ओर को सोच रही हूँ if this is happening. So whatever symptom my client is having right now, there is a reason behind it, and we just try to explain it in such a way so that, again, from that victim or crazy mode to that survivor and a human response. All right. For example, सेल्फ हार्म का ही तो आई थिंक ये डीबीटी किताबों में भी आई थिंक मोस्ट ऑफ अस वुड हैव read about it. So the client cut her wrist. Okay. And why did the client cut her wrist? Because right now at that moment, or maybe थोड़ा बहुत उनसे पता भी चल जाता है because they have their own reasons behind it. Maybe. Preeti, this emotional pain is so overwhelming that I had to cut my wrist. As soon as cut my wrist, I suddenly felt better. I felt as I have come back to the moment. And now, again, यहाँ से मेरा शायद साइको एजुकेशन होगा जहां मैं उसे बताऊंगी what actually happens within us. The concept of endorphins, how adrenaline rush happens, okay, and how ultimately the client comes back to reality, to the present. So there is one more. So what happens as a result of that? It decreases patient's shame, confusion, and sense of being crazy. They have a lot of shame. और कई बार ना चाहते हुए भी हम लोग ऐसे sentences बोल जाते हैं जिससे वो shame ना double हो जाता है. So this kind of education is actually helping them to deal with their shame. For them to understand that yes, they are a human being, and because of something that happened, this like kind of at that time when this thing happened, this was the best survival option for them. All right, it's not that it's a psychopathology, but maybe that felt like the best option at that time. It doesn't mean that हम उनके उसको बहुत बढ़ावा दे रहे हैं. उसके साथ साथ हम ये भी बता रहे हैं that yes, however, it has its own long-term consequences, and we always have examples ready with us. At the same time, when we talk about the shame, there is one more thing to it. We are talking about you survived very well when that happened. It shows that you have the strength to recover. You have everything within you to recover, to get out of it. Again and again. And again, ये सोच के नहीं कि एक सेशन में कर लिया हो गया. We have to do it as much as we want. As much as our client requires it. कभी खत्म नहीं होता है, करते रहना पड़ता है, बीच बीच में करना पड़ता है, because there are times when their hopeless part comes out. There are times when वो parasympathetic में वो लाल जोन में पहुंच जाते हैं, that polyvagal में, or the yellow zone. Ma'am. Then modeling has two purposes. So it's like modeling to ensure safety. Because many of our clients, they actually know how safety looks like. They have no idea of it. You know, I have heard my clients telling after like few months of sessions, Preeti, you know, for the first time, like now I feel how good calmness feels like. My life was so chaotic at that time and I couldn't calm myself down. और आपको पता है प्रीति, अब तो थोड़ा chaos होता है, मुझे लगता है भाई मुझे मेरी personal space दे दो, मुझे calmness में जाना है. And these are those clients जो कहते थे once upon a time, we don't know how calmness feels like. We don't know how safety feels like. So this happened with it's a very new client. I've had like 3-4 sessions. So first day, I thought, let me see how she feels about safety. And she was amazed. She was astonished Preeti, for the first time, I realized I do not know how safety feels like. Imagine something as simple as safety. They have no idea how safety feels like. And we are trying to work to reintegrate and their personalities. So modeling, so to think about our own safety, it starts from how we model it. So according to Janina Fisher, she works a lot in the area of trauma. She says that it starts from the time when we have had a first contact with the client. Which means जब हम फोन पे भी बात कर रहे हैं ना, तो हम बोलेंगे I hope before you enter my session, like from now to the time you reach me, you will remain. There are measures around you to keep you safe. I hope there are people around you, or not people, but because people can trigger them again. Maybe they don't have any. So a very open-ended thing just to tell them that I hope you are safe between this. And again, when the client comes to the session, हम अपनी बातों से, अपने क्वेश्चंस पूछने के अंदाज से ये चीज को मॉडल कर रहे हैं that safety comes first, your stability, your safety comes first. All right, so जैसे कि फिर से जैसे the example I gave you earlier, the client wants to tell everything about her. We will try to calm them down. It's all right. Okay. For me, your safety comes first. I don't want you to get extremely overwhelmed. All right. And maybe let's talk about something else. Sometimes they want to talk about, and we tell them that let's not talk about it today. They may feel, they may get angry. They may again feel rejected. Again, as eager as you are to tell what's happening with you, I'm similarly eager to know about it. However, for me, your safety comes first. For me, it comes first that you don't get extremely overwhelmed. मैं इसे मजाक में कई बार ऐसे भी बोलती, इमेजिन आप करो हमारे दिमाग, लाइक आई सर्वाइव टिल डेट बिकॉज माई ब्रेन यूज सो मेनी स्ट्रेटेजीज. इमेजिन उसने ये एपिसोड हुआ, उसने उसको लॉकर में लॉक किया और ब्रेन में कहीं डाल दिया, छुपा दिया, और अब सेशन में जब हम आए हैं, जैसे कि हम उन लॉकर को खोल रहे हैं और सामने ला दे रहे हैं, इमेजिन वो जितना सामान था सब बाहर आ गया है. एंड दिस सामान इज नॉट जस्ट क्लोथ्स, इट्स इमोशंस, इट्स सेंसेशंस इन योर बॉडी, इट्स थॉट्स, इट्स मेमोरीज, इट्स सो मच. इट्स अगेन बिलीव्स दैट आई हैव अबाउट माई ओन सेल्फ एंड द वर्ल्ड. सब कुछ आ गया एंड बिकम्स वेरी डिफिकल्ट एंड टू कंटेन इट. All right. So using our own metaphor, our own ways to just tell them that again, slow. Then sometimes I think that it is. So then third is the skill building. अभी हमने उनको ये तो इंश्योर करा सेफ, मतलब व्हाट वी आर ट्राइंग इन द कि भाई उनको समझ में आए कि सबसे पहले उनकी सेफ्टी आती है. ठीक है. Then the skill needed for trauma patients in order to stay stable include following: grounding and centering techniques, then coping strategies for dealing with suicidal and self-abusive impulses, then contracting for safety with themselves and others, how to anticipate stressful or triggering events, learning how to calm the body and mind, distinguishing past and present reality and how to stay in the present, then recognizing and making better use of dissociative abilities. So all these are a part of what we do in the process of stabilization. Ma'am, can we come to the skill building side? Right. All right. So it's फर्स्ट इट इज ग्राउंडिंग एंड सेंटरिंग. आई थिंक ग्राउंडिंग ऐसी है, जहां हमने डिसोसिएशन पढ़ा था वो हमने ग्राउंडिंग सबसे पहले सीखी है. लाइक वाइवा में भी होता था, क्या करोगे डिसोसिएशन में, मैं ग्राउंडिंग करूंगी. तो आई थिंक ग्राउंडिंग वी ऑल नो इट हैपेंस through different ways. Sometimes we use imagery, sometimes we just use our body to see how it feels in the present. All right. Then coping strategies for dealing with suicidal and self-abusive impulses. I know suicidal contract हम सबने बना रखे हैं. It's bit different क्योंकि trauma के केस में क्या होता है ना, there is a lot of struggle with power and control. All right. और अगर उन्हें कहीं से भी ऐसा लगेगा ना that we are trying to exert our control, it won't help. It won't help. So वो कुछ इस तरीके से that they realize that we are not controlling them. Okay. At the same time, suicide or these contracts fail because they feel powerless enough to sign them, to use them in their life. So कितना simplify करके हम उनका contract बना सकते हैं, कितना simplify करके, हमको बहुत ज्यादा जाने की जरूरत ही नहीं है. मेरा contract बस यही है that I take charge of my life, of my recovery. As simple as that. So depending on my client, okay, but contract are important, and not just making a contract. to go through it again and again to see if my client followed it. If he or she did not, then what led to this, that the client did not follow it, and what next can be done. Then it's contracting for safety. Okay, so all right. So contracting and the coping strategies. There is one more thing when I talk about coping strategies. Like I told you, because they don't have any idea of how safety feels like, or sometimes they reach like the fight, flee, or the fight, flee, or the freeze response or the collapse response is so instantaneous that they don't know what to do. We need to create that safety net around them. और शायद वो सेफ्टी नेट भी लेवल्स में होना चाहिए. पहला ऐसा हो सकता है जो कि अगेन वील हैव अ डिस्कशन विद देम, बट फर्स्ट थिंग आई एम गोइंग टू डू, ठीक है, वो ये हो सकता है दैट आई स्टार्ट डूइंग समथिंग एल्स व्हेन सच थॉट्स अकर. Second safety net could be कि I'll go for a walk, or maybe some things ready with me. It can be again list of things or people जो कई बार कहते हैं ना, आप लोगों ने सुना होगा, केवल उसकी याद आई मुझे इसलिए मैंने कूद नहीं लगाई. सो मे बी सच, वो जो कि उस इंस्टेंट में उनको याद करूँ और मुझे कहते हैं ना एकदम से है कि नहीं, आई नीड टू लिव. Then it can be just messaging my therapist. But messaging or calling my therapist is never my first net. Third, and maybe fourth would be calling my therapist. So again, we have that net ready. We have that box ready, like they have that box ready with them कि अगर मुझे even first safety net में बार बार ये पढ़ना कि क्या क्या चीजें मेरे लिए trigger zones बन सकती हैं, that I am aware of it. How to anticipate stressful or triggering events? Again, जब भी हुआ हमने वहीं पे सेशन में क्या हुआ कैसे हुआ, जैसे कि पूरी हमने किस किस स्टॉप में गाड़ी रुकी थी वो जानने की कोशिश करी, फिर क्या हुआ, फिर क्या हुआ, फिर क्या हुआ, फिर क्या हुआ. सो समटाइम्स ना ऐसी, आई थिंक यू गाइज ऑल आर फ्रॉम दिल्ली एनसीआर, सो सबने ब्लू लाइन यूज करी होगी. तो जो मेरे दिल्ली वाले क्लाइंट्स है ना, उनको ऐसे ही मैं मजे में बोलती हूँ, कभी आपने ब्लू लाइन में चढ़ा है, कभी द्वारका से, और आपको जाना था नोएडा इलेक्ट्रॉनिक सिटी, लेकिन ध्यान नहीं रहा वैशाली की मेट्रो में बैठ गए. अभी जैसे रियलाइज हुए, यमुना बैंक पे रियलाइज हुए, वहीं उतर जाओ कि भाई चले गए, ठीक है. अगर रियलाइज हो रहा है निर्माण विहार में, वहीं उतर जाओ, ठीक है, सो दैट यू कैन कम क्लोजर टू यमुना बैंक, यू कैन चेंज योर लेन एंड यू कैन गो बैक. और अगर आपको द्वारका से आते आते शायद सीपी में, राजीव चौक में याद आ जाए, बेस्ट टाइम टू चेंज योर लेन, because it helps us to not go to that memory lane, or not to it helps us to not go to that zone of rumination. Then distinguishing past and present reality and how to stand in the present. Okay, so what happens with trauma, it's like a part of me is frozen back in time. Sometimes I'm actually not reacting to the present incident, I'm actually reacting to what had happened to me in the past. So it becomes very important for them, or for all of us, to come back to the present, to stay grounded in the present, so that we are dealing with the present when we are not reliving the or living the past. एंड अगेन इसमें हमारी ग्राउंडिंग, हमारी जितनी कामिंग एक्टिविटीज होती हैं, माइंडफुलनेस एक्टिविटीज हैं, ऑल दीज हेल्प अस टू स्टे. Then recognize and making better use of your dissociative abilities, because trauma or dissociation, they are closely related. Why did they dissociate? Because if they hadn't dissociated at that moment, it would have felt like it is a threat to survival, or the information was so overwhelming that the brain had to dissociate itself. Or maybe if it is happening now also, they need to dissociate because it's so overwhelming. And how to again use dissociation, how to come back to the present. And yes, ma'am, so let's exercise a container exercise. Let's make a container for our own selves. It's again an exercise which we use as a part of stabilization, a beautiful one. All right. All right. So when it says that how to use that dissociation can happen in एनी वेज ओके सो जब हम डिसोसिएशन की बात कर रहे हैं ना और यहाँ पे हम डिसोसिएटिव एबिलिटीज को यूज करने की बात कर रहे हैं तो इट्स मोर लाइक कि first identifying so what we actually do when we try to identify dissociative experiences, we sometimes use this dissociative experience questionnaire so that we are able to get a good information about कि वो डिसोसिएशन किस किस तरीके से हो रहा है. ठीक है. और जब हमको उस चीज का पता चल जाता है, मान लो कि उसने बोला मुझको I just zone out when I am talking to people. I just zone out. तो यहाँ पे dissociative abilities को mainly use करने का ये है कि this is how it's like I'm just trying to help that client to understand how your dissociation is helping you at that moment. It's more like that. Okay, how your dissociation is helping you at that moment and how then you can gradually come back. It's more or less like that. So let's exercise a container exercise now. So what a container exercise looks like, it's simple. It's like you have to create a container. This container can be a container of your imagination. It can be a container, a real container that you have right now with you. It can be something that you have had once upon a time in your life where you used to keep your precious things. So it can be like which nobody touched. All right. So मान लो उस कंटेनर को मेरे क्लाइंट ने बोला that it is a wooden box. ठीक है. It is this big and it has a lid and it has a lock, a beautiful lock. So उसने उसको describe कर दिया. Now let's notice what's happening in my mind right now. Okay. So the client may say कि right now or let's do it right now. Why not to do it on our own selves? Okay. So just imagine your containers where you would want to keep your disturbing thoughts, your memories, or anything that you don't want to deal with right now in this moment. I hope you guys have imagined it. All right. Now just imagine as if if you want, you can close your eyes. Imagine as if I am walking towards my own mind and noticing what thoughts are there that are bothering me right now. These are my thoughts. Nobody can take them away from me. However, right now in this moment, I want to keep them inside my container so that I can deal with them in future or whenever I want to. And with this thought, whenever you have identified your disturbing thought, memory, or whatever it is, start packing it and beautifully keep it inside your container. Place the lid and come back. So I hope you were able to do it. And now just come back to your mind and see how does it feel? Does it feel spacious? Sometimes it does wonders. Sometimes what happens, with lot of our clients, they have so many issues going on at the same time. Uski wajah se they are not able to concentrate on one. What we can do? Just walk to your mind. Notice what's there. Let's pack it. Keep it inside a container. Second, let's pack it. Keep it inside a container. Let's pack it. Keep it inside a container. Come back. Let's talk about what remains or what you want to explore first. तो वो जो वो ऑल ओवर द प्लेस वाली फीलिंग होती है ना, एक ये चले जाती है. कई बार मेनी ऑफ आवर क्लाइंट्स कहते हैं ना, रात को मैं और मेरी तन्हाई आपस में बातें करती हैं, सो बहुत सारी बातें कर रही होती हैं. आस्क देम टू यूज दिस कंटेनर. समटाइम्स है प्रीति 100% नहीं गया, जितना जाता है उतना बढ़िया. ऑलराइट. सो now let's do one more exercise, again a stabilization exercise. This is called light stream exercise. So are you guys willing to do it? All right. So in trauma work, we use a lot of body sensations, make a lot of use of our body sensations. All right. So again, one more thing, with clients who were a survival of trauma, we give them an option if they want to close their eyes, because closing their eyes would be extremely like they would feel extremely insecure closing their eyes. All right. So again, if you want, close your eyes. If you want, keep them open and through your mind's eye. All right. Let's start with this. So take some deep, long breaths as if I'm trying to connect with my own breathing. This is my body and it belongs to me. And right now, in this moment, I am trying to connect my own breath. I'm just noticing how far it goes inside my body. I'm tracing my own breath in my body. And now, gradually and gradually, let's move towards our own brain as if we are trying to use our mind's eye to scan our whole body thoroughly. Imagine that your mind's eye have become a CT scan machine, and this machine is scanning your whole body from top to bottom. Start from the top of your head and gradually start scanning towards your feet. And notice, where in my body do I find any kind of discomfort, any unusual sensation, any tension, any heaviness? And when you are ready, let me know whatever is happening. So, right now, you don't have to tell me, just have to keep it with you, register it. Okay. So, once we have done it, now that you have found out part of your body that feels discomfort, tell me, if this sensation had a shape, what shape would it be? If the sensation had a color, what color would it be? How big does the sensation look like? If the sensation had a sound, what sound would it be? If the sensation had a texture, what texture would it be? If it had a temperature, what temperature would it be? Now, what would be your healing color today? A color that you think is a healing color for you, that is a soothing color for you. So once my client tells me maybe green is my healing color, now imagine from the cosmos, a green cosmic energy is coming, and this energy is reaching there. This energy is very powerful and abundant. It has come to care for you, to heal you. Feel its intention as it spreads in that area. Notice if this energy had vibrations, how would these vibrations feel? If this energy had a particular temperature, notice how that would feel when it spreads there. And then let's take a moment to come back and see what's happening to the shape, size, and color now. So I'm just trying to uh, do it this much. We can go on for like minutes doing the same thing. Sometimes clients say it has changed, sometimes it hasn't, it gotten bigger, sometimes it's gotten smaller. So anything can come. It again is a stabilization exercise called light stream exercise. Ma'am,
Hello? Yeah. Just give me a moment.
I'm not able to see who.
Are you able to hear me? Yeah. So I wanted to ask about the container exercise that we did. So as we were discussing yesterday, certain trauma can show up as different psychopathologies, and with when trauma shows up as anancastic personalities, uh, there I'm a bit confused about how to go about such an exercise, if it is a good idea at all, because what I have received when I've tried it once is that it
Doesn't work.
yeah, it felt like to the client that okay, so I have to schedule my worry.
Yes, it's like
और
प्रीति मुझसे साफ ही नहीं हो रहा है.
हाँ,
मैं कितना भी करूं और बढ़ जा रहा है. Yeah, it does happen, and sometimes with such clients we can use other stabilization exercise. Like it's like whatever fits your client. जो मैंने light stream exercise कराया ना, it again doesn't fit everyone. Maybe for them we need to use a lot of body based work. Okay, so whatever fits your client.
and another thing there is that so with this light stream exercise and other body based relaxations, sometimes victims of trauma of various kinds have some reluctance towards going into these kind of stabilizing exercises also, um, and the conflict for me arises that this is an important part of the stabilization, but also not, of course, to kind of convince the client into doing it. So how do you suggest we go about that sort of a situation? So what I sometimes also have a difficulty where is that I feel like right now it is important we go into a stabilizing mode, but the client, like you shared an example, has a strong desire to discuss what they want, what has come up for them emotionally, and it always becomes difficult to kind of create space for both the aspects. So if you have any suggestions on how to go about such situations.
So it's more about how I'm using my psychoeducation. It does happen, and then at times we have to कहते हैं ना कि again remember I have to be very directive at times. Your safety comes first, and why am I doing it? To ensure this, maybe we'll take them to the window of tolerance, we'll take them to the polyvagal perspective, we'll use our own analogies to help them understand why we are asking them to do what they are doing. Or it can be इतना करने की भी जरूरत नहीं है. Sometimes notice your like कई बार there are many of our clients who have pets at home. Let's take a time, let's take our own good time to notice our pet. So I had like this client who had 2 bunnies. Bring them on, sit with them, online session था. ठीक है, let's do it. बहुत तरीके से होता है. टेक्सचर यूज करो, स्मेल यूज करो, मूव अराउंड इन द रूम. ठीक है, go to your dressing table, not just smell all the deos that you have in your room. Can use anyway just to help them. कोई भी senses use करो, कुछ भी करो, whatever fits your client. However, psychoeducation needs to be tailored according to how my client is going to receive it. Does it make sense?
In response to which the question was, can we also do it simultaneously? Like if the client is sharing some event, can we have like a grounding thing at beside them, like a cushion or some stress ball or something which at the same time grounds them?
Yes, we can. Like you can ask them to keep a soft toy with them, the favorite toy with them, their pillow with them. It's like again, उस सेफ्टी को बनाने के लिए मुझे साइंटिस्ट बन जाना है कि मेरे क्लाइंट के लिए क्या बेस्ट फिट होगा, लेकिन मैं उसको तब तक नहीं बोलने दूंगी इतना ज्यादा कि मैं उसको कंटेन ना कर पाऊं. पता चल रहा है वो 1 घंटे के सेशन के बाद अभी तक तो वो केवल लो फील कर रहा हूँ बोल रहा था. सेशन के बाद मैसेज आ रहा है, मैम अब तो मैंने अपना हाथ भी काटना शुरू कर दिया है. It does happen at times if we are not able to use it properly.
Just one understanding. What I'm understanding from yesterday's discussion and today your discussion is that
even stabilization has a lot of levels. It's that you don't start maybe with light stream exercises. You just start with simple body awareness or environment awareness.
Yes.
Can you elaborate a little bit more for our clarity how that leveling up can happen or from where you can
So
start?
it depends on client. It depends on your client. Sometimes with your client, this will do wonders. This
Okay.
light stream exercise. But with some, just one of my, I give you example of this client of mine. Preeti, मुझे नहीं समझ में आ रहा. I just can't understand what you are doing. Okay, I need to do something. So what did I do? I just asked her. So again, जो मैंने आपको बोला था ना, करो इसको इस तरीके से कर लो. Just focus on what I'm noticing here. ठीक है? Let's do this. ठीक है?
Right.
उसके बाद just notice, like sit like this. Notice the wall. How does
Right.
the wall feel? Okay. It can be stretched this way. Anything. Be your own scientist.
Okay.
जो उसके संग फिट करे. Alright?
Alright.
लेकिन ना कोई एक first step नहीं है ऐसा. हाँ.
This is just from the perspective of the client, possibly, or maybe it's a question coming to our mind. With the containers exercise, are we, or will it picture the encouraging the idea of suppressing a little bit? Will the client going through the trauma might get the idea that my therapist is actually asking me to suppress my painful thoughts? Will it picture like that?
Again, psychoeducation here. All right. Right now, in this moment, I don't want to deal with it. Okay? That is why I'm keeping it inside my container. When the right time comes, I'll take it out and deal with it. Okay? और उसमें साइको एजुकेशन जिसमें हम बताएंगे कि हम ऐसा कर रहे हैं तो क्यों कर रहे हैं. अभी हम जब रिसोर्स बिल्डिंग में जाएंगे ना, तो आई थिंक इट विल कम मोर एंड मोर क्लियर. लाइक वी नीड टू क्रिएट एन अम्ब्रेला फॉर आवर क्लाइंट्स बिफोर वी आस्क देम टू गो इन under range.
Or maybe we can ask them that we are going to deal with it one by one. When we are doing it we are keeping the others in the closed box. Something like that.
We can go like this too. Even when we are working in EMDR, na, sometimes what happens, we are working on one memory, other memory comes in. What we do, let's keep it inside the container.
Yes.
Okay, come back to this memory.
Thank you so much.
I get difficulty when I am educating the client because I want to stabilize first before taking all this difficult parts. So what happens is they want to share a lot. And there comes a difficulty. What should I do? Should I let them flow? Should I stabilize? And if I want them to know the importance of stabilization, I will have to go for psychoeducation. That may become a lot theoretical for them. They will think that the therapist is speaking so much. I want to speak. So there is a struggle. So what do I do?
It does happen. It does happen, and it does happen with me. When I'm not even like one session goes, like I think it's I need to learn more, because yes, it does happen with me too कि पूरा एक session उसमें चले गया, वो बोलता गया at the end of the day कुछ नहीं मिला. Does happen, but gradually I have tried to work on like this particular issue. So what I do, maybe initially, ठीक है, I can say it's like, again, there is a part is the compassionate inquiry. ठीक है, Dr. Gabor Mate, if you guys have known about him. So in compassionate inquiry, how they start, I may interrupt you in between. Is it okay? We take a lot of permission before we start the therapy. And before every single session in compassionate inquiry, they always take permission. Okay? और कहीं ना कहीं इससे हमारा वो पावर और कंट्रोल का गेम भी गड़बड़ा जाता है कि बहुत सारे क्लाइंट होते हैं ना, ये भी दबा रहा है मुझे. Like the world has overpowered. Again, this is the therapist is also doing the same thing. Maybe asking for permission helps us. It does. Like my therapist does with me, and I feel, हाँ यार चुप हो जाओ.
Right. Thank you so much, ma'am.
While you were discussing contracting, I was just thinking sometimes trauma clients might present with suicidal ideation or active self-harm tendencies. As per our ethical understanding. We are supposed to kind of help them understand that they have to sign a contract to ensure their well-being, right? So you said that to make the contract very simple. But if I'm seeing that after my risk assessment that it's quite high in intensity, how do we ensure that without, damaging that pattern of that the concept of power and control? Because for them, again, it would be like I'm forcing you to do something.
It does happen. It does happen. So, if you remember, there was a step before it where we are creating their safety net.
Yes.
So it's like making use of both these things together
Hmm.
so that we are able to give them the best. Okay. And sometimes in our safety net, I think we also include not just individual, like people who can help them when they are going through it. So I think all these things all together do. And again, we may fail. हम फेल होंगे because जब वो अपने डोर्सो वेगल में पहुंच जाते दैट रेड जोन, nothing helps.
Yes.
Okay, no issues, we'll come back, we'll again talk. ठीक है, धीरे 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 करके and it does happen. हो सकता first time में ना हो, but it does happen gradually and gradually.
Will it not compromise us ethically if we somewhere not able to ensure after the session that I don't know if they're gonna attempt or
वो तो नॉर्मल कॉन्ट्रैक्ट बना के भी नहीं होता है. आई जस्ट गेटिंग, वो बस हम फोर्स करके बनवा रहे हैं. यहाँ पे हम कंपैशन से बनवा रहे हैं.
They're letting the client come to us.
Yes. Okay. फोर्स करके तो बिल्कुल नहीं होने वाला है. At least if it is going to help, it is going to help only when it is made with compassion. And we are doing the same things, not that we are doing something else. It's just compassion के साथ.
Understood.
All right. So your next thing, something that is again related to stabilization is resourcing. So what happens when due to trauma? Okay. Sometimes, like imagine if there was a child who was एरिक्सोनियन स्टेज की बात अगर हम करें, ठीक है, स्टेजेस में ही जाते हैं, तो पहली स्टेज क्या है एरिक्सन की? ट्रस्ट. अब आप सोचो ट्रॉमा तब हो गया जब ट्रस्ट डेवलप करते हैं. नहीं होगा. कैसे होगा वर्च्यू डेवलप? ऐसी जो हमारी टाइम टू टाइम, एज टू एज जो हमारी वर्च्यूज डेवलप हो रही हैं, अगर उस टाइम पे ट्रॉमा हो रहा है शायद वो नहीं होगा. समटाइम्स हो भी रहे हैं, बट व्हाट हैपेंड? ट्रॉमा अकर्ड, इट हैपेंड. बहुत सारी स्ट्रेंथ ऐसी होती हैं जो कि we are no more near to those strength, those resources of ours. All right, what we need to do then? जैसा आपने बहुत सारे सुना होगा कि आपके क्लाइंट्स आके बोलते होंगे, I used to be this confident person, I don't feel confident at all. I used to be patient, like people used to give my examples when they talked about patience, but I don't feel patient at all. All right, so ये सारी चीजें जो कि मैंने आपको बोला ना, when we are going to work with the trauma, we need to first create an umbrella. तब हम सेकेंड स्टेज में जाएंगे जो कि वर्किंग विद द ट्रॉमेटिक मेमोरीज है. अगर हमने वो ही बफर नहीं तैयार किया है, they will relive their trauma, they will feel more broken. All right, so ma'am, all right. So resourcing refers to the way we strengthen our sense of stability and safety in this world. Resources are internal and external tools that allow you to feel grounded in the present moment and capable of turning towards the pain without becoming overwhelmed. They are specific qualities or attributes, beliefs or behaviors needed to address specific challenges. All right, ma'am. So internal, like few examples of internal resources, there can be many more. So I'll give you example of this client of mine who had who is a 55-year-old lady. She sometimes she, like, because she has a daughter who is like 22, 23 years old, and we know their issues. So they fight at times. So she told me, Preeti, I do not know. There used to be a time when I was able to deal with all these issues, but I'm no more able to do it. I don't feel as if I have that left within me. So I just asked, let me know. I wish I had that thing within me, that quality within me. When my daughter approached me and she started to ask me questions, and when she asked me to buy that bag for her, all right, patience, pretty patience. Pakad liya. This is the resource that my client needs right now. All right. So what will we do? We can uh, do three things. One, can you think of a time in your life when you used this resource? All right. हो सकता है उनको याद आ जाए, बट हमारे बहुत सारे क्लाइंट्स होते हैं उनको याद नहीं आता है. ठीक है. Second, do you remember anyone around you who uses this resource or who used this resource with you? All right. कई बार ऐसा हो सकता है उनको वो भी याद ना है. ठीक है. Can you think of any book that you had read, any person that you or any movie that you had seen, or anything जहां पे आपको एक ऐसा इंस्पिरेशन मिली जो कि पेशेंस वाली हो. ठीक है. Sometimes it can even be things from our culture, spiritual figures. It can be even symbols, maybe as patient as a lake, as patient as an oak tree. It could be anything for my client. So I'll give them that opportunity to think of patience उन्हें क्या होता है. अब पहले उसमें आते हैं. Maybe that client realized on particular day I was very patient. All right, tell me more about it. Okay, the client will start speaking about it. Okay, जब उसने बोल लिया, let's take some time to see how do I feel inside my body. What emotions do I feel? One. Second, where do you feel them in my body? All right, वो बताएंगे. ठीक है. ज्यादातर बताते हैं. कुछ लोगों को टाइम लगता है जब वो नए नए थेरेपी में आते हैं, बिकॉज मोस्ट ऑफ अस आर नॉट अट्यून्ड विद आवर बॉडी व्हेन वी स्टार्ट थेरेपी वर्क, ट्रॉमा थेरेपी वर्क. तो दे टेक देयर ओन टाइम. टाइट्रेशन, धीमे 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 करके वी डू इट. ओके प्रीति, आई कैन फील दैट पेशेंस इन माय चेस्ट. सिट विद दैट. नोटिस हाउ डज इट फील. ठीक है. आप चाहो तो और कर सकते हो. अगर सा कोई कलर, लाइक वी आर ट्राइंग टू स्ट्रेंथन इट मोर. ओके. आप जैसे when I was about to have this start my wo, you know what resource did I try to think about? Confidence. प्रीति याद कर कब तूने कॉन्फिडेंस में एक दिन एक लेक्चर डिलीवर किया था. आई वेंट बैक टू दैट टाइम एंड सडनली आई कुड फील दैट कॉन्फिडेंस विद मी and here I am. All right. So we can use resources like this, and resources, that patience was example of an internal resource. Resource can be an external one too. Pets. Okay. They can be your family. Again, family में बड़ा कई बार tricky हो जाता है, क्योंकि कोई कहते हैं अपना सपोर्ट ना मम्मी के संग बहुत लगता है, लेकिन पता चलता है मम्मी इज एन ऑब्जेक्ट ऑफ टेरर एज वेल एज, और कहते हैं ना वो लव हेट का ऑब्जेक्ट है. तो try not to use anything which can trigger, anything which is very neutral. ठीक है. That is why pets sometimes are the best resources. ठीक है. Any place that I had gone to, any view that I had seen in a TV, anything from my imagination, it can be a state too. Okay. Maybe sometimes people, like one of my clients say, Preeti, मेरे लिए मेरे ऑफिस में मेरा कॉर्नर का केबिन है, वहां पे वो ठंड के दिन थे जब हमने रिसोर्स बनाया था, वहां ठंड के टाइम पे धूप आ रही है, मैं अपना काम कर रही हूँ और मुझे कोई डिस्टर्ब करने वाला नहीं है. दैट इज माई सेफ काम प्लेस. Alright, so this can be anything. So what it does, it actually creates that buffer, because when trauma happens, वो शॉक में हम बहुत सारी चीजें भूल जाते हैं और बहुत सारी चीजें तो बिल्ट ही नहीं होती हैं, तो वो हमें बिल्ड भी करनी है, जैसे सेफ्टी. All right, ma'am, stand, ma'am. So let's do a small safe calm exercise. All right. So it used to be safe calm place. Now EMDR says it's safe calm state. State क्यों? क्योंकि वो कुछ भी हो सकता है, जरूरी नहीं उसके लिए कोई जगह की जरूरत हो हमें. Okay, so again, if you want, you can close your eyes. If you want, you can keep them open. Let's create a safe, calm place for you. Do you remember a place? Do you remember a state or any situation where you felt safe? Mentioning one more thing, सेफ्टी बहुत डरावनी होती है, तो ये सोच करके जाना कि क्लाइंट के लिए सेफ्टी ट्रिगरिंग ना हो जाए. देन calmness. All right, because sometimes safety sunte hi, one day what happened, I spoke to one of my, I just really, let's sit with the sensation with a lot of love. You know what happened? Jaisi love suna, she welled up. What happened? I don't deserve love. It can go to that extreme, so we have to be very particular about what we are using, how we are using, when to use, when not to use. Yeah.
So that time we should not use.
नहीं, not with this client, at least with this client. उसको वापस बुला के what happened, थोड़ा सा कि हुआ क्या इस वक्त, ताकि वो फिर से हम लोग वो अपना बिल्ड कर सके, और फिर मैं वहां पे उसे कैसे यूज करूं. लाइक अगेन, इट विल डिपेंड ऑन what happened earlier, like how I managed that situation once my like started weeping. So how I managed it depending on that, because आज तक मैं अब दोबारा लव नहीं यूज करती हूँ, जब तक मैं उसे बिल्ड नहीं करूंगी मैं नहीं यूज करने वाली हूँ. इवन विद सेफ्टी, शी वॉज अमेज्ड. प्रीति, आज तक मैंने जो एग्जाम्पल दिया, प्रीति, आई नेवर फेल्ट कि सेफ्टी क्या होता है, मुझे पता ही नहीं था. एंड देन टाइट्रेशन, धीमे 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 धीमे, नॉट लाइक अ फ्लड.
So can you give me like any other alternate example that, you know, instead of love, then what we could use?
Sometimes you can say kindness, compassion. Just sit with it with curiosity.
So basically, we are going to lead to love. Basically, that's what you're trying to say.
जरूरी नहीं, मतलब डिपेंड करता है कि हमारे क्लाइंट को जरूरत क्या है. Maybe that word was not at all required. I just used it because it was in the script. Maybe my client did not require it. Like जरूरत क्या है कि प्यार से देखो उसको, मत देखो प्यार से, क्यूरियोसिटी से देखो, कामनेस के साथ देखो.
Okay, thank
है
you.
ना. सो अगेन ये बहुत टेलर मेड हो जाता है, बिकॉज हमको नहीं, मतलब एक दिन व्हाट हैपेंड विथ मी, सो ये मतलब आई थिंक इसने मेरी शेम रिएक्शन को ऑन कर दिया था. लाइक आई हैड टू यूज अ लॉट ऑफ कंपैशन ऑन माय ओन सेल्फ. So this client came to me for the first time, and what we usually do, we keep on taking notes छोटा छोटा ना, और हम साथ में थोड़ा सा पैराफ्रेज करते रहते हैं. मुझे बहुत अच्छे से याद है कि उसने कॉम्प्लेक्शन शब्द बोला था, बट आई थिंक आई वॉज नॉट माइंडफुली प्रेजेंट. समटाइम्स वेरी इंपॉर्टेंट टू बी माइंडफुली प्रेजेंट टू, ऑलवेज इंपॉर्टेंट. ओके, सो हुआ क्या, जब मैं उसको पैराफ्रेज कर रही थी, उसने जो भी बोला मैंने कॉम्प्लेक्शन शब्द बोल दिया. As soon I use this word, Preeti, I don't think I use this word. I think I can't work with you anymore. You keep the money with you. I think it won't work with us. Imagine this word complexion. कितने छोटे छोटे शब्द ट्रिगर कर जाते हैं, पता ही नहीं चलता है. इसलिए कितना माइंडफुल होना पड़ता है at times.
So there was a client of dissociation, and she was a bit darker on her complexion, and her sister was very fair. So she was dissociating from past 5 to 6 years, and she could not get any reason for that. And I don't know how none of the therapists also could not get any reason for that. So I planned a psychodiagnostic for that. Maybe I would get something. So I think in the second or third session, she said that my mother doesn't like me because I'm not fair as like my sister. And that moment, then she realized, okay, that could also perhaps be a trigger that I am dissociating. And that was the reason. I think after 5 to 6 sessions, she was like fine. She was not dissociating after that. So that's how it works.
True, that's true. Sometimes things which we think are not कहते हैं ना, going to trigger, they can be the biggest trigger for them. We have to be very mindful. Like that day I realized, Preeti, be mindful. Agam, I wish I was mindful enough. I would have told her, because out of blue मैंने complexion नहीं बोला होगा, कहीं से तो आया होगा. But I wasn't mindful enough to tell her that yes, this was happening. Or I could have done something else. I don't know. But yes, it was shame provoking for me. All right. So shall we do this safe calm place? All right. Okay, so if you want, close your eyes. If you feel it's good to keep them open, it's all right. As you close your eyes, go within, as if you are more and more with your body, the body that you own. In this process, thoughts may come, thoughts may go, and it's all right. This is what happens. As and when you realize that you are going somewhere else, come back to the task, that is my safe calm place. Can you think of a time? Can you think of a place or situation which can be your safe calm place where you feel safe? And let's see what comes up. So normally I'll ask my client, what are you noticing? They'll tell me, all right, let's talk more about it. When you go to your safe calm place, what do you see? What do you hear? What do you smell? And what do you feel? Then I may ask, what are you noticing? They'll tell me, all right, let's notice what else comes up. Can you notice? What emotions are you noticing right now? And notice where in your body do you feel them. Stay with them for some time, for as long as you want to. So normally what I'll do, I'll try to make it as long as it can be so that I'm able to strengthen it more and more. And story doesn't end here. हमें बार बार कराना पड़ सकता है. ठीक है, जरूरी नहीं है कि आज हमने करा अरे बस सेफ काम बना दिया छोड़ो. अब हो सकता है 2 दिन के बाद दोबारा करना पड़े, because it for them it is required. For all of us it is required, but sometimes for them it is required more often, क्योंकि जब कल आप लोगों ने लेक्चर्स में सुना ही होगा, जब ट्रॉमेटिक मेमोरी आती है तो अगेन दो ब्रिज जो टूटता है हमारा थिंकिंग ब्रेन का और हमारे सर्वाइवल ब्रेन का या इमोशनल ब्रेन का, है ना. तो उसके लिए बहुत जरूरी है, लाइक इवन it's like the listening part of like the part of the brain which carries the memories, part of the brain which thinks, part of the brain which helps us to survive. इन सब में नॉर्मली कनेक्शन रहता है, लेकिन जब ये होता है कनेक्शन टूट जाता है. इसलिए हमको बहुत बार बार कोशिश करनी पड़ती है ताकि हम इसको यूज कर सकें. ओके, ऑलराइट, आई थिंक this is it from my side. Is there any question? So I do have, and I can like forward it to. I'll do one thing. I'll share it with Prerna ma'am or Sonia ma'am. And हाँ, please. Ma'am, references, ma'am. Yes.
I wanted to ask you, during the safe calm state, sometimes people would report, like for example, when you did this, sometimes people may feel sleepy. and they would say that, oh, you know what, this is so good, I can go off to sleep, I don't think we should do this. So what can be done to address that? Because is it okay to let them drift off to sleep?
So,
Or
what I realize, I think it's like it's again from my experience, not that I've read it somewhere, but I realized maybe I can use some other safe calm place. Maybe it is taking them to their, maybe again to their collapse wala state. It could be anything else. So, with a safe calm place, sometimes it becomes very important to ensure कि वो सही में उनका safe calm place है कि नहीं है. तो ये एक task हो जाता है. For yeah, that is true.
How do you differentiate between the client feeling so safe that they can actually go into rest mode versus the client actually going into the freeze mode, or sort of like dissociation spectrum?
All right. Gestures, face. Okay. And sometimes जब वो freeze में जाते हैं, freeze में होता क्या है? Freeze में it's like parasympathetic and sympathetic, they're acting together. Okay. So it's more like energy बन गई, अब क्या करें, जम गए. तो वो you'll be able to see. हो सकता है वो कहते हैं ना वो कहते हैं वो deer light वाला जो आंखें ऐसे हो जाता है. It may go like this. So it's very different. That calmness we'll be able to observe. And they will communicate. They communicate also. Because freeze is a very difficult sensation to hold. They do communicate when this happens. And sometimes they can dissociate. So there are few questions like, how much part of you is there in the session right now? 10%, 20%, 30%, 40%, 50%. We can ask this question. ठीक है? Sometimes मैंने जो स्टार्ट किया था, मैंने ना लेफ्ट नोज और राइट नोज का किया था. लेफ्ट नोज का मतलब है लॉस्ट, राइट नोज का मतलब है राइट हियर. सो इन I'll ask in between, right nose or left nose? Left nose. So yeah, this does happen. So it's like again your ways to inquire and bring them back in the session. Pardon? Yeah. Yes. Yes.
That's a key reminder,
Yes.
tell them that you can't fall asleep.
Yes.
You can't with me or in the using sentence may help, yeah, to be in
That's true. That's true.
the window of
Ma'am, window of tolerance. Window of tolerance. This
readers, but
आप अगर अपने उसमें गूगल में बस विंडो ऑफ टॉलरेंस डालेंगे ना और इमेजेस खोलेंगे, it will appear.
Ma'am, what happened with me, ma'am?
Hi.
Ma'am, when I was doing that safe calm exercise, I was imagining my room, but I was, also there was coming these images of that container where I had kept that all stressors and traumatic events. Why this happened?
That is why it's become very important to
Because it
make a
was-
very neutral safe place. जैसे ना एक बार मुझे बहुत सारे क्लाइंट्स ऐसे बोलते हैं, माई रूम इज माई सेफ प्लेस. तो एक दिन ना ऐसे मैंने मजे में पूछ लिया, ये ऐसा तो नहीं कि जंगल में बहुत ज्यादा जानवर घूम रहे हो और मैंने एक अपना कमरा ढूंढ लिया है उसके अंदर. Okay, so that is actually not my safe calm place. I went inside because I wanted to safeguard myself at that moment. It's a very neutral place जहाँ पे हम जैसे if I give example of my own safe calm place during my MPhil days, like the safe calm place that I created was 12 o'clock at night. We are coming back from like one hostel to my own hostel. और वो जो रात के तारे चमक रहे हैं, ठंडी ठंडी हवा है, दोस्तों के संग गप चल रहा है, that is my safe calm place. Okay, so it's like it's very neutral. इसका किसी से कोई कनेक्ट नहीं है, क्योंकि कई बार ये होता है हम सेफ काम प्लेस वही ढूंढ लेते हैं जहां पे हमारे स्ट्रेसर्स भी होते हैं, ट्रिगर्स भी होते हैं.
we do this exercise again.
जब तक कि हमें हमारा सेफ काम प्लेस ना मिले. Yes.
While dealing with patient having trauma, something which crop up while dealing when I was dealing with someone, the person was in New York and I was treating him for trauma. But they build a kind of trust. They think that we are the only one they can speak about it. What will happen that, when they're taking a drastic step and they think of calling us at that time, and
Okay, so
like he was driving very fast and he called me, I'm driving very fast. And I say, is somebody with you? He said, no, I'm driving. I just want to call you. So what could be done? Because I picked up the phone because it was not a normal call that person is giving. Maybe for something that he has called. So I picked him up, picked the call, and this what happened. So I actually didn't know what to do because I wanted to call his family, all the cops there, so that he could be stopped there. Otherwise, he would harm himself. So what could be done in that case?
all right. So I think first, because we have created a safety net, we have given them lot of options. Like we are at the end, but they may use us, and sometimes they may think us as the first option, even if the safety net has been created. Maybe again, because we have already picked up their call, we can ask them to like find a safe place for themselves where they can halt their car. Then we can speak to them. Maybe at that time we can help them in doing some grounding exercises. Okay, maybe we can help them कहते हैं ना, because that is handy, that survival kit is handy, maybe somewhere in their mobile phone. Okay, maybe we can help them go through it. But again, I think it will depend on person to person and how the situation arises. And at the same time, because safety net में हमेशा उनके known ones तो होते ही हैं और उनको फिर contact, it becomes important at times too. But right now, right at that moment, I think गाड़ी रोकते हैं. Let's come back to the present, because हुआ क्या, अगर trauma की language में बात करें, there was a part which came out which was feeling extremely hopeless, which felt it's the end or something, because of which it happened. It's not the person, it's the part of that person which is feeling hopeless or something, which is indulging in that. And once we do this grounding or whatever we are planning to do, then we will help them to come back to the present. And when we are in the present, we are our integrated forms.
Thank you, ma'am, for this enlightening session, for this metaphorical explanations and all those case vignettes you have presented. These are all very, very heart touching, I can say in that way. Thank you, ma'am. Thank you so much. Now, I would like to call my dearest colleague, Miss Sonia, ma'am. She has completed her MPhil and PhD from Amity University. She is an assistant professor and a senior faculty at IBHAS. She has been working with us for the last 15 years. Also, she is a RCI licensed clinical psychologist. She is a certified art-based therapist and a drama therapy practitioner. Ma'am, please welcome.
Thank you, Sneha, for that warm welcome. Good morning, everybody. I think after such an interesting lecture by Preeti, this is a topic which is a continuation only, which is going to be talking some bit of things that Preeti has already highlighted, and we're going to be taking it forward from there. So my topic is expressive art therapy for trauma survivors, right? I think since yesterday and today in the morning, we've been talking about, what trauma survivors are, who people with trauma are, what kind of symptomatology they come up with. Can I ask that what do you think what people with trauma need? That's my first question. What do you think they need? Safety.
right? We all have been talking about safety. They need safety. What does that safety mean? Calmness, okay. Reassurance, all right. Okay, what else? Acceptance, all right. Validation. Yes. Now, let's understand also that along with all of that, I think, the points are self explanatory. They also need boundaries because there is always a challenge with boundaries that come about. And a very important point what Preeti highlighted, modeling. Therefore, as therapists, we need to model calmness, we need to model acceptance, we also need to model boundaries. Next slide, please. What would that mean? That would mean predictability, predictability in session flow, also safe space, predictability of space as well. If possible, let's make it a little more predictable for them. Right? We think surprises might be interesting, but not in case of trauma. Surprises are not very interesting there. They would rather like predictability to start with. Continuity, safety, predictability. Also perspective. Perspective comes in two shapes here. Perspective of the client as well as perspective of the therapist. Right? If we are focusing from a perspective of a deficit model versus strength model, that brings about a chance there. Recalibration. Recalibration. Can anybody understand what recalibration is? Yes. Bringing them back to the state of safety because they move from that state of safety time and again to help them, realize that there is this safe space. They can always come back to it, which Preeti has been talking about. And in trauma-informed therapy, we are talking about stabilization again and again. So that stabilization is, let's come back to that space. And that space is available. Right now, it's not accessible because of my trauma response, but that space is available and I can come back to it. Right? Attribution, I think, I would think you all would agree with me that a lot of times, initially, a trauma patient always is asking for why. Reason. What was my fault? Reasoning. Attribution, reasoning. The mind is always questioning also. And that's why they want to share so much. That's why that sharing flow comes about because they are trying to make meaning of it themselves when they are sharing. Again and again, repeating almost similar themes, but sharing again and again because they are also trying to attribute various reasons for what happened, why did it happen. Because like we have agreed, we have yesterday understood, memory is so disfragmented that it is not accessible. Clear information is not accessible to me. So I'm also trying to make meaning of it. Support, reciprocity, as well as control and choice. And when we say reciprocity, here comes about a lot of trauma clients sometimes may want to put the accountability of their decisions onto you. Does that happen to anybody? Where patients want to put the accountability of their decisions or what they should be doing, what should they do onto us? Yes, I can see some nods there, right? But we need to take this, a step back here. Control and choice always is, we need to bring that back to them in smaller, very minute ways also. As simple as where would you like to sit in the room? As simple as that, also giving them choices, giving them control. Next slide, please. So why art therapy and what is trauma-informed expressive art therapy? The quotes that I've written is that art is not always about pretty things. We think that Art should be aesthetically pleasing, it should be about pretty things, but it is not. It is also about things that we experience, things that we don't have words to express, and that comes out in an art form. So, trauma informed expressive art therapy is a model that is basically based on arts based approaches and has taken the current practices of trauma informed care. Right. So, it is using different forms of arts. There can be different forms of art, and most common used is visual art. Visual art is your painting, drawing, but there are also other forms of art that can be used, including music, writing, play, santry, and this is all done in a context of psychotherapy model. Right? And we are using it for promotion of psychological, physical, and spiritual well-being. Next slide, please. So these are different forms of art modalities that can be used. Visual art being the most common. Most people kind of stick to visual arts, but there are other art forms also. Now, one of the question comes in, I'm not good at art. As a therapist, you all may have that question. As clients, our clients have that question. But like I said, art is not about pretty things. Let's put the judgment aside. Art is about engaging and involving oneself with creative mediums. And if we can do that, we are helping them create something new. I'll come to that part also. Next slide, please. So what are the components of trauma-informed arts-based therapy? The first is obviously using a bottom-up approach. So what has been talked about yesterday and today morning also is that the prefrontal cortex is not working, but what is working? Amygdala, right? And Preeti talked about reptile brain, right? So the body is feeling, but the mind is not able to make sense of it. That's why body keeps scores, because body is feeling it. Body is feeling the feeling, but the mind is not able to make sense of that feeling. The prefrontal cortex is not able to feel what is happening or judge what is happening, problem solve. So the first thing that is there is that in expressive arts therapy, we are using a lot of body-based work. There is also that identification of what does body feel when it's stressed. Where does it feel the stress? Which part of the body does it feel the stress also? Responding to body's reaction to traumatic events through somatic and sensory approaches. We'll talk about somatic and sensory approaches also a little, and I have some examples as well to share with you all. And then we reinforce that sense of safety through recognition that positive attachment and self-soothing can take place. As well as arts-based therapy, expressive arts-based therapy is focusing on strengthening the resilience. Next slide, please. So like we said, we are working through the continuum of senses using the bottom-up approach. So therefore, somatosensory is what we are working with first, before even working with emotions and cognitions. Right? So sounds, gestures, movements, image making, writing, storytelling, all can be used as somatosensory approaches. This is a very, one of my favorite sayings from Carl Jung, that often hands will solve a mystery that the intellect has struggled in the vain. So something that we do with our hands help us much more. And some research evidence that, how arts-based therapies are being helpful. So refugee researchers are there where drama was used with adolescents in classroom, which showed that, it lowers level of impairment by trauma symptoms and higher levels of social inclusion that came about. With music, adolescents from North Korea, there's a lot of Indian studies also, but unfortunately, we don't have much documented. Right? With sexual violence, there are different studies that were used with different modalities, poetry, dance, art, and drama, and all of them found that they help in self-regulation,
They allow the individual to, have positive coping with the shame that has been talking about. Because what we are doing is we are also distancing. Instead of what is happening here, we are putting it out there also to be an observer of what is happening within. So, along with sexual violence, there is also for incarcerated women. Next slide, please. Incarcerated population, where again it kind of empowered women in their own diversity, helped women have longer term views, no longer bounded by the prison stigma that they had. So, this is a recent research with PTSD and art therapy that was done, and in that out of 6 studies that they reported, 4 studies had significant decrease in PTSD symptom severity. Additional impact was reported that art therapy allows people to verbalize their thoughts and improve social relationships. It also has been found effective in dissociation because it allows for people to come back, calm down, be there, be present, instead of dissociating to somewhere else. Next slide, please. So the conclusion of these systematic reviews was that art therapy have positive impact on treatment, definitely, of dissociation and eliciting positive emotions. I think we've been talking about negative emotions and how negative emotions is what is experienced more, but positive affectivity is what we also need to focus upon. Rather, so far our literature has focused on how increase in negative affectivity is where the pathology is. But we also need to know that decrease in positive affectivity is where we need to inculcate more work also. Next slide, please. So, what is the conclusion of art therapy based research that we find is that it is a good technique, but it also is an adjunct technique. It doesn't directly work with symptoms. It rather works with the effect of or the impact of symptoms. So therefore, it's best when it is combined, especially in child sexual abuses, it is best when it is combined with other therapy modalities. Next slide, please. Now, arts-based interviews have been found to be very effective, especially when working with children with sexual abuse. How drawings can, give us some suggestions and help the child speak about or verbalize what they initially are not able to verbalize. The 3-step process is that the first step involves projective drawing or a storytelling around that projective drawing to build rapport. This leads on to discussion of trauma, what may be there, as well as followed by discussion of what is left now. Where is the child now also? All the 3 steps incorporate drawing. Next step, caution. Okay. We may use this, but we may use it not as an investigative tool, but rather an exploratory tool to explore more rather than coming to conclusion of whether it was there, whether it wasn't there. We're not coming from a place of mistrust. I think we've been talking about it. We need to come from a place of trust as therapists and believe what is being said. Yesterday, there was also an important discussion that everything feels like trauma to everybody. Yes, there was that discussion. There's a saying, no sane person wants to prove themselves as insane. Okay, so if anybody is trying to do that, there is something that they are finding in inability to cope with something. Right? Maybe not trauma, but definitely they are having an escape mechanism. There is something that they are trying to escape with. There is something that they are unable to cope with. We may not label it as trauma, but we do need to help them. Again, maybe with boundaries, with different approaches, but that help should come around rather than saying that, "Arey, isko to sab kuch trauma lagta hai." Let's not invalidate it because we don't know what may be there, right? So arts-based assessments are suggestive, not diagnostic. Let's be cautious of labels, as well as research is not conclusive on it. But it has been found that these certain signs that I'm going to be talking about in drawings are seen, and I think we must have done this during our training also. I'm just repeating some of it. Can we go ahead, please? So the projective literature on human figure drawing has been found to be one drawing modality that does give us some indications. Again, not diagnostic, but suggestive. Please go ahead. So sexualized figures. Next slide. Encapsulation, you will find this, and I have found this personally in my work with children, that children with abuse tend to draw encapsulated figures much more than other children, because there is a sense of safety that they are trying to build and project upon, that they are building this, within their drawing, they're building safety also. Next slide. Hiding themselves, hiding figures in some way. Again, a safety building approach that may be there. Regression. Yesterday, Sujata ma'am also discussed and showed us certain pictures of regression that was there. So geometrical figures or stick figures tend to come about even for adults. Only head rather than the whole figure. There's only a certain, they feel this fragmented, so only a part is projected upon. Next. Kinetic family drawing has also certain signs that kind of come about, including family size, presence and absence of family members that may be there, size of figures, placements, distance between figures that may be there, the facing directions and the orientations, nurturance activity that has been showed, fighting activities or nurturing activities, and the barriers between people as well, please. So in kinetic family drawing, next slide, please. Certain signs that are there is one, compartmentalization. Second, ma'am, please, can you just go on one by one? Edging. Edging is where drawing on near the paper to kind of again take support. The drawing is taking support of the edge itself. Next. Encapsulation we talked about. Next, please. Folded compartmentalizations, where the sheet is folded, or full compartmentalization is not there, but part compartmentalization is there. Next slide. Lining on the bottom. Next slide. Lining on the top, that may be there. Again, these are all, if one looks at from a projective lens, they are ways of supporting the figure that they are drawing. Next slide. Underlining individual figures. Next slide. Bird eye view, where the eating lunch and the bird eye view is taken up for drawing. Next slide, please. There are other arts-based assessments also that are there. There is one which is called as 6PSM, which is 6P story making, where we ask the client to make story on based of six instructions. You can Google it; it is available. You can find that. Stories, narratives, but what is the theme that has been found in these story making assessments is that there'll be aggressive themes, oppressed themes, dominating, inconsistency. The stories are started, but there is inconsistency, there is not continuity, and defragmented. They're not very well formed, continuity is present. So now I'll be talking about why arts therapy, why is art therapeutic for trauma. So what we talked about, that there is a sensory feeling that is present, but not cognition, which is very well developed. And what art does is it's also working with sensory modalities. It is working with sensory modalities, therefore it is helping access the limbic system much more. It is also helping regulate the limbic system. Art therapies target basically the anxiety response and help us calm those responses. Again, these results provide evidence, but we need further results on this. Please go ahead. The first research that is there, that is also written in Body Keeps Scores, where we need to understand that, during trauma, the right hemisphere has heightened response, and the left hemisphere, which is basically language, becomes inactive. So if we emphasize on words, it tends to limit our clients also. Therefore, if we can work with the right hemisphere, that's the premise on which our therapy is based, that if we work with the right hemisphere, the creative space, where there are chances that we will have more access to the right hemisphere also by connecting them. Next slide, please. Next slide, please. Yeah, this is the most recent research that is there, creative arts therapy in work with children and adolescents with traumatic experience. And it was found that, again, arts therapy tends to help traumatic experience in safe way, give them skills to talk about it, and also build skills, skill building that we were talking about, despite their traumatic experience. Next slide, please. Now I'm sharing some useful examples. I think Preeti did the calm, safe space. We can also do it via art modality. Like we start with what Preeti did, where we are asking them to imagine a safe space, right? I have done this with a lot of adolescents, and it has been found to be effective, where we can also do it as a collage making. Sometimes, like Preeti said, how many of you had this difficulty, if you had it, where when Preeti said safe space, nothing was coming. Nothing came. Yeah, some of us and some of our clients also, when we talk about safe space, when we talk about safety, nothing comes because they have not experienced it. They don't know it. Right? And they may feel, again, shamed for not even able to imagine that, what they want, because they want safety. Na? So it may be very shaming experience also for some of them. In those cases, what I found is that collage making with old magazines, newspapers, you have words, you have images. Yes, there may be some triggering things that may be there, but they are getting triggered anyways, no? So can I, in my safe environment of that therapeutic space, also bring about things and understand what was triggering, and also help them change and modulate that. So a collage making of safe world has been found to be effective, where these are, again, paint drawings from real drawings from my clients, and I've taken permission to share these. Next, please. Art as a transitional object, it has been found to be really effective with especially young children. I think most of us would know what transitional objects are. Winnicott's theory. I'd like to share a case here that, one of the child with traumatic experience was there, and, he drew like a small rat again and again. And there was like a sense of pleasure that he had with that rat, small drawing. And what we thought was like, if we kind of give him a small rat like toy, which comes in very, compact manner, and if we can carry that with him as an experiment. And it was found that he would have tremendous anxiety response earlier, but when he was carrying it in his pocket, his anxiety response is reduced. There was a positive feedback that we got from the parents also. So that's just one example of using, we sometimes need to use creative ways to find what will work with our clients, and especially when we are working with younger children and adolescents. Next slide, please. So this is another activity that was there, which is like a self-care box that within adolescent one can build up, which is like, one big shoe box, and then you have these match boxes, and they can work around different feelings. to identify as well as have coping cards for that particular feeling on that particular day. Right? And you can help them build this up as well. Next slide, please. This has been found to be another activity which is very effective, but a caution here, if you're not trained art space therapist, kindly be a little more cautious if you ever happen to use it. This is a body map activity, which is not done in the initial phase of therapy, but primarily when there is enough trust and emotional safety established with the client. Especially those clients that are, that have difficulty with their bodies in some way. This activity tends to help them, where we make like a full body map, and that map is done either by collage making or painting, just as an example that one can see over here. And then there is obviously, before that, there is full body awareness that is built up to create this experience more in depth and in along with that. Then there is also destroying of the creation, but by the client, not by the therapist, ever. We never destroy artwork of our clients. Only our clients can destroy it. So that is something that is always to be maintained. And then recreation of a newer, safer, calmer, positive, again, using their words, what kind of body would they like? Right? Like I said, a caution here, because this activity can be very, very emotionally overwhelming also. So a lot of emotional safety is done before using this as an art activity with the clients. Next, please. And this is not, sorry, just go back. And not to be used with people who have tendencies of self-harm. Okay, because we need to kind of work on self-harm tendencies first. And if there has been like a long time that we've been able to work with it, then we work on the body map activities. Next slide, please. Then you have Tree of Life activity, which was also shared in a similar way, Tree of Sustenance that ma'am shared yesterday. So Tree of Life activity is borrowed from narrative therapy exercise, which helps them build on their resources, which helps them stabilize as well as find different resources that can be used by them and in a period of distress that may be there. It also helps them give a more broader view of themselves. Rather than just looking at themselves from a deficit model, it also helps them look at themselves from a more holistic perspective. Next, please. Messy art making, and it has been found to be really effective also, because sometimes they just feel so much, but they don't have a place to take it out, which may come in their disruptive behaviors. Rather than in disruptive behaviors, if in that 45 minutes, they make that messy, disruptive art and then clean it also later. It's not that we're just making disruptive art, but a lot of releasing of their anxiety symptoms also takes place with messy art making. Next, please. And then you have controlled art making also. And this is like, one of my favorite and easy low resource activity, because you get paper plates. And within that paper plate, it's a circle. It allows them to control and develop control over the material, which is also a symbolic way of developing control that they are trying to struggle with also. It tends to as well help where, a controlled art activity comes about. Next slide, please. So what Preeti talked about, window of tolerance, we plan the activity based on that day of the client, how the client is. If there is hyperarousal, then we'll do something more calming and bringing them back to that recalibrated space. If the client is hypo, we will do something more energizing that kind of brings them a little more at a, again, window of tolerance, recalibrated. Next, please. So what are the 4 functions that we are achieving by doing all of this? Is self-regulation, because we are allowing the client to regulate. In art making, there's a lot of, what goes next, which one should I use, how much should I use, There's a lot of self-regulation that is incorporated within art making process. If you've worked with paints especially, you will have that, how much, how, and that kind of helps in a way of decision making, control, that kind of comes around for them. Co-regulation also with the therapist, and if you're working in a group, then co-regulation with other participants of the group that comes about. Exploration and restoration. So the benefits that we are actually looking at are at 3 levels. One, we are working with the sensory and kinesthetic primarily. That is the first level at which we are working. So we are working with the nervous system and brainstem to calm the process. Then comes emotions, because there is something that is getting created. You will find a lot of times either they will have like a little disgust with that creation, or they will be very joyous with the creation also. And then whatever is coming up as symbolic, can we talk about it? Can we work around it? Can we play around it? So there is a symbolic and cognitive level that comes around. So in nutshell, the expressive art therapy continuum is trying to build an inner balance, right? I'd just like to do one little activity before I end my session. Can you all think of what would inner balance mean for you, like as a metaphor? Inner balance is like anybody? Inner balance is like for me, inner balance is like balance between soul, mind, heart, body. So can you also put it in an image? Let's say, for example, what would that mean? Okay. Okay. So for her, it would be sitting in a calm position and there's a light that is falling on you. All right. One more or two more, please. Yes. Lens of emotions. Okay. All right. A sunrise. All right. Okay. More metaphors. Metaphors are coming now. And I work with metaphors. A boat. Yeah. All right. A boat, and where, if possible, like in, like a calm, relaxed boat, or what kind of boat? A lake. A boat in a lake. All right. Rainbow and clouds. All right. A rocking chair. All right. Okay. So now, can we take 1 minute, because many of you probably will not be able to come up with it right away also. I understand that. But those of you who are able to come up with something, just close your eyes and think of, again, what would inner balance mean to me? Inner balance is like and whatever that metaphor comes in, like for somebody it was rainbow, somebody it was sun rays, a boat in a lake, or a rocking chair. And can you put that into your body or hands in some way? Please. All right, whatever it is, can you embody it in your body or your hands in some way? If you can, in any way. Yeah, all right. Okay, for you it was a seesaw. All right. Yeah, so a little bit of. Okay. Anyone else? So, like I'll just ask you to write this down and maybe do it later. Okay, can you put the slide on, please? Because this will become your personal healing signature. And we do this with the clients. And, when they do it for even a minute and a half, can I ask those of you who did it or who found it, can you just do it for a minute? Like 30 seconds, if you can, just embody that, whatever it was for you, in whatever way it was. Yeah. All right. Yes, those of you who did it, if they can just share, and that's where I'll just send.
Ma'am, what about clients having, or like me personally, have a thought of cravings?
Hmm.
Like inner balance for me is I'm going to be straightforward chola bhatura plate.
Right. Okay.
So
So
what's to do with that?
right. In here, let's say for example, if you were my client and that was something that you brought about, can we imagine a plate of chola bhatura in front of
No,
us?
that was the first thought
Ah,
came.
Absolutely. So can we imagine a plate of chola bhatura in front of us, and how does that feel? What would that plate look like? You know, it's all about just connecting with your own self for that little moment. Whatever it may be, it may change over time also. We do this exercise over time as well. But that may be something that you enjoy and that kind of grounds you for a while. It may be like, again, not really taking real chola bhatura every time. That would not be really healthy. But, imagining the feeling that comes. See, let's understand whatever it was, it is associated with a feeling that kind of gave you safety, that calms you down. So it's a feeling that is important for you. And it's not the chola bhatura, but the feeling that is important. And if we can tap onto that, we have
Feeling of
grounded you.
satisfaction.
Yeah, we have grounded you there. Right?
Thank you so much.
Thank you, everybody. There are questions, and I'm happy to take them. Yes, one or two. I think.
Yeah, ma'am. So when you said that inner balance is like, so I imagine it was a tree.
Yeah.
Then you asked that okay, now you can embody it in anywhere in the body, and I thought it was in my heart.
Fair.
But when I actually thought about it, I couldn't get the tree to sit in my heart or in my hand.
Fair.
So
It takes time. Again, let's understand this is like, what? I am just did it in 5 to 7, not even that much minute. I would allow you to take some more time on it, work with it. Maybe we'll draw a tree. Then maybe we'll come to embodiment also.
So, but at that time, we should not change that.
Ideally, no, we will like to sit with one idea that is there. Again, we are working on consistency. So we'll like that was something that was instantaneous.
Yeah.
So it had some relevance to you, some feelings that kind of come around. We'll work around that. Then.
Or thank you.
One question. I don't know how relevant or not so relevant.
All
it is.
relevant questions.
Since we are trying to understand trauma-informed care in a lens of recent practices, our entire mode of therapy has changed recently post-pandemic. It has become online also.
Yeah, right.
So, because expressive arts, therapeutic approaches are very friendly when it's in person, right? You get to do it in person. You get to sit with the person and make them engage with a lot of materials. How can we do the same? Maybe some examples of some other activities that can be employed on an online mode.
See, similar activities can be done online also. The one thing that will be important in an online session would become is, again, boundary setting, trust with the client, creation of space. So here in my therapy room, creation of space is my responsibility. Right. At home, creation of space becomes client's responsibility. So we will kind of put certain guidelines out for the client that what kind of a space will be helpful for them.
Okay.
Which material should they keep with themselves? Because material is also something that we use again. And we'll try and see again, we can scale it to a expensive, we can scale it to low modality. Rather, because of shortage of time, I couldn't add certain pictures and add certain other exercises which are very low resource. So you have like, toys and toys. You have also rocks that are available on the road. There are feathers available on the road. There are leaves that are fallen. There are natural material resources that are there. Can we use that and incorporate that? A creative therapist would.
Okay. Okay. Is there anything that we need to keep in mind as not to do or not to like?
Again, two things that will come about. One, judgment around artwork.
Hmm.
We need to really reserve our judgment around artwork because it is their creation. And we rather need to be more as an observer, as a witness to what they are making as well. We can also make art together, which is also a co-regulating
Co-regulation.
activity that comes around, that is there. One is judgment, definitely. The second is, like I said, certain activities we will not do initially, right? Especially the body map or going deeper into more deeper into emotions, we will not do initially before we established a good, safe, rapport based space between us and our clients.
Okay, thank you, ma'am. Thank you
You're
so
welcome.
much.
Ma'am, to telling us that it is helpful, but it is not helpful alone. We need other treatments for, again, different. An eclectic approach, a CBT based, arts based therapy approach will be more effective.
Yeah. So is it like all the bottom up approaches are to be combined with top down approaches so that the link can happen?
So, see, initially, I would recommend starting with the bottom up approach, working with the body initially, because that is where we are working mostly, and then bringing about the top down approaches after maybe in the middle sessions, middle therapy sessions.
So to ensure stabilization.
Yes, absolutely.
And second question is there any course which we can do to get trained in expressive arts?
I think there are a lot of courses that are available in India as well and otherwise also. I don't have specific recommendation. The course that I did was from Pune, and that has been helpful for me along with my other training. So it's not just the course, but your other training also is equally important. That kind of works around here. Yeah.
Thank you, ma'am.
You're welcome. There's one more question, and we'll take that as the last question because we need to break for the tea also. And ma'am is here. We would like to listen to her, eagerly waiting to listen to her.
Hello, ma'am. Actually, I joined the session in between, so I don't know whether you have discussed this before or not. But in this activity, like metaphor, so when you asked that, can you put up the metaphor into an action, right? So when I tried doing that, I could fit it into my body, but while maintain, it has actually created some anxiety right now.
Yes,
right?
it may be.
So how do we go about it? Because
again, you know, what was like, what did it feel? Because two reasons: we are not very well connected with our body, right? Second, there are others in sitting over here. We feel judged in some ways also. That kind of comes around. अरे वो देख रहा है या कौन देखेगा, ये तो थोड़ा silly सा है. So we need to lose that judgment also to kind of bring that. And in session or with one-on-one work, it works a little better. Definitely, I understand that may be there.
So in sessions also you have seen that
yes, it does.
Get anxious.
Yeah, because we have judgments for our own selves.
Because I believe like when you just said judgment, so it just lit up my mind that it might not be judgment about how silly it is, but it might be judgment about how well other people can balance it, and I am not able to do that.
Yeah. And we have judgments, and our clients have far more judgments about them. And that is what we are trying to, one, get access to, and second, help them. It's okay. Others might be doing it, you're doing it really well. And this is like unconditional regard that kind of comes around over there, that this is good and this is well. Let's do it.
Thank you so much.
All right. Thank you, everybody.
Thank you, ma'am, for this session. Now we'll be going for the tea. We will be coming back in 15-20 minutes. Okay? 15 minutes.
Good afternoon. Please settle down. We are about to begin with our next session. Sonia? Please take your respective seats. Please settle down. We are about to start our session. A very good afternoon. It is my pleasure and great honor to introduce Professor Dr. Vibha Sharma ma'am. Ma'am is a professor of clinical psychology at Institute of Human Behavior and Allied Sciences, Delhi. She has been associated with the field of clinical psychology for more than 25 years now. Her major achievements include 5 awards from various associations, more than 90 publications in various national as well as international journals, chapters, and she has also edited a book titled Clinical Neuropsychology. She has always been an invited resource person to various seminars, case conferences, and has presented various papers in national and international conferences. She is member of 15 scientific bodies and member of editorial board in 3 national journals. She has already supervised more than 5 PhDs and 70 MPhil dissertations and has also been a co-supervisor for MD and DM thesis. Her special area of interest are neuropsychology, women and mental health, adolescent and adult mental health problems, and positive psychology. So I would request Dr. Rushi to please welcome ma'am with a sapling. Waiting to hear a round of applause. Please, ma'am. So, ma'am will be talking about trauma-focused hypnotherapy with us. Thank you, ma'am.
Good noon, everyone. So, I think we are a little behind the schedule. No worries. The topic I think is quite interesting, maybe for you. Hypnosis and hypnotherapy are the topics which are generally thought as something mysterious, and everyone who's studying psychology would at some point of time, I think, keeps being interested in hypnotherapy or to learn that or to practice that. Same was with me. Being a huge fan of Freud, I always thought of learning hypnotherapy, and in the due course after finishing my MPhil, I learned hypnotherapy and past life regression therapy. But when I started practicing it, it was not that kind of core hypnosis, rather taking it as in the form of therapy. Most of the times adjunct to other therapies, sometimes core hypnotherapy, sometimes with past life regression, sometimes with other purposes, or depending on the purpose. So while we are talking about trauma, it is generally trauma is a point where hypnotherapy is very, very useful. We know about so many therapies. Dr. Sonia was talking about art-based therapies. I heard very good therapies for trauma, for ventilation of emotions and other traumatic experiences. Similarly, hypnotherapy can directly help in relieving trauma, and sometimes through reframing the trauma, sometimes reliving the memories and experiences depending on the case. So my approach in start, I would say, though I learned here in India, but when I practice and I use hypnotherapy, especially in trauma related cases, is more of kind of Ericksonian approach, if you are aware of. So we would talk about it. So I know since yesterday you are listening about trauma, but just to start, I think the background is very dark. Are you able to read? I don't know. Can you? That's what, maybe I don't know whether it would change or not right now. I don't know. From here I can see, but is it visible from back? The slides are visible? Last lines probably. Okay, don't worry. We'll go. Okay, so sorry for that. It's not possible to change the design right now. So we know what trauma is when it is very stressful situation, distressing, frightening. It is trauma, and trauma is generally an emotional response. It's generally not the event that is important. It is your subjective emotional experience and response to that event which becomes traumatic. So when we talk about treatment, we have to think about that emotional response rather than the event. One event may be traumatic to one person, not to other. And sometimes when the trauma actually happens, it is not traumatic for the person. The memory of that event may become traumatic in due course of time. So it can be like emotional, psychological, or maybe caused by any type of situations, maybe disasters, maybe accident, maybe some kind of emotional trauma, loss of some loved one. Any event can be traumatic depending on your person's own subjective experience. And trauma, it's not that trauma is only related to childhood. Trauma can happen to any age, to any gender person, or from any background. It's not that it is more prevalent into lower socioeconomic status or persons with high education or low education. It is nothing to do with all these kind of variables. Any human being, any one of us can undergo some or other traumatic experiences. And I think all of us at some point of time in life goes through some or other traumatic experiences. But every trauma is not a difficult trauma. That also we know. Every one of us have faced this situation, losing a loved one, or separation from a loved one, or losing some loved object, person, or different kind of experiences. But depending on my own emotions attached to it, my own cognitive and emotional state at that point of time when the event happened, my own developmental stage in life, how I was able to understand the situation, how I was able to cognitively process that situation or event, how I am memorizing that event. that all is related with the traumatic experience. So we know the three main categories of trauma: acute, chronic, and complex. So why I have written it here is hypnotherapy can work with all three types of trauma. And I would give some examples also in between. Using hypnotherapy with acute traumas, with chronic trauma, and of course with complex trauma, because the studies mainly say it is very useful with complex trauma, but it's not. It can be used even with the acute trauma. And we know that most of the researches you would find are on PTSD. So trauma converting into post-traumatic stress disorder and then using hypnotherapy. But it's not that always PTSD. There might be some other manifestations of traumatic situations in life, and hypnotherapy can be helpful in that also. So we know you must have listening from yesterday about reactions of trauma. I'm just again reciting these, how to deal with these in the hypnotherapy. That's why I'm listing it again. Avoidance experiences unpredictable emotions, sometimes getting very cheerful or like mood fluctuations, flashbacks, hypervigilance that we know are the symptoms of PTSD. Relationships are, I think, the most important area in life which gets affected by trauma. So generally when we deal with PTSD, we work with flashbacks, we work with the kind of memories, EMDR, other things, but generally we don't work on relationships in other kind of therapies. But relationships are the much affected area after a traumatic event, because the perspective, sometimes the trust is disturbed in your life, like your sense of trust, your sense of having a good relationship, that trust is lost, then all the relationships get affected. So hypnotherapy can help in getting back that kind of trust and that kind of self-confidence in making the good relationships in future. Rest is like mood swings, irritability, ongoing feelings of anxiety, fear, guilt, feeling disconnected, numb, hopeless, or withdrawn, even sometimes losing total sensory or motor loss after the trauma. Just psychogenic trauma or psychogenic, what we call functional disorders, having motor problems or sensory problems, losing, for example, not able to walk, not able to see, not able to use hands. So this kind of reactions are also seen. These are very common. We know feeling nauseous, headaches, disturbances in sleep, aches and pains are very common, heartbeat, startled. So as I was saying, PTSD is not the only disorder or only psychological manifestation which we see in clinical situations. As we all are aware, most of us sit in clinics and do our clinical work. We see acute stress reactions. After that, generally it comes in the form of adjustment reactions or adjustment problems. If it is a long term, it may also convert, or acute trauma also can convert in PTSD. It may be some types of phobias, anxieties, and one of the most common forms are dissociative and conversion disorder, which are not, because PTSD has been researched much more related to trauma. But if you see in your clinics, patients with conversion and dissociative disorders, trauma is, in most of the cases, trauma is one of the reasons behind dissociation, having dissociative experiences of any kind, not only like multiple personality or other, but maybe even simple headaches, even conversion symptoms, having somatoform disorder kind of thing. So conversion and dissociation is also highly linked with traumatic experiences, and hypnotherapy works wonders with such patients, because what happens with other medicines and therapy, that symptoms get changed. Sometimes what happens, if a person is coming with some particular pains and aches and we give some therapy, and the person doesn't learn actually how to solve the problems of the life, coping is not good, or not able to deal even with medicines, fear, anxiety, depression can go for some time. But if the problem persists, it comes again, then symptoms also come again in some other form, maybe some other form of conversion or dissociation. So hypnotherapy can prove one of the very effective method of dealing with any traumatic events related with this dissociation. And this kind of associations are going on through since the time of Freud, the psychodynamic and psychoanalytic orientations, and after that. So we all know that what causes trauma, it is maybe the feeling of abandonment, feeling ashamed, frightened, humiliated, feeling powerless, invalidated. So the kind of feelings we get, feeling threatened, powerless, trapped, under threat, unsafe, unsupported. So it may be like trauma may be accident, a road accident. Trauma may be a disaster. Trauma may be a sexual abuse. Trauma may be neglect. But the kind of feelings generally are felt powerlessness, feeling humiliated. So attached feelings are very important, having those kind of identifying those subjective emotional experiences and feeling before dealing with any kind of trauma. Because as I say, and as you all know, that trauma situation is not important, whether someone has gone through a sexual abuse or through a loss of someone. The thing is how that person has perceived it, kept in his or her memory. So, and this may be like one event or maybe ongoing kind of events, and or living constantly in a traumatic atmosphere. For example, living in a home with continuous domestic violence, it may be a traumatic experience, ongoing traumatic experience. Living with someone who is like toxic, in a toxic relationship, any other kind of living in a very stressful, traumatic environment, maybe workplace, or maybe any other situation in life, which may be where trauma may be ongoing kind of trauma. Or even sometimes a person doesn't experience trauma directly. Someone close has experienced a trauma and it may be like secondary experiences. I have witnessed an accident and it may become traumatic for me. Though I have not undergone an accident, but I have witnessed an accident. Or I know that someone close to me has been in a disaster situation or has been in a traumatic home situation where relationships are very traumatic or situation or events are very traumatic. So even being the secondary person who is experiencing may also give you traumatic experiences, just understanding others, empathizing others, or those who are close one to you. So we know it can stem from childhood experiences, which could include physical, psychological, emotional, or sexual abuse or neglect. And other, as I already talked about, abuse, medical trauma, terrorism. Nowadays, terrorism is also a big trauma. Grief. What we commonly see in Delhi NCR, a road rage. Just that can be traumatic. Coming daily into traffic is also a traumatic experience. So, but the degree is different and how you resolve that situation. But even such small incident of getting stuck into traffic may be traumatic if you have to reach somewhere in time, and starting from there, witnessing a road rage or being a part of road rage or any other experience can be severely traumatic. So we know that there are many options. You are hearing since yesterday different type of treatment options, psychological treatments, especially art-based therapies, body-focused therapies, cognitive analytical therapy, trauma-informed CBT, EMDR, schema therapy, mindfulness-based interventions, positive interventions. Generally, all the psychological interventions has some input in trauma-related experiences or traumatic events and situations. Then how hypnotherapy is different from others. And hypnotherapy can be used with any other therapy also. It's not that only hypnotherapy can be used. Hypnotherapy can be adjunct. As we were talking about art therapies in last session, art therapies can be used as adjunct to other therapies and medicines. Similarly, hypnotherapy can be used as an adjunct to other therapies, for example, with CBT or with any other behavior therapies or other therapies, as well as with, of course, with medicines. So it can be used as adjunct. Sometimes in like acute trauma, only a few sessions, 2 or 3 sessions, just resolve the trauma and this symptoms. At least symptoms are relieved, and then the underlying trauma. And why it is used as adjunct therapy, or why there is a need of joining other therapies with hypnotherapy, is that sometimes that acute reaction is resolved, but for future, the person has to learn how to deal with such problems in future, or how to deal with those memories. Or sometimes it is the faulty memory, it may be the faulty perception of that particular event which is making it traumatic. So dealing with those kind of things, as I said, making them learn different coping skills, and how it becomes helpful even with hypnotherapy. Because when you are doing any form of therapy in a trance state or in a hypnotic state, every hypnosis doesn't need going up to a trance state. It is a stage of high suggestibility. Your other therapies also work better. For example, CBT. If you are doing CBT in a conscious state, it has a different effect than if you are doing it with hypnotherapy or in a high suggestibility state, because there the effect is increased. Try this. So we know it is trauma is a universal experience, and hypnotherapy, a state of deep relaxation and focused concentration, and it helps. It is a kind of mind body treatment for trauma. And your intense level of concentration and focus, how it works, it generally allows not to get distracted through other distractions, and a person is open for guided suggestions. So how it increases its effectiveness in comparison to other therapies is because while you are doing any other talk therapies, there may be other distractions, but while in hypnotherapy, person has full concentration, there are no other distractions, person is not in that high conscious stage, person is in somewhere in subconscious stage, and high suggestibility is there. So instructions given at that point of time. Now, for example, for anxiety, now you are not feeling that anxious, your heart rate is going down. Even these kind of suggestions help the person to act. So your mind is under high suggestibility state and following the instructions of the therapist. So even doing relaxation exercise and leading towards a stage of high suggestibility and giving suggestions. For example, while we are talking about relationships, so through hypnotherapy, if you know how a person is feeling in a particular relationship and what can be the probable solutions, we can ask how you are looking for the solutions, what can be the probable solutions. And the solutions also come from the mind of the person. So you are also encouraging the person to dig into their subconscious and unconscious, finding their own problems and finding their own solutions. So it is guiding the person to look into one's own mind, one's own subconscious. That's how it works. So it can be used with all the disorders or reactions we were talking about: acute stress, PTSD, dissociative convergent disorders, chronic pain. It is very helpful. In different addictions also it is helpful because suggestions help there. Giving active suggestions during hypnotherapy, it's helpful in different addictions also. Depression, anxiety, we know it works. Sleep disorders, relationship and behavioral issues, as I was saying. Because you may not find many researches directly on relationship issues and behavioral problems, but it works because, as I said, person is able to explore the reasons, the kind of jealousy or the kind of insecurities, their own psychic conflicts which are behind any relationships. So if these are identified going in a trance state or going in a subconscious, person is able to dig into subconscious and find out the jealousy or the kind of emotions related to any relationship issues, then it is easier to solve them. Then it can be solved through hypnotic suggestions and also through other therapies in conscious stage. So how it works, if we can say, how it can help is, as I said, it is used with alongside with other therapies, and it helps in explore past traumas and underlying issues that may have exacerbated that the reaction to the or experience with trauma. So it is not only identifying the trauma. Sometimes what happens, person is able to identify trauma, and in some other disorders, as I was talking about dissociative and convergent disorders, person is not able to identify the trauma. So hypnotherapy helps in identifying the trauma as well as how the trauma has affected the life, past traumatic experiences also, and the reaction to the experiences of trauma. So through hypnotherapy, we can see different stages of trauma, identifying trauma. Some persons, for example, if it is a physical kind of trauma, it is easy to identify. Okay, I met with that accident. I was into a disaster situation. I was there when there was a terror attack. So it is easy to identify such trauma. But childhood traumatic experiences or some other traumatic experiences, which generally person represses also. No? So it is generally repressed into the mind. Person is not aware and repressed in unconscious. So it is not, person is not able actually to know what is my actual trauma. So there are conflicts, there are symptoms, but the therapist as well as the client is not aware of what kind of trauma person has gone through. It may be like, for example, childhood sexual abuse, person may not be aware, or any other situation which was traumatic, but person is not aware whether it was traumatic at that point of time, and it is causing some or other effects, causing symptoms, causing different kind of anxieties or dissociative or convergent symptoms. For example, leading to chronic pain and aches, leading to some other kind of convergent symptoms. So hypnotherapy helps in identifying trauma, and I can say with my experience that it helps very much, especially in dissociative conversion, when you are not able, because there is a trauma or the conflict is not visible. It is not at conscious level, but a patient doesn't know what the conflict is. And just with 1 or 2 or 3 sessions of hypnotherapy, trauma can be, or the traumatic experience can be identified. It may be shame, it may be some kind of abandonment, it may be relationship issues that can be identified. And then if you identify, then you can resolve with any form of therapy, whatever you want. And it also helps in identifying unhealthy coping mechanisms. For example, if a person is able to identify the trauma, then how he or she dealt with that trauma. For example, a problem is existing problem, maybe, for example, domestic violence. But what is the coping? How the person is dealing with that kind of situation, or even not domestic violence, it is just relationship issues in a family, very common in Indian families, and a saas bahu kind of relationships. Even, you know, even this can be very traumatic for a person and can lead to some disorders, up to the disorder level, having those conflicts, because in social situations person may not respond, person may not react in those relationships, and having those traumatic experience, imbibing those in their subconscious and unconscious minds as traumatic experiences. So after identifying them, the kind of coping mechanisms which were used, so it could have been resolved if a person is having healthy coping mechanisms through problem solving or through other positive kind of coping. But generally, if a person is using emotionally focused coping skills, not able to go for healthy coping styles or coping skills, then those can also be identified, that how person has dealt with that traumatic situation, and then you can use that information, use that to build up further therapy. So it also helps, you can say, in making goals of our therapy. So to make future goals, long-term goals of therapy can also be depending on your hypnotherapy sessions. So after knowing that what kind of situation is it, what are the deficits in the person, what type of personality or what type of coping skills person is using, what kind of defenses person is using. So through hypnotherapy, you can also learn the kind of defenses person has used. If you have that psychodynamic bend of mind, so you can also learn that what kind of defenses has been used. So then dealing with those becomes easier in any form of therapy, and then your goals also become clear. As a therapist, it helps you. So you can, after the hypnotherapy session, you can sit with the client and form the goals, talking about your findings through hypnotherapy, whatever you have found. So you can discuss it with your client and you can frame further goals for future therapies. So first of all, the person feels relaxed in a hypnotherapy session. Therapist makes the person feel relaxed, and while safely accessing his or her memories to help him or her better understanding their emotions surrounding the trauma. Together, the therapist and client can identify triggers and change how one reacts to them and how one feels about traumatic events. So when we talk about the stages, how it is done, identifying the trigger. So what are the triggers which leads the person to those traumatic memories, and then how to deal with those triggers and how to deal with the actual traumatic events. It's not that we are dealing to just to say forget it. Through hypnotherapy, it is not possible, or if you claim no, we are just making the person to forget all traumatic memories. So we are not working on that. It's not the aim, because it's not possible for any person to forget anything which is already existing in subconscious or unconscious mind. So the context is like to reframe those memories, providing them different context, reliving those, revisiting those, providing different meanings to those memories where possible, if like forgiveness is there. So then using solution focused therapy, using positive interventions, how you can process those memories of traumatic events. That's much more important. So if we talk about trauma focused hypnotherapy, especially though hypnotherapy is used, we know, in most of the situations, and when we use hypnotherapy, as I am saying, through my experience, some other trauma is generally found. So when I am dealing with any type of client, generally when we go into the hypnotherapy sessions, we find some or other traumatic memories. So trauma is such a common thing, I may say, and it is there underlying. So again, going to, if we say back to the Freud's theories and psychoanalytic theories, that some childhood experiences, your own traumatic experiences lead to different conflicts in conscious and subconscious and your conscious mind. Ego, if ego is not able to deal with them, not using the proper defense mechanisms, then it may convert. Sometimes we start therapy for some very different purpose, but ultimately we find that, okay, this disorder is also related to some kind of trauma. For example, hypnotherapy is also used for disorders like asthma, respiratory problems, for other health problems like sleep problems, so many other disorders, even for hypertension, it helps. So when a therapist starts, so many physicians are using it. If you are aware of Hypnosis Association of India, there are the more, like if you say psychologists are less, there more are like doctors, physicians, dentists. They are also using it for anesthetic effect while doing surgery, or especially on the dentist chair, people are using hypnotherapy. But what happens when they are using it even for some physical disorder or ailment, they find that there may be some trauma attached to it. That's why it is coming. Not especially the psychosomatic kind of disorders. If we see when we deal with hypertension, when we deal with asthma, when we deal with some other cardiovascular disorders, it may be helpful, and there may be some underlying psychic conflicts, not even trauma, there may be some psychic conflicts, and we are able to resolve those psychic conflicts through hypnotherapy, then those physical disorders are also cured. So this, a theoretical orientation based is generally based on the principles of Ericksonian and Jungian hypnotherapy. So I hope at least some of you must be aware of Ericksonian hypnotherapy. How many of you are aware? Erickson's hypnotherapy techniques, very nice. What I practically follow is also a kind of Ericksonian therapy, because the use of hypnotherapy done by Erickson was not that kind of classical hypnosis which was used by Freud. Jung also had some differences. That's why Jungian therapy is also based on, trauma-based therapies are also based on Jungian approach, where he used more of like metaphors, symbols. We know Jung is famous for using symbols, metaphors, and other things to identify, doing dream analysis, or taking a person to directly taking to trance, and then using the symbols to understand what person is experiencing, the kind of stories coming to the mind. But Ericksonian approach, when we talk about Erickson approach, is very flexible. The very important part of it is very flexible. It is, Erickson says that you should make a tailor-made approach for every patient. So it is a tailor-made approach because every person's trauma is different. Every person's experience and the way they experience the trauma is different. So even if the event is same, the way a person experiences it may be different. Subjective experiences are different. So our therapeutic approach should also be different for each patient, dealing with their own subjective experiences. And what other things? Erickson also uses many metaphors. Metaphors means if we are using, not directly giving the suggestions to go into trance, using it going into deep sleep, going into deep relaxation states, inducing it with different methods. Erickson was known to induce hypnotherapy even with a handshake. So it is more towards giving those kind of assertive suggestions to a person. If the suggestibility of a person is high, even a handshake, even just seeing into the eyes of the patient can lead to a hypnotherapy session. So not giving so many minutes time for leading a person to trance. So it may be a very quick approach, just like this. As we see, sometimes the magic happens. So what is very important in this kind of hypnotherapy is your understanding of patient and your rapport. So first stage in any hypnotherapy when we are planning is rapport with the patient, trust of the patient on you. Because if you have a great relationship with the patient, if patient thinks I can reveal, because you, as like ethical principle, you have to tell what hypnotherapy is, what you are doing. You are trying to reach to the subconscious, so you have to take the permission from the patient. But at the same time, remember and always tell the patient that it is not necessary that you are supposed to tell me everything you are feeling or you are able to coming to your memory or in your thought while you are going through hypnotherapy. Because sometimes, and that gives a relief to the patient. Otherwise, the general common belief is hypnosis is something where a person would do magic on me and they would ask me to reveal anything, and I may reveal anything about me, which I may not like to reveal. जनरली जो कॉमन मैन में हिप्नोसिस का कॉन्सेप्ट है वो यही है ना, कि कुछ जादू जैसा कर देंगे, हिप्नोसिस होगा और वो मुझसे कुछ भी काम करा लेंगे, हिप्नोसिस में मेरे से कुछ काम करा लेंगे, मेरे बारे में पता नहीं क्या जान लेंगे, कुछ ऐसा सजेशन. क्योंकि जो कॉमन स्टोरीज हम लोग सुनते हैं ना कि हिप्नोसिस, जैसे जो जादूगर लोग बताते थे कि हिप्नोसिस किया और उसको यहाँ से वहां भेज दिया, उससे ये करा दिया, है ना. इन सम ऑफ द novels you would find कि hypnosis में करके murder करा दिया. तो it is, but it is not. We are using hypnosis as a therapy. तो हमको patient को बहुत अच्छे से बनाना है कि we are using it for a therapeutic approach. And during that time, it's not that your conscious mind is totally shut. It's not. You are aware of what you are experiencing even during your hypnotherapy session. So you are free to recall and you are free to communicate. You may recall many things, but you are free to communicate whatever you wish, or you may say, no, I know, for example, during a hypnotherapy session, a person may be crying and you ask, what is happening? What are you feeling? So a person may choose to say, no, I know I am feeling something. It is painful, but I don't want to reveal to you. But I know once I am undergoing this experience, I would feel relaxed, relieved, because I was not aware that this event was such painful to me. But I don't want to share it with you. So it's okay. Your purpose is that the person is able to identify. Person himself or herself has identified that trauma, and he or she is also learning to deal with it. So your purpose is over there. It is not necessary that I should know what was the actual event or what was the actual thing, who were the persons involved in it. Usually what happens, especially in relationship issues, person may not want to tell you who were the persons involved in it. Sometimes, for example, childhood sexual abuse. Person now, during adulthood, person comes to know that I have undergone that childhood trauma, childhood sexual experience, but I don't want to reveal the names. It may be a very dear person to me today, or it may cause any complications if I think consciously. My conscious mind says if I reveal, if other persons know, it may create complications. So I may choose not to reveal the name. I may choose not to reveal exactly what happened. So our interest should not be knowing the stories. Our interest is to focus on relieving the symptoms, relieving the stress of the patient, relieving the trauma of the patient. वो कहानियां सुनने का शौक नहीं रखना है ना. हम लोग मान के चलते हैं कि शायद जब हम हिप्नोथेरेपी कर रहे हैं, हिप्नोसिस कर रहे हैं, तो हमें बहुत सारी कहानियां सुनने को मिलेंगी. एंड एज अ पर्सन वी ऑल्सो गेट इंटरेस्टेड. तो वो इंटरेस्ट को हमें कंट्रोल में रखना है. So it allows to bring unconscious thoughts and beliefs we know in conscious, and hypnotherapy is evidence-based intervention that can serve the needs of individuals, couples, and families. So it can be used with anyone. Evidence-based, there are ample researches, especially for trauma. Any theoretical orientation a practitioner may use can be integrated with the principles of hypnotherapy to provide healing and resolution for those who struggle with trauma. So if I feel I am a behavior therapist, or I am a pure cognitive behavior therapist, my training is in CBT, or my training is in a particular therapy, acceptance commitment therapy, I have done a specialization, or any other particular therapy. But hypnotherapy can be used as an adjunct to any of these therapies. So that is an amalgamation with any theoretical approach. That's what Ericksonian hypnotherapy is. So when we are using it, generally it is used as eclectic approach. So Erickson's give that flexibility. You can plan your sessions according to your patient. You can use the approach. You can even use the technique of induction. It's not necessary that you use same technique of induction with every patient. So you also need to learn so many techniques of induction. You also need to evolve as a therapist to learn, because there may be different backgrounds. The kind of hospital I am working with, we get patients from very lower backgrounds, illiterate patients. So sometimes for CBT, we find some limitations because they may not be able to get those kind of cognitive therapies. But hypnotherapy can be done even with an illiterate person, person of any age, person of any gender, adolescent person, or senior citizen. It can be done with anyone, and it is very safe, believe me. Sometimes people think that if a person is gone to hypnosis, when we may not be able to bring him or her back. That thing you have to learn. So before practicing, it is also very necessary to practice it, to learn self-hypnosis. If you are able to hypnotize yourself, then only you can practice. I think one should learn that. And you can practice with your friends, with your colleagues, and then you should start with patients, because bringing back is also one of the major thing, because it's not that the person would stuck there. It's not. Now, because in hypnotherapy, we are not using that kind of hypnosis, as I am saying. But if we leave the person in between of a traumatic experience, then those subjective experiences of anxiety, fear, or whatever subjective experiences were attached to that, person was reliving that, those experiences, he was experiencing that anxiety and fear during your hypnotherapy session, and if it ends abruptly without any solution, then what would happen? Those symptoms would rather enhance, instead of going down. So while you are performing hypnotherapy, you have to keep this in mind, because during the hypnotherapy session, you may find person having high anxiety, nervousness, heartbeat बढ़ रही है, कोई person रो रहा है ना? Sometimes person start crying, screaming, anything may happen. So you should know how to deal it. Sometimes we have to use CBT techniques during the hypnotherapy. So it is a kind of a package deal, not just using hypnosis as a method, doing it for half an hour and just it is over. And like as I am saying, bringing back the patient to the conscious. And sometimes we need to just a post-hypnotic session there and then. Because after the hypnotherapy session, person may be having so much traumatic experiences. He was not aware of the trauma and now he is aware of the trauma. So how to deal with it? So your ability of dealing those experiences which a person has experienced during hypnotherapy is also very, very important, especially in trauma-focused hypnotherapy. So it is uniquely equipped to help patients deal with complex traumas and, as I said, acute and chronic traumas also. How does it work actually? So hypnotherapy explores different states of consciousness which play a major role in your everyday life. We know that different levels of consciousness as psychology student, and our conscious mind involves the thoughts and feeling we can access directly, while subconscious and unconscious we know. So during the hypnotherapy, those states of mind, subconscious and unconscious, we try to explore. We try to go deeper and deeper into those parts of mind and try to access those thoughts, beliefs, feelings, and it may include your habits, skills, learnings, memories, so many things. So which we are not aware in the conscious mind, which we are not thinking in our conscious mind. In our day-to-day life, we may be very busy and not aware that there is something lying in our unconscious mind. So when in easy term, you have to explain it to your patient what we do. I don't know how you people explain conscious, subconscious, unconscious mind. I say it is somewhere like a storeroom in the house where so many things are lying and we are not aware. Whatever is lying there, it is not used for many years. So it is like a big, as we have some ancestral house at our village, where is some dark room where the things are kept which have not been used. But these are very important. There may be some ancestral things which we have got from our ancestors. There may be some important and some meaningful things which we are not aware of. So through hypnotherapy, we are trying to access to enter that storeroom. So the technique I may tell you after some slides. And sorry. So how it is done? Through deep relaxation. What we do, reframing the context of memory. As I was saying, we cannot just ask the person to forget. Any one of us can forget anything. If we say, I have forgotten, you are just repressing it to subconscious or unconscious mind. We don't forget anything. Though we say like it's good that we forget. But even we know that through stimulation, what happens in like forensic studies we do, if we have witnessed some accident or some incident where we have to go as a witness, there are so many studies on eyewitnesses where person does not remember exactly, but when done hypnotherapy or the mind is stimulated, brain is stimulated, we may recall the details of that event or that situation, that place. So our mind is able to recall those details even which we are not paying conscious attention to. So all these things are kept in subconscious and unconscious mind, and through hypnotherapy we can approach those things. So even in forensics, the help of hypnotherapy is taken to find out to recreate the scenes, to recreate the situations and know that the person is lying or not, what was the exact motive or how it actually happened. Witnesses can be hypnotized, or through hypnotherapy witnesses can tell about the traumatic experiences or what they witnessed actually, which maybe otherwise consciously it might have repressed due to trauma. And for example, having a murder in your presence, that may be very traumatic. So the acute memory may be subsided, but through hypnotherapy it can be brought back to the conscious level to tell the details. So it helps in forensics also. And if you have heard the name of Professor H.P. Mishra, who started clinical hypnotherapy in India, after we know Professor Girindra Shekhar Bose, who actually started psychoanalysis and that kind of hypnotic practice in Calcutta. He is known as the first psychologist introducing psychology in India. But the actual clinical hypnosis, which was used with patients in different forms and in forensics also, was by Professor Haripad Mishra. If you know, he was professor at NIMHANS, and he actually started using it. So so many techniques was taught by him of going into actual practical hypnotherapy, and especially I'm talking about hypnotherapy, not pure hypnosis. So how hypnotherapy works, it helps in reframing the context of memory. So when we are not able to erase the memories, but we can change specific thoughts, beliefs and emotions attached to it. So going into trance or going into a hypnotic stage, identifying that traumatic memory and subjective experiences, and then trying to change those subjective experiences, not actually the event, the subjective experiences, the subjective memories, and how a person remembers that incident, not the raw memory itself. Because sometimes what happens in due course of time, it is not the actual incident what we remember. So many other things are attached to it. For example, something happened, but how I received the comments of my family members, how everyone commented on me. I had a breakup in a relationship that was traumatic, but how others reacted to it, how my family or other friends, what kind of feelings attached to it. I had a low self-esteem. I felt that I'm not good enough to be liked by anyone. So it's not the actual breakup which is painful. It is the kind of attribution, it is the kind of cognitive meaning and experiences I am attaching to it, the feelings I am attaching to it, feeling of abandonment. So what are the feelings, what are the thoughts, what are the beliefs or cognitive schema I am attaching to that particular event? So separation may be traumatic for someone, may not be traumatic for the other person. And why it is becoming traumatic? Because the kind of meaning I am attaching to it. So through hypnotherapy, we can identify those core feelings, thoughts, beliefs which were attached to that events, and we can consciously deal with those. So therapists consciously taking those things, making it a target in the therapy, that these are the target symptoms I have to deal. And during hypnotherapy and post hypnotherapy, using any technique which you are comfortable with, you can deal with those particular reactions. And these memories, are flexible. These can be changed, adapted to situations. So that's how during hypnotherapy, that flexibility helps. Through making open suggestions and more able to accept small changes to some of their original meaning. So person also becomes flexible and adapting to the small changes which are made into the memory. So each time the mind replays a memory, minor details of the memory are constantly being remolded. So we try to give a different meaning to that memory. And that happens with trauma also. It is with trauma that a person, every time I remember that trauma, I may remember it in a different way. For sometimes it is giving me a different meaning. For sometimes, from other time, it may be providing a different kind of anxiety to me. So it is a kind of tool which is there to re-edit. You can change whatever a particular memory means to you and how you feel about it and how you respond to it when you create and attach new associations and narratives to that memory. And then when these changes are applied, it becomes reasonably acceptable to the person also. Okay, this has happened, but I have to move on. What happens with the trauma? That person is not able to move on. Person is stuck into it. So our main, in any trauma focused therapy, our aim is that the person should not get stuck, should learn to move on from that trauma. Try to live a normal life. So hypnotherapy helps in that way. So it is basically re-editing that emotional experiences in your mind and negative experiences. And these can be reinterpreted toward your hypnotherapeutic goals. And and as you change the way you feel about the memory, you change your entire perception of it, including altering your mental discomfort and the negative physical reactions. So the techniques generally used are relaxation. So usually the technique through which hypnosis or hypnotherapy is induced is through relaxation. That relaxation, maybe you can start with Jacobson relaxation. If you are aware of it and you practice it, you can start any form of relaxation. So whatever form of relaxation you have learned during your training, you can use it. After the relaxation, you have to just start more suggestions that you are going into a sleep-like state. Don't use the word trance. We don't use the word trance, that you are going into trance. So you are going into a state of deep relaxation. What is very important while you are practicing hypnotherapy is your volume, your tone, your modulation of your voice, your own persona. That is very, very important. We know that these therapist factors are important in any therapy, but these are very much important in hypnotherapy. Because person's eyes are closed, he has to hear only your voice, and your voice modulations, your language of suggestions you are providing is the thing which is going to work. And that also you have to be flexible. You have to change according to client. What is his or her education level, what is background. So we have to change according to it. So it may start through relaxation. It may start, if like a person learns relaxation in second or third or fourth session, you can just ask, you sit quietly, you just relax, and you can start within 5 minutes. The person may go to trance. In initial sessions, it may take some time. Some people use that pendulum. Some people use relaxation. Some people use Jacobson's method. Some people may use Yogasana, Yog Nidra, any form of relaxation. Some people may just, or sometimes the more common techniques, which sometimes I also use, is after going into relaxation, just say, I'm counting from 1 to 10, and as my counting, you will start going into deep sleep. So with every digit, I give a suggestion, and a 1, your eyes are closed, you are feeling relaxed. 2, so your eyes are getting heavier. धीरे धीरे limbs heavier होते जाते हैं ना, तो limbs are getting heavier. 4, 5, 6 तक पहुंचते पहुंचते now you can hear only my voice, you cannot hear other voices around you. You cannot respond, you will respond only when I ask you to respond to any stimulus. So the gradation of suggestions increases with the time. So counting these numbers helps. Some people even don't use these numbers. As I said, if you have learned and if the patient is that much suggestible, it can be induced just by a handshake, just by talking to a few minutes. You ask the patient to just sit comfortably in a chair or lie down on a couch and just say, okay, you just relax, and you will be able to go into your subconscious and we would be able to talk about your experiences. So it may be just like depending on the patient. But when we start practicing, when we learn, it's always good to start with relaxation, count the numbers. So you also learn, you also go with the patient, you also take that journey. So going deep, deeper and deeper, you use your voice accordingly. Second phase is identifying the triggers. So what are the triggers which bring back the traumatic events? Sometimes these are unnoticed. So person suddenly starts feeling PTSD symptoms and those flashbacks and all. But what are the actual triggers? It may be sometimes the background music. It may be sometimes, for example, if someone has witnessed a murder, then what was the actual environment at that point of time? So whenever a person enters accidentally even into that environment, all that anxiety comes back. A childhood trauma, childhood sexual abuse. So whenever I am around of a person of that particular age, unconsciously I start getting anxious. Or if I enter into a closed room, if the door is closed, if there is no light, so many things with different persons. Even having a dark room may trigger traumatic experience or trigger symptoms. I'm not able to sleep into a dark room. I'm not able to sleep while all the doors and windows are shut. So all these may be the triggers. Similarly, talking about the event, incidents, people present around the person at that point of time. So while we are dealing with the trauma, we are identifying that what was the event, what were the incidents actually happened, who were the persons who were present at that point of time, whatever person can recall about the event. Then reframing the memories. So trying to build a new perspective, what you could have done. For example, if it is a childhood trauma, now as an adult, what you could have done at that point of time, what you missed. Now as an adult, what you can do. So reframing, providing the person a new perspective. Now, for example, being fearful at that point of time was your appropriate response. You were a child, you could not react. But now what you can do? Now you can go and directly offend that person. Now you are an adult. If you know that person, now you can go. Or if you are in a similar situation, if you can protect someone, or you are in a similar situation, now you can react. At that point of time, whatever was your response was appropriate, at least validating that response. You became fearful, you became traumatic, you could not say it to anyone. Now it's very easy to say कि आपने उस समय अलार्म क्यों नहीं रेस किया, आपने पेरेंट्स को बताया होता, आपने ये किया होता. No, the child was not in that stage. Child was so fearful. So validating also that, okay, whatever you did at that point of time was appropriate. You were a child. You did not understand what to do. You did not know to whom you should go. But now as an adult, you are able to identify it. So can you now tell it to your family members? Can you now deal with it? Can you challenge that abuser or perpetrator now if you know the person, है ना? कई बार होता है family members ही हैं, but now do you have courage to challenge that person? How you are going to deal with it now? ना, क्योंकि कई बार होता है जब when we become adult we get those memories, we know that this person was perpetrator and sometimes it's a family member only. How to deal with that person now on having memories of those childhood events. So hypnotherapy may help in that. And then anchoring resource states. Making, after the trauma is identified, triggers are identified, now giving the person new kind of feelings, replacing those anxieties, fears with confidence that you are now in a safer environment. You know how to make yourself safe. You are confident. You have all the resources with you. So making the person aware of the resources. You can take help. You are now adult. You have a thinking power. You can deal with the situations. So making the person aware of whatever resources the person has right now. What new coping skills person can learn. What new problem solving skills person can learn. What may be the sources from where help can be taken. And how he can help others. So even helping others can be a big resource. Is now possible that he can forgive that person. For example, in relationship issues, I was in a very toxic relationship. It is traumatic. But once a person starts contextualizing those memories, reframing those memories, can I now forgive that person? Because I don't want to live with that person. I'm not living with that person. But as positive psychology intervention says, if you start forgiving, at least your own burden is also lessened. But it depends totally on your approach as a therapist and as client's approach, if client is willing for it or not. So dealing with different approaches. Yes, I think just after a minute or two, we would have questions. So hypnosis, as I'm talking, it becomes more effective and helpful when other techniques are also associated. So even mindfulness-based interventions, positive interventions, as I'm saying, based on the needs of the client. So solution-focused therapy. I don't know how many of you use solution-based, solution-focused therapy. Has anyone of you learned? Okay, very nice. It's a very brief, nice therapy. Pardon? Adolescents, okay. Yes, it is a short-term therapy, but it can also be used with hypnotherapy. When a person is in that subconscious state or after as post-hypnotherapy session, now I am aware of the problems, but how to focus on solution, what solutions can be given to it. Positive interventions are also very good to use after hypnotherapy sessions. Yes, so coming in between to some questions. Yes, ma'am, you were saying something, please.
You said that later on, then you can ask the person to forgive. Like a lot of times, like people who are staying along with the people who are toxic in their environment. So, and they will continuously be coming in touch with them, especially like when it is relatives and all that. So, can we expect them to forgive them when they are?
I'm not saying to ask everyone to forgive.
No,
it totally depends on the client and the kind of approach you are using. It should totally be the choice of client. It's not my choice, therapist choice nahi hai. If the person wants to move on, especially with the persons who are no more living with the person. And if there was an incident, an accident, for example, there was an accident, someone hit me and कुछ मेरा साथ ऐसा trauma हो गया ना, कोई पूरा life के लिए कुछ traumatic हो गया, then can I forgive that person after a few years? Because that relieves the burden. We all know in positive interventions, but it totally depends, suggesting that person on person's own inclination, whether a person is inclined towards that kind of solution or not. Now we cannot ask everyone to just forgive in toxic, and it is not good for sometimes. In many of the situations, forgiving is not good. We are not making our clients so meek that forgive everyone.
Right.
So it is not the only solution. It totally depends. There may be different approaches. Person may learn in such situation, as you are saying, that he's encountering that person who is a perpetrator or who is causing the toxic environment.
Yeah, especially it
frequently.
happens with narcissistic abuse.
So you have to make the person learn assertiveness, how to deal with that person. So different type of copings, as well as the assertiveness training may be required, how to challenge that person or how to ignore the reactions of that person. So it totally depends the kind of skills person requires on the situation, the kind of problems there are, and the kind of persons, and of course the personality of the client, what kind of action person may want to take. So there is no, as I'm saying again and again, for every client we have to make a tailor-made solutions. And as I said, what I also practice sometimes, the goals, these kind of goals are made after hypnotherapy sessions. When in the hypnotherapy we know that these are the triggers, these are the traumatic events, these may be the persons involved in trauma who are still living or who are not living with the person. So now what is required? With the help of client, we further make goals, short-term goals and long-term goals, how a person is going to deal. Now the burden is more. Now the person is aware of the trauma also. Now the person is aware of the incident also. So it is our duty to not leaving him or her in between. ना अगर पर्सन को पता भी चल गया ये ट्रॉमा था और कोई सॉल्यूशन भी नहीं मिला तो वो तो और ज्यादा ट्रॉमेटिक हो जाएगा.
Thank you, ma'am.
Yes, please.
Ma'am, I have two questions. Firstly, you said that in techniques, any kind of relaxation can be used. So, in that case, can we use autogenic training for hypnotherapy?
Yes.
Because in autogenic training also, like we go in self-hypnosis, we train the patient to go. So wouldn't that be a bit contraindicated that we are telling the patient to go into self-hypnosis before we're actually going for hypnotherapy?
Not asking to go to self-hypnosis. In autogenic training, suggestions can be provided, but it cannot be used, I think, in initial sessions. When a person learns how to get relaxed, then person can use autogenic suggestions to get relaxed and to get into hypnosis. But if a client is naive, if he has never done the relaxation techniques, doesn't know how to feel relaxed, for that kind of client we cannot do that. If a person already knows, he has taken some kind of relaxation training, or if he is practicing Yoga Nidra, Shavasana or anything, we can say, okay, you start from there, you know what is relaxation. Then we can start further from the relaxation. If a person doesn't know what is relaxation, now what a feeling of relaxation, or we can introduce imagery. Imagery is also very good, visual imagery. Now what we do is taking into the relaxation and then inducing some kind of imagery, either asking the person to imagine, as like Sonia ma'am was saying in the last session, to identify your own metaphor, what you were saying? Metaphor, na? So what is the thing which is giving you balance? So similarly, what is the thing which is making you relaxed? So if you ask me if I have to imagine myself sitting on a seashore, seeing the sea, na? So for some person it may be hills, for some person it may be going into a good garden, seeing greenery. For someone, even it may be going to a mall. So it is like we can say that you feel, so you just imagine wherever you are feeling comfortable, you are happy, you are relaxed. So then introducing that imagery, and from there now going to relaxation and deep relaxation. Or you can just introduce some imagery by yourself, as I do generally. If a person is not able to identify or to use his own imagery, we can introduce an imagery. So may I tell you in brief what kind of method I use, if you all are willing? But at present, I'm not trying to take you to that journey. because of time constraint, but just telling you how I start. So giving some kind of relaxation first, either as I said JPMR, or I have learned that JPMR ke aage ka just clenching your fist and then identifying, then just screening your body from toes to the upwards, and feeling that screening, like screening and scanning हम कह सकते हैं, scan कर रहे हैं body का, like from my toes to upwards, that every part of my body is getting relaxed, because it is a quicker in comparison to JPMR. JPMR में minimum 20-25 minutes लग जाते हैं. So you can ask, just lie down or just sit in a relaxed chair and scan your body from downwards to upwards, and every part of it is getting relaxed. And what is the feeling of relaxation? That it is going lighter. आप ऐसे इमेजिन करें जैसे उसमें से सारा टेंशन निकल गया है, बट आपकी वॉइस और आपका, जैसे मैं कह रही थी, दैट इज वेरी इंपॉर्टेंट. आंख बंद करके जब आप कह रहे हैं, आप इमेजिन करिए धीरे धीरे आपके पैरों से सारा टेंशन जा रहा है, आपके पैर हल्के होते जा रहे हैं ना. सो आपका जो टोन है, जो आपका पेस है, वो बहुत इंपॉर्टेंट है. सो आफ्टर inducing relaxation, like going from legs to the middle part of the body and hands, neck, face and up to the head, तो आपका सर में, आपके दिमाग के अंदर आप पूरा रिलैक्स्ड फील कर रहे हैं. जितने भी आपके दिमाग में टेंशन्स थे कुछ समय के लिए, वो सारे सबसाइड हो गए हैं. यू कैन इमेजिन, जैसे हम कह रहे हैं इमेजरी, जैसे आपके दिमाग के अंदर कुछ गांठें थी, है ना. आई कैन इमेजिन some conflicts, troubles, so these are in the form of some knots and you are untying those knots. धीरे धीरे वो गांठें खुल रही हैं. गांठें खुल रही हैं ना, या आप सर पे बहुत हैवी फील कर रहे थे, धीरे धीरे सारे बर्डन्स वहां से हट रहे हैं. तो इट मे बी लाइक हैविंग सम थिंग्स आउट ऑफ योर माइंड, और यू आर अनटाइंग सम नॉट्स. तो धीरे धीरे गांठें खुल रही हैं, दिमाग आपका शांत होता जा रहा है. आप धीरे धीरे एक ऐसी रिलैक्सेशन की स्टेट में पहुंच रहे हैं जहां कुछ समय के लिए आप अपने आसपास के एनवायरनमेंट से कट जाएंगे. मैं 1 से 10 तक गिनती गिनूंगी और आप एक अच्छी सी नींद में जाते जाएंगे. और हम एक जर्नी पे जा रहे हैं जो एक इनसाइड जर्नी है, आपके मन के अंदर की जर्नी है, और आप इसे बहुत एंजॉय करने वाले हैं. ऐसी बहुत सारी चीजें जो हमें कॉन्शियसली नहीं पता है, शायद हम उनके बारे में जानेंगे. आप अपने मन के अंदर की जर्नी के लिए तैयार हैं? तो चलिए, लेट अस स्टार्ट. 1, आप धीरे धीरे एक गहरी नींद की तरफ जा रहे हैं. आपकी आंखें बंद हैं, आपने बॉडी स्कैन की है, आपकी बॉडी में अभी कहीं कोई टेंशन नहीं है, आपकी बॉडी और माइंड दोनों पूरा रिलैक्स्ड हैं. आप एक इंटरनल जर्नी पर जाने के लिए तैयार हैं. 2, है ना, आप देख रहे हैं ना, एक थोड़ा सा पेस धीमा, आपका वॉल्यूम धीमा, और उसके बाद थोड़ा सा गैप देके देन 2. नाउ योर आईज आर गेटिंग हैवियर. आपकी आंखें भारी हो रही हैं, धीरे धीरे भारी हो रही हैं. आपको नींद आ रही है, लेकिन जिस नींद की तरफ मैं ले जा रही हूँ वो आपकी रेगुलर स्लीप नहीं है. आपको इसमें सोना नहीं है, आपको हम एक माइंड की अवेयरनेस की जर्नी पे ले जा रहे हैं, तो इसमें सोना नहीं है. ये बात हमें शुरू में इंस्ट्रक्शन में हिप्नोथेरेपी में देना बहुत जरूरी होती है, कि बिकॉज वी डोंट हैव मच वर्ड्स इन हिंदी, जनरली वी यूज द वर्ड दैट यू आर गोइंग टुवर्ड्स स्लीप, या आप सो रहे हैं, या आप डीप रिलैक्सेशन में जा रहे हैं, बट इट डजंट मीन दैट यू हैव टू एक्चुअली स्लीप. सोना नहीं है, ये कॉन्शियसली जरूर बताना है ना. और आपके हिप्नोटिक सजेशंस में भी कि आपको सोना नहीं है, आप सोने नहीं जा रहे हो. इट इज दैट्स व्हाई आई यूज द वर्ड्स लाइक गोइंग टुवर्ड्स द इंटरनल जर्नी. धीरे धीरे हम इसको ऐसे 1 to 10 तक बढ़ाते हैं, एंड देन उसमें इंपॉर्टेंट जो बीच में इंस्ट्रक्शंस हैं, जो बात हमने की ना डिस्ट्रैक्शंस को कट करना, कि देयर शुड बी नो आउटर डिस्ट्रैक्शंस। तो अभी आपको अब कोई बाहर की आसपास की आवाजें सुनाई नहीं दे रही हैं। कुछ देर में आप सिर्फ मेरी ही आवाज सुनेंगे, आप सिर्फ मेरी ही आवाज से रिस्पॉन्ड करेंगे, आपको कोई आसपास की आवाज सुनाई नहीं देगी, है ना। तो कुछ असर्टिव से आपके इंस्ट्रक्शंस हैं, बट वो असर्टिव इंस्ट्रक्शंस, वॉइस आपका जो पिच है वो नीचा है, बट जो इंस्ट्रक्शन है वो बहुत क्लियर है एंड सजेस्टेबल, मतलब आपको एक पूरा आप सजेशन दे रहे हैं जिसमें कि आपको ये होगा। सो it should be in future tense, it should be, you know, so your instructions should be like that. फिर आप धीरे धीरे है ना 1 to 10 तक अब आप उसमें टेस्ट कर सकते हैं, क्या आप लग रहा है अब आप पूरी तरह रिलैक्स्ड हैं। अगर आप रिलैक्स्ड फील कर रहे हैं, सिर्फ मेरी आवाज सुन पा रहे हैं, तो you may ask to raise a finger or raise a hand. And how to test that a person has reached into that state or not? It's very simple. If a person has reached towards the trance state, if you ask the person to raise a hand or raise a finger, because the body becomes so heavy, आप में से आई होप कुछ लोगों ने तो जरूर कभी ना कभी हिप्नोसिस खुद के ऊपर किया होगा, महसूस किया होगा, करवाया होगा. How many of you have undergone such sessions? Many of you. So you know जो पहला रिएक्शन होता है क्या, कि हमारा शायद शरीर बहुत भारी हो गया है. So raising a hand is a very difficult task. So you can test whether a person has reached to that state or not when you ask to raise a hand. बिल्कुल वो बहुत एफर्ट के साथ धीमे से हाथ उठा पा रहे हैं. अदरवाइज अगर नहीं है, आप सिर्फ रिलैक्सेशन में हाथ उठाने को कहा जाता है तो आप थोड़ा धीमे उठाओगे, लेकिन आपने इजीली उठा दिया. तो व्हेन यू नो कि अभी उस स्टेट में नहीं पहुंचे हैं, तो यू कैन अगेन काउंट, यू कैन गिव, यू कैन इम्प्रोवाइज सम मोर सजेशंस, एंड देन अ पर्सन व्हेन रीचेस देयर. नाउ इट डिपेंड्स, आप सीधे ट्रॉमा के बारे में बात करना चाहते हैं, लेकिन जैसे मैंने कहा कि सीधे हम ट्रॉमा के बारे में बात करेंगे उस स्टेज तक ले जाने में भी, बिकॉज इट मे बी चाइल्डहुड, या आपका कोई गैस है, आपको भी नहीं पता, पर्सन को भी नहीं पता कि ट्रॉमा क्या था, तो इमेजरी इंट्रोड्यूस करने से फायदा होता है ना. यू कैन जस्ट इंट्रोड्यूस अ इमेजरी. फॉर एग्जांपल आई यूज कि नाउ यू आर वॉकिंग ऑन अ रोड, एन एम्प्टी रोड, इट्स अ गुड नाइस रोड, दोनों तरफ पेड़ लगे हुए हैं, सुंदर सा एक रोड है, आप जा रहे हैं, आसपास बहुत अच्छा एनवायरमेंट है ना, आप कुछ भी क्रिएट कर सकते हैं. देन यू आर एंटरिंग इनटू अ पार्क, फॉर एग्जांपल यू आर एंटरिंग इनटू अ गार्डन, नॉट पार्क, इनटू अ गार्डन. इट्स अ ब्यूटीफुल गार्डन. आप इस गार्डन में एंटर कर रहे हैं, एंड यू कैन चेक अगेन एंड अगेन, हैव यू रीच्ड देयर, नाउ हैव यू रीच्ड. एंड ये भी हम इंस्ट्रक्शन में बोलते हैं, दिस इज ऑल्सो वन वेरी इंपॉर्टेंट थिंग, कि यू विल रेस्पॉन्ड ओनली टू माई इंस्ट्रक्शन. जब मैं आपसे कुछ पूछूंगी तभी आप जवाब देंगे. एक तो आपको आसपास की कोई आवाज सुनाई नहीं देगी, और जब मैं कुछ पूछूंगी तभी आप जवाब देंगे. तो जब आप टेस्ट करने के लिए कि वेदर पर्सन हैज रीच्ड टू दैट लेवल ऑफ इंडक्शन और नॉट, हम कहते हैं जैसे आप गेट से एंटर कर रहे हैं, क्या आपको गेट दिखाई दे रहा है, क्या आप गेट के अंदर एंटर कर रहे हैं. पर्सन नॉट्स और सेज कि हाँ यस, अंदर चलिए, बहुत खूबसूरत गार्डन है, फ्लावर्स हैं, ये है वो है, आप कुछ भी उसमें इंट्रोड्यूस कर सकते हैं. एंड यू मे आस्क पर्सन व्हाट यू आर विजुअलाइजिंग इनटू इट, आपको क्या दिखाई दे रहा है ना. पर्सन में टेल, ठीक है फ्लावर्स दिखाई दे रहे हैं, किस कलर के फ्लावर्स हैं, तो आप इमेजरी को और स्ट्रॉन्ग कर रहे हैं. देयर इज अ लेक, देयर आर फ्लावर्स ऑफ दिस पर्टिकुलर कलर. देन एक जो टेक्निक कहीं ब्रायन वीस की टेक्निक से मैं कह सकती हूँ हमने ली है, वो है देन आस्किंग अ पर्सन, जब गार्डन में चले गए एंड यू हैव टेस्टेड दैट पर्सन इज विद यू इन द इमेजरी, कि देयर इज अ बिग लाइक रोप वे हम कह सकते हैं, या एक सीढ़ी जैसी है जो बहुत सुंदर है. दैट स्टेयरकेस मे बी मेड ऑफ एनीथिंग, है ना, एंड इट मे बी वेरी ब्यूटीफुल, having flowers around. It's a beautiful staircase. आप देख रहे हैं, और ये बहुत ऊंचा staircase है. Now you start climbing on it. Are you ready to go to that journey? Yes. Would you like to climb? Yes. अब आप धीरे धीरे ये सीढ़ियां चढ़ना शुरू करिए. धीरे आपके जो सारे बर्डन्स हैं वो नीचे छूटते जा रहे हैं. आप जैसे फ्लोट करते हुए चढ़ रहे हो. आपको अपने आसपास क्लाउड्स दिखाई दे रहे हैं एंड आपकी बॉडी अब हल्की होती जा रही है. आप ऊपर सीढ़ी से जाते जा रहे हैं. So it takes a few like more suggestions and then you ask that now you have reached up. Clouds से भी ऊपर आप पहुंच गए हो and it may be a big hall, it may be a corridor, whatever you want to say. And there are many doors into it. तो sometimes जब हमें ये नहीं पता trauma क्या है, person को भी नहीं पता, आपको भी नहीं पता. So what I use is generally like you have entered to a corridor. देयर आर मैनी डोर्स है ना. जैसे हम इमेजिन करते हैं कि होटल का कॉरिडोर है जिसमें बहुत सारे कमरे हैं, दरवाजे बंद हैं. तो उस तरह का एक कॉरिडोर है, बहुत सारे दरवाजे हैं. फॉर एग्जाम्पल इफ अ पर्सन इज ऑफ 30 years, तो डिफरेंट आपके एज ग्रुप्स उन दरवाजों पे लिखे हुए हैं. 0 to 5 years, 5 to 10 years, 10 to 15 years. Now you have to choose which room you want to enter into. आपका जिसमें भी मन है आप उसमें उस रूम का दरवाजा खोल के आप घुस सकते हो. फॉर एग्जाम्पल अ पर्सन वांट्स टू एंटर इनटू 10 to 15 एज ग्रुप. पर्सन एंटर्स और आपके साथ है, वो जर्नी में है ना, तो बता रहे हैं कि मैं इस रूम में एंटर कर रहा हूँ. अब आपको वहां क्या क्या दिखाई दे रहा है. हु आर द पर्सन्स, व्हाट इज हैपनिंग, हाउ ओल्ड आर यू. आप उस समय है ना. सो पर्सन कैन इमेजिन आई एम जस्ट 12 years, आई एम वियरिंग this dress. These are the persons with me. What are the experiences? There may be good memories, there may be bad memories, there may be traumatic memories. So person can tell you कि ये memories हैं ना. So sometimes एक रूम में सक्सेसफुल नहीं हो सकता है. ठीक है, कुछ नहीं है, अच्छा है, okay, you come back, now move towards other room. Or if you are aware of the trauma, after reaching there you can directly ask the person to enter the dark room to find that traumatic situation and now ask for the solution. अब आप क्या करना चाहते हैं. वहां पे आपको ये पर्सन मिला, आपको बहुत गुस्सा आ रहा है, बुरा लग रहा है. अब आप क्या करना चाहते हैं. मैं इस पर्सन को मारना चाहती हूँ, मैं इसको शाउट करना चाहती हूँ, धक्का देना चाहती हूँ, या जो भी, whatever the reaction is. And I know. So sometimes person starts crying. And sometimes just if you are using hypnotherapy for kind of strength, या बाद के जो sessions हैं जहाँ पे कि trauma resolve हो गया, you can also lead a person towards कि ठीक है, ये रूम सारे खत्म हो गए, हमें trauma भी पता चल गया, हमने इसे resolve भी किया. For future what? You can revisit whenever you like. Now you have learned how to reach to your internal journey, है ना, to your mind. So you have learned, you can use it anytime, this technique, and now go forward. इस कॉरिडोर से और आगे जाइए. देखिए आगे आपको एक ब्यूटीफुल लाइट दिख रही है ना, एन एंजल लाइट. ये सारी चीजें अलग अलग उससे मिलेंगी आपको. हमारे स्पिरिचुअल थेरेपीज में भी हैं, है ना, हमारे पास्ट लाइफ रिग्रेशन में भी यूज होते हैं, हिप्नोथेरेपी में भी यूज होते हैं. So there may be a divine light or there may be some symbol you can use, but generally we try to use symbols which are like universal kind of symbols, not any particular god or कोई भी, क्योंकि वो बहुत ही contextualized हो सकते हैं. But if some person wants to imagine by oneself, तो ठीक है, वो कर सकते हैं. But what we use generally are the universal kind of symbols. So for example, a divine light, it is with you. आप वो देख रहे हैं, वो आपको कुछ कह रही है, आपको कहीं गाइड कर रही है ना. कई बार होता है कि भाई हमें नहीं पता हमें कहाँ जाना है. As a person is totally in dark, everything is dark, I don't know where to go. So then that divine light may help you to take up to the room wherever you want to go. लाइट आपको कहाँ ले जा रही है आप देखिए. फिर ये लाइट मुझे उस जगह ले जा रही है, वो आपको क्या बता रही है, वो कौन से सॉल्यूशंस दे रही है. So the solutions are coming from the own unconscious but coming through the divine light. So this can be very it may give very healing effect, may be very therapeutic for traumatic situations. कि there is someone, कोई angel light है, divine light है, whatever you are calling, and then you can reassure the person कि whenever now you are in trouble, जब भी आपको ये याद आता है, आप इसको घर में ऑटो सजेशन से प्रैक्टिस कर सकते हैं. This light is going to help you in future. आप इसको जब चाहे तब ये इमेजरी इंट्रोड्यूस कर सकते हैं. एंड एज आई सेड, इट्स नॉट ओवर अप टू दैट. ये सेशंस हुए, इसके बाद आप पर्सन को वापस भी लाएंगे. अगेन द सेम प्रोसेस. इफ यू आर यूजिंग दिस प्रोसेस, तो कम बैक टू द स्टेयरकेस. नाउ यू आर कमिंग डाउन फ्रॉम द स्टेयरकेस. धीरे धीरे आप नीचे उतर के आ रहे हैं. आपको बहुत अच्छा लग रहा है. जैसे आप गए थे तब आप परेशान थे, लेकिन आप उतर के आ रहे हैं तो आपको बहुत सारे सॉल्यूशंस मिले हैं. नाउ यू नो व्हाट आर योर प्रॉब्लम्स, सो यू आर फीलिंग लाइट. आप धीरे धीरे नीचे आ रहे हैं. आप खुश हैं. आप देख रहे हैं नीचे आके अब शाम हो गई, मौसम और अच्छा हो गया है. क्या आप थोड़ी देर और गार्डन में बैठना चाहेंगे या बाहर चलना चाहेंगे? The person may want to remain there in that environment. Some people don't want to come out of that. नहीं, मेरा मन नहीं है, मुझे यहाँ ही बहुत अच्छा लग रहा है. But it may be your time limit 1.5 घंटा already हो गया है. So you have to say नहीं, अब काफी देर हो गई है, अब यहाँ से चलना है. रात होने वाली है, यहाँ भी अंधेरा हो रहा है, गार्डन के गेट बंद होने वाले हैं. So you have to do many improvisations, है ना. आपको अपनी स्टोरीज वहां लिखनी पड़ेंगी. तो या कई बार होता है लोग घबरा जाते हैं, नहीं मुझे यहाँ नहीं रहना है. इवन व्हेन द पर्सन इज अपस्टेयर्स, एज आई एम सेइंग, कि ये रूम देखकर मुझे बहुत घबराहट हो रही है, मुझे तुरंत यहाँ से निकालिए. तो आपको तुरंत ये करना पड़ेगा कि ठीक है, आप नीचे आइए. नीचे आके अब आप रिलैक्स्ड फील करिए. वो आपने ऊपर छोड़ दिया है, आप फिर से एक अच्छे एनवायरमेंट में है. यू कैन अगेन इंड्यूस रिलैक्सेशन. यू कैन आस्क द पर्सन टू कम आउट. और वहां क्या हुआ था, किस चीज से एंजाइटी हुई थी, उसको हमें एक्सप्लोर करना होगा. एंड देन टू प्रोवाइड, एज आई एम सेइंग अगेन एंड अगेन, सम अदर फॉर्म ऑफ थेरेपी, है ना. सीबीटी हम करें, सोल्यूशन फोकस्ड करें, जो भी हम करना चाहते हैं वो साथ में उसको इंट्रोड्यूस कर सकते हैं.
So ma'am,
yes
ma'am, I had one more question. Ma'am, here.
Sorry,
Yeah.
yes.
I had one more question. Since you said that hypnotherapy is becomes more effective when we introduce other modalities, so is it safe to say that it's more of an adjunct therapy rather than a primary therapy?
Yes, that's what I said in beginning. No, it's not that we cannot use it alone. We can use it alone, but while finding solutions, because for most of us, it's not that only like, even it does wonders, है ना. कुछ केसेस में सिर्फ 3 थेरेपी या वो 3 सेशंस या 2 सेशंस हिप्नोथेरेपी के प्रॉब्लम सारी खत्म. Because it depends on the type of problem. So quickly, like telling you about, because मेरा जो experience है traumatic situations में, but more of dissociative kind of reactions I see in persons. For just time is also 2 बजने.
Thank you, ma'am.
So it is like just, for example, a girl who became totally mute after marriage, a young girl after marriage, a few days after marriage, for example, a week or 10 days, became totally mute. And पता नहीं हो रहा था क्या था, some episodes of unresponsiveness, and became totally mute. Was admitted, करीब 1 महीना हो गया, all the medications were tried, then the ECT was planned, and I said कि just give me chance of having 1 or 2 sessions of hypnotherapy. And then when like hypnotherapy was done with her, it was revealed that she was having some premarital relationship, which, and where she eloped also with the boy for 3-4 days, then came back and was married by the parents, as usually happened, to some other boy. Now she found this boy also very good, with whom she got married, but she had this conflict in mind, if now my husband comes to know about my previous relationship, this relationship may get spoiled, and now I want to live in this relationship, so I should not by mistake tell to him any time about the previous relationship. किसी भी तरह कभी ऐसा ना हो मेरे मुंह से निकल जाए कहीं वो बात, मेरे हस्बैंड को किसी तरह पता चल जाए. So that's why probably, अगर हम इसको साइकोडायनेमिक उसमें देखें कि भाई शायद म्यूटिज्म वाज द रेस्पॉन्स. इफ आई वुड नॉट स्पीक, आई मे नॉट बी एबल टू टेल एनीथिंग अबाउट द प्रीवियस रिलेशनशिप. सो दैट वाज द काइंड ऑफ रिएक्शन, एंड व्हेन इट वाज रिजॉल्व्ड, एंड आफ्टर दैट a kind of some family sessions were conducted, husband also knew about it, and then everything was resolved. So just with 2 sessions of hypnotherapy, this kind of reaction came out. So there are so many cases. Yes, please.
Hello, ma'am. Ma'am, as we talked about the concept of forgiveness, right? So if we are dealing with a person, or you can say a client, that is having a trauma from an immediate family member, from a past experience, and we want to apply that concept of forgiveness on him, and he or she is not able to get with it, and the situation is like there is no way of getting rid of that person. He or she has to spend his whole life with him. So what should be our approach for that?
We cannot force forgiveness to any person. हम जबरदस्ती फोर्सफुली नहीं कह सकते कि आप उसे फॉरगिव कर दो. वो तो घर वाले भी कहते हैं चलो जो हो गया छोड़ो, माफ कर दो, फिर रहना ही है इसके साथ. लेकिन ये हम भी फॉरगिवनेस को फोर्स नहीं कर सकते हैं. Ask her what can be done, and you as a therapist have to tailor-made some things. How to deal with that situations. Whenever that person is there, the person has to encounter that person. उस समय क्या होता है, प्रॉब्लम कहाँ आती है, वो असर्टिव नहीं हो पाते हैं, वो उनकी डिमांड्स से गिव अप कर देते हैं, क्या सिचुएशन होती है एक्चुअली ना, ये आपको आइडेंटिफाई करना पड़ेगा. और उनकी शायद कोपिंग में कहीं कमी है, या उनके असर्टिवनेस में कमी है, या क्या वो सिचुएशंस हैं, वो सिचुएशंस को इग्नोर नहीं कर पा रहे हैं, क्या और कोई सोशल लीगल तरीके हो सकते हैं उस रिलेशनशिप से अलग होने के.
Like if they are in a husband-wife relationship, but they are not trying to get legally separated, they need to have that relation just because of that society or
कई
family.
बार एक्सेप्टेंस कमिटमेंट थेरेपी बहुत अच्छा काम करती है इसमें. इसके अलावा कुछ और बहुत प्रैक्टिकल सॉल्यूशंस हो सकते हैं. आप ये भी एज थेरेपिस्ट है ना, एक तो हम वैसे में कई बार हम अपने PSW जो सोशल वर्क कलीग्स हैं उनकी हेल्प ले सकते हैं. इसके अलावा जैसे वर्किंग इन डिफरेंट सिटीज है ना, लिविंग सेपरेटली, मीटिंग समटाइम्स. अब आप सिर्फ महीने में एक बार मिलते हो 2-3 दिन के लिए, तो आपकी वो जो झगड़े की फ्रीक्वेंसी है वो अपने आप ही कम हो जाएगी ना. And you are not legally separated also, it is socially acceptable also. So you have to actually, but this solution also should come from the client side. You can suggest many things, so it depends totally on the situation.
It must be more client-centered. From client-centered.
From client-centered perspective. या आप उनको cognitively इतना मजबूत कर रहे हो, या आप उनको कोई और coping सिखा रहे हो, या अगर आइडेंटिफाई कर पाते हैं कि हस्बैंड में कोई पर्टिकुलर साइकोलॉजिकल प्रॉब्लम है, तो क्या हम उनको ट्रीटमेंट के लिए वो कर रहे हैं.
Excuse me.
Yes, please.
In this case, won't we be applying hypnodrama and empty chair technique?
Pardon?
In the case he has given example, hypnodrama or empty chair technique.
Any technique you wish you can use.
Okay, ma'am, one thing I want to know your view about. Nowadays, most of the therapies or clients are taking online session. So in a traumatic state or the thing, what about the online view, like how to handle that thing? Because I'm a hypnotherapist practicing from since 2018, and I've dealt client with traumas and everything. But maybe I'm an old.
Online hypnotherapy भी, I'm not much aware about it.
Yes. Maybe I'm from old school.
Yes. मैंने भी कभी अभी तक ऑनलाइन नहीं प्रैक्टिस किया है ईमानदारी से. But I know people are practicing online hypnotherapy also.
Okay.
So I may not be able to give you, honestly, I may not be able to.
Okay, so any approach that you have heard means online, any of your means
like phone से या उससे instructions देना, especially through video call.
Yes.
People give instructions.
Zoom and all.
Zoom या कोई भी जो video calls है, Skype है, Zoom है, WhatsApp call है. Giving instructions and उनके सामने person कर रहे हैं, but sometimes it becomes difficult.
Yeah.
ना, so I don't have any personal experience, so I can't comment much
Okay,
upon
ma'am.
it.
Thank you so much.
Yes, आप कुछ कह रहे थे sir. Not much as such. The trauma focused is mainly when we are talking about the memories and subjective experiences related to trauma. So we are dealing mainly with trauma. Hypnotherapy can be used for any purpose, even for career enhancement. So when we are talking about trauma focused, our main focus is trauma. We are dealing with the memories of trauma. As I said, we are reframing the memories attached to trauma. We are reframing the subjective experiences, emotional experiences, making the person learn how to deal with those subjective emotional experiences of trauma. That's the major difference. Basic techniques are the same. Not much as such. कई बार लगता है लोगों को, but I think this is one of the most like safest kind of therapy, no side effects. ना कभी कभी हो सकता है अगर आप एक्सपीरियंस नहीं है तो पर्सन को ट्रांस से लाने में दिक्कत हो, या जैसे हमने कहा अगर आपको डील करना नहीं आता उस समय जो एंजाइटी फेस की, फॉर एग्जांपल if a person is reliving the trauma, remembering those traumatic memories and those traumatic emotional experiences, then how to bring that person out of that, वो बहुत इंपॉर्टेंट है. इसलिए मैं बार बार कह रही हूँ कि साथ में सीबीटी या जो भी आप टेक्निक यूज करते हैं, अनटिल अनलेस ये नहीं हुआ तो सिम्टम्स और बढ़ जाएंगे, है ना. पता चला आपने तो हिप्नोथेरेपी की और पर्सन की एंजाइटी या स्लीप प्रॉब्लम्स और बढ़ गई ना, उनको पैनिक अटैक्स होने लगे, अगेन हैविंग दोस फ्लैशबैक्स ऑफ दैट ट्रॉमेटिक मेमोरी. बिल्कुल पूरा बताना है भाई. आज के जमाने में विदाउट परमिशन यू कैन नॉट डू हिप्नोथेरेपी, है ना. यू हैव टू टेक कंसेंट, यू हैव टू टेल द प्रोसेस, एंड ये उनको जरूर क्लियर करना है. जैसा मैंने बोला कि ऐसा नहीं है कि जो भी चीजें आपके माइंड में आ रही है कि आप हम जबरदस्ती आपसे जान लेंगे. आपकी मर्जी है. हो सकता है बहुत से एक्सपीरियंस जैसे मैंने कहा वो कहें मुझे दिखाई दे रहा है, मुझे समझ आ रहा है कि ट्रॉमा क्या था, बट मैं आपको शायद पर्सन का नाम ना बताना चाहूँ. इट्स ओके ना, क्योंकि पर्सन उतना बोल सकता है ना उस समय ड्यूरिंग द. To hypnotherapy only he is going to past life regression. So many things are going on, है ना. It is not parapsychology. His point of view is I think more of psychological. आप उसको कहीं भी रख लो, पैरासाइकोलॉजी, पैरा नॉर्मल, स्पिरिचुअल, जहां मर्जी आप रख सकते हो ना. यू आर फ्री टू पुट इट. टू मी इट इज मोर ऑफ साइकोडायनेमिक. हाँ, for me it is more of psychodynamic. Any other thing? I think 2 o'clock, so I finished. Thank you all. Thank you.
Thank you, ma'am. It's always such a pleasure to listen to ma'am, and the clarity with which she explains the concepts. I think all of you would agree that, it has been an enlightening session. I would like to request Dr. Rushi, ma'am, to facilitate ma'am with the token of appreciation. Dr. Rushi, ma'am. Lights. Can we have the lights also, please? Can I request the management team to turn the lights on? A big round of applause for ma'am, please. A huge round of applause. Let's go on. Yes. Thank you, ma'am. A small request for all the participants. If you haven't signed the attendance sheet today, kindly just come near the stage. We need signatures on both days for us to send this data to RCI. So if anyone by chance has missed out on signing on the attendance sheet today, kindly come in front. We are going to be breaking for lunch right now. And right, can somebody just help me with the time? What? 2:10. All right. So can we all make it back by 2:35, 2:40 maximum? Please be back by 2:40. Thank you, everyone. Yes, there are 2 attendance sheets. Yesterday's attendance sheet and today's attendance sheet. Just in case somebody hasn't signed today's attendance sheet, kindly stay back for just 5 minutes. Thank you. To come and take her next lecture. I think all of us know her by now, but to just introduce her, one, she's been our dear friend as well as ex-colleague, and she works as a consultant clinical psychologist in Noida and is an EMDR practitioner, has been trained, has really taken efforts to train herself and update her knowledge again and again. And we know that, how much she puts in an effort to make her client work most effective. I welcome her on behalf of IBHAS Amity University. Come, Preeti.
आपके लैपटॉप हम स्टार्ट करती हूँ उसके बाद ओके सो हाय अगेन so let me tell like one more self disclosure. So before I started learning EMDR, I got trained in it. My knowledge of EMDR was just limited to that one paragraph in Carson and Butcher. जो शायद एमफिल में भी पढ़ के दिया और मास्टर्स में भी वो शायद PTSD के साथ था जो alright so as I told you 2 years ago I started reading more and more about trauma, and then again through Shalini ma'am got to know about Shalini ma'am was a speaker yesterday, got to know about EMDR too, and she asked us to get trained in EMDR.
यही ना मैम एक मिनट
All right. So this is how my journey, my EMDR journey began. So let's talk about how EMDR came to this world. All right. So EMDR was introduced as EMD. So earlier it was just eye movement desensitization, more or less like a behavioral technique. In 1987, when Francine Shapiro, like it was again, she was having some thoughts in her mind, some distressing thoughts, and she went for a walk. And suddenly she realized that she was no more thinking about those thoughts. Then she thought, what did I actually do that led to disappearance of these thoughts or whatever way she was feeling then? Then she realized while she was walking, she was actually moving her eyes. And then she tried it again. Ki dekhte hain, if it works with other distressing thoughts. And it worked. Then what she did, she tried it on people she knew. And it worked with them too. Then gradually she thought it is actually working. Let me try it on people who are victims or survivors of trauma. Like at that time it was veterans of Vietnam War. And when she tried using this on the victims of the survivors of Vietnam War, the veterans of Vietnam War, I realized that somehow they were able to release their trauma and they were able to get back to their life. Then she tried exploring more and more. So initially, EMDR कहते हैं normal सबको पता है ऐसे ऐसे करते रहते हैं, ठीक है? So it actually did not start this way. She asked people to just move their eyes when they were thinking about that distressing event. Then she realized that not many people are able to just move their eyes this way. Then she thought, let me use my fingers. And she would ask them to move their fingers, move their eyes the way her fingers were moving. All right. And this is how this technique got introduced. Then gradually, more like initially it was more like a behavioral technique, desensitization ho gaya, theek hai? Then she started to research more and more in 90s. And she realized that it's not just limited to it. There is much more to it. She realized that if I ask about their thoughts, their beliefs, okay, and other aspects, and maybe if I work on them too, I'll be able to do much more than just desensitization. And this is when EMDR came. Eye movement desensitization and reprocessing, because it was no more about desensitizing as a behavioral technique. Here it was about changing the cognitions also, changing the narrative, like the way memory, they thought about their memories. So it became eye movement desensitization and reprocessing. So every therapy, every approach is based on some model. This approach is based on the adaptive information processing model. So this AIP model is very important to understand if we want to use trauma focal, like EMDR. Adaptive processing model is a concept of psychological self-healing, a construct based on the body's healing response to physical injury. So the way our physical immune system works, our psychological immune system also works the same way. Somehow, so what happens actually with when some incident happens in our life? If it is a good incident, we are able to reprocess it, and once it is reprocessed, it becomes a part of our experience, our learning, our self-esteem. Even if it is a bad incident, and if we were able to process it well, maybe we were able to process it by talking to people, we were able to process it because dreams are also one way to process the information. And gradually we realize it is no more distressing to us. All right. So what happens when such an experience happens, when or a trauma happens? In general, if a trauma happens, all right, this information processing system, this psychological self-healing, there's a block to it. And because there's a block to it, what happens? We are not able to process it. Our brain is not able to process it. अगर इसको और easiest way में समझें, तो when an incident happens, we get aroused. वो जितने neurotransmitters हैं, जो इसमें implicated हैं, जितने chemicals हैं, सब disbalance होते हैं. As a result of which we are not able to process it well. And that is why what happens, the memory is not processed well. और जब मेमोरी टूटती है ना तो वो कई बार just doesn't get कहते हैं it's not just broken in terms of memory, it has image to it, it has an emotion to it, it has a sensation to it. So वो इस तरीके से fragment होकर के हमारे अंदर save होती है. That is why there are many times when clients they complain of flashbacks. Sometimes they won't even complain about flashbacks. They're like बस एक घबराहट हो रही है, generalized anxiety, and we don't know what's happening to us. Right? So, I'm reading the next. There appears to be a neurological balance in a distinct physiological system that allows information to be processed to an adaptive resolution. Imagine फिर से हमारा सर ने ये कंप्यूटर है और वहां पे एक सॉफ्टवेयर बन रहा है और उसमें बग्स आ गए. बिकॉज बग्स आ गए तो प्रोग्राम ढंग से रन नहीं हुआ, तो वो प्रॉपर आउटपुट नहीं मिला जो मिलना चाहिए था. So when an experience is successfully processed, even if it is negative, doesn't matter, it is adaptively stored, integrating with other similar experiences about self and others. So मेरा self-worth, मेरा self-esteem, my learning, confidence, ये सारे के सारे उन्हीं adaptive experiences का result है. Whenever adverse life situations occur, individuals go to high arousal states. As a result, proper information processing does not occur, leading to inadequately processed and maladaptively stored memories. And these memories, they create networks. So again with EMDR, we say, like when we try to process a memory, we say 1 foot in the past and 1 foot in the present. Present में रह करके हम past को process करेंगे, ठीक है? Any stimuli from the present can get connected to negative experiences in the past, hence triggering a reaction. So sometimes we also know that the situation was not so big, but we reacted so harshly. It was actually not because of this situation. It was actually because of something that we had been carrying with us for so long. So components of memory, as I had just stated, sensory input, images, sounds, smells, tastes, thoughts, emotions, body sensations, and beliefs. So again, so there are two kinds of memory networks. One is adaptive and one is maladaptive. So what happens, like as the name suggests, when we are able to process something, it goes to an adaptive memory network. When, because of certain reasons, because we were so aroused due to that trauma, we were not able to process it, it went to our maladaptive networks. Okay. So what we are trying to do in EMDR, maladaptive network से memory को निकालेंगे, उसको present में process करेंगे ताकि वो ढंग से process हो, उसका जो positive है, ठीक है, वो हमारे adaptive network में जाके store हो सके. It's a bit different from the traditional therapies that we perform. I hope you're able to understand it. So ये simple जो हमेशा videos में दिखता है, this is called bilateral dual attention stimulation. And you know, again in a REM sleep, dream sleep, the same thing happens. वो saccadic moment हमारे उसमें भी होता है, इसीलिए कहते हैं कई बार जो हम दिन भर में process नहीं कर पाए वो हमारी नींद में हो जाते हैं. इसी मॉडल पे या इसी assumption में ये bilateral dual attention stimulation based है. Okay, because we are moving our eyes and it doesn't only happen through this. ठीक है, we can use these are called butterfly taps. We can use this too. Okay, we can use sound also. So it's like bilateral. Both sides of the brain, they are now, this sides are active. Because they are active, the information processing is open. And then we bring the material from the past. So, because COVID के time पे तो everything went online. तो उस वक्त this did not help. So what we were mostly using, we were using this, or we would ask our clients to place 2 post-its at the opposite end of the laptop. और उसके बाद to do the eye movements. So again, EMDR is based on 3-pronged protocol. तो केवल इतना ही नहीं कि हम पास्ट में प्रोसेस किया और खत्म हो गया. Past, present, and how we are going to adaptively manage the future situation. So for example, there was a person जिसको कि there was fear of dog. All right. So पास्ट में जहां से वो फियर आया था, प्रेजेंट में जो अभी हो रहा है, देन फ्यूचर में वो कैसे उसको मैनेज करेगा. वी क्रिएट फ्यूचर टेम्पलेट्स टू. So the basic components of EMDR processing targets. All right. So first is image. So a very simple question. Again, EMDR actually is in form of a proper script. One has to use the script while doing EMDR. Okay, so I did not want to include those scripts. It was just 1.5 hour session, would have become extremely cumbersome, tiresome for you guys. Second, वो सारी scripts copyright होती हैं, which I can't use here. All right, so it's just a summary of, just an introduction of what EMDR is and what happens within it. Okay, so imagine if there is my client told me that the experience was, I was with my teacher, my tuition teacher, and I had obtained 7 marks, and suddenly my mom came and she said, ये बस आपको ऐसे ही कर रही है, पढ़ती नहीं, she's so stupid. ठीक है, this is the experience. Now I'll ask, what is the worst part of the experience for you? Because again, वो तो बहुत बड़ी मेमोरी है, उस मेमोरी का क्या वर्स्ट पार्ट है आपके लिए? वो इमेज बन जाएगी हमारी. ठीक है, मे बी उसने बोला माई मॉम सेड स्टूपिड, और द वे शी स्टूड नेक्स्ट टू माई ट्यूशन टीचर, दैट बिकम्स अ मेमोरी. सेकेंड कम्स नेगेटिव कॉग्निशन. आई टोल्ड यू ना, अब ये केवल डिसेंसिटाइजेशन नहीं है, वी वर्क ऑन द कॉग्निशंस ऑल्सो. सो व्हेन यू थिंक ऑफ द वर्स्ट experience now, what does it tell you about yourself, or what belief that you have about yourself now? So even if it happened in the past, abhi aapko apne bare mein kya belief aa raha hai? So she may say, I am not good enough. So that is the negative cognition that I found. Then it is because हम क्या कर रहे हैं, हम हमेशा वो करते हैं ना कि like negative को पहले desensitize करेंगे और positive को install करेंगे. So I'll ask her, instead of I am not good enough, what would I like to think about myself, believe about myself? She may say, I'm okay as I am. She may. It is a positive statement. It can never be I am not I'm not good. Like I am bad, I am not bad is never a positive cognition. Positive cognition is always positive. So if the person says that I am dirty, ठीक है, positive would be I am clean. I am not dirty would never be a positive cognition. It's always positive. So then what we say, we ask the next question, that is the validity of cognition. All right. So validity of cognition के लिए there is a rating scale 1 to 7. So we ask on a scale from 1 to 7, where 1 feels completely false and 7 feels completely true. ठीक है, how true do the words I am okay as I am feel to you now? ठीक है, client will tell me कि मुझे 5 ही लग रहा है, मुझे 4 ही लग रहा है. I'll note it down. Then the next step is emotion. When you think of the experience and the words I am not good enough, what emotions do you feel now? So can be anything. Sometimes they say we are feeling very sad, angry, disappointed, can be anything. All right. So once we have found out the emotion, the next part is distress. इस एक्सपीरियंस से मुझे डिस्ट्रेस कितना हो रहा है? तो डिस्ट्रेस इज 0 से 10 के बीच में. ऑन अ स्केल फ्रॉम 0 to 10, how much disturbing this experience feel to you now? All right. So 0 से 10 के मार्कर में मान लो उसने 4-5 कुछ भी बोल दिया, we note it down. And then we come to the last part, because trauma body में हमेशा स्टोर होता है और वो कुछ ना कुछ कर रहा होता है. तो where do you feel it in your body? So they may say in a chest, in my hands, anywhere. सो ये हमने सारा का सारा बेसिक कंपोनेंट्स बना लिए कि अब इसमें हमें काम करना है. इसमें हमें इमेज मिल गई दिमाग में जो सबसे ज्यादा फंसा हुआ है, नेगेटिव कॉग्निशन मिल गया हमको कि वो क्या, उसके पीछे बिलीफ क्या था जो फंसा था. हमको ये भी पता चल गया कि इस बिलीफ को मुझे वॉश ऑफ करके ये बिलीफ इंस्टॉल करना है. देन आई फाउंड कि भाई वो बिलीफ पे उस इंसान का भरोसा कितना है. ठीक है. देन इमोशन वो क्या फील कर रहा है, देन उसकी डिस्ट्रेस कितनी है, और बॉडी में वो कैसे फील हो रहा है वो ट्रॉमा या वो डिस्ट्रेस. सो लेट्स टॉक अबाउट द कॉग्निशंस नाउ. ठीक है. कॉग्निशंस को EMDR ने क्या किया है ना, 4 प्लेटूज में डिस्ट्रीब्यूट कर दिया है. पहला रिस्पॉन्सिबिलिटी का प्लेटू है जिसमें कि उसने 2 चीजें डाली है, डिफेक्टिवनेस और एक्शन. डिफेक्टिवनेस में पर्सन बोलेगा शायद आई एम बैड. ठीक है. एक्शन में आई डिड समथिंग बैड और समथिंग, मतलब कहते हैं ना, एक में गिल्ट प्रोवोक हो रहा है और एक में शेम प्रोवोक हो रहा है. दैट्स द डिफरेंस बिटवीन शेम एंड गिल्ट ना. शेम सेज आई एम बैड, गिल्ट सेज आई डिड समथिंग बैड. Then safety vulnerability, the second plateau is safety का या vulnerability का, जिसमें कि the person will say I am not safe. ठीक है. I am vulnerable. ठीक है. जिसमें ये क्लियरली समझ में आ रहा है कि सेफ्टी, उसको सेफ्टी से रिलेटेड उसकी थॉट प्रोसेस में परेशानी है. Then it is power and control. Okay, so it's like जहां पे उसको पावरलेस फील हो रहा है, उसको ऐसा लग रहा है कि मैं कंट्रोल में नहीं हूं. सो दीज काइंड ऑफ कॉग्निशंस विल अकर. इट्स लाइक अगेन आई एम पावरलेस, आई एम नॉट अंडर कंट्रोल. Then it's connection and belongingness, the fourth one. So this fourth plateau was added on after some time. I think it got added only few years ago. पहले ये 3 ही थे, जहां पे cognitions क्या होंगे, I am alone, okay, I am invisible, nobody is around me, or it can be anything. तो इन plateaus में normally हमारी information जाती है. जैसे I had a client, unfortunately, like we all know in India there are many families who always compare girls and boys. So this client of mine, again the same client, it's the example of the same client जिसकी मम्मी ने आके बोला इसे कुछ नहीं आता है. ठीक है. In some other the ultimate cognition was I am unwanted. So that was her cognition, and that cognition was so strong कि वो हर जगह फील हो रहा था. मतलब ये है कि अगर वो एक गैदरिंग में जाए और उसको ऐसा लगे, पहले तो ये कि आई हैव टू प्लीज एवरीवन. ठीक है. एंड इफ शी इज नॉट एबल टू, इफ समबडी इज नॉट पेइंग द राइट अमाउंट ऑफ अटेंशन, आई एम अनवांटेड. सो दिस इज हाउ दैट कहते हैं ना, बिलीफ सिस्टम वाज गेटिंग प्लेड in the current situation and how it was formed. So these are the, so what happens in EMDR? EMDR हमेशा की स्टेज में होता है. हम ऐसा ही नहीं कि किसी भी क्लाइंट को उठाया और EMDR कर दिया. We have to first see whether our client is able to sit for a session of EMDR or not. Reason? Because sometimes trauma, we don't want our clients to get re-traumatized. Okay, we don't want to work on them using EMDR until and unless we know they have the required resources with them. Because when we are going to process the memory, for example, my client felt that I'm all alone. I'm happy that I had created a resource earlier, her grandfather. All right. Because her grandfather was always a support system. So I just think of your grandfather. Grandfather was a resource there. Okay. So as she thought of the grandfather, she felt that no, she's not alone anymore in the process of EMDR. So imagine if I had taken her to that incident without creating that resource for her or strengthening that resource for her, I think I would have re-traumatized her, or I would have traumatized her more than what she was already feeling. All right. So again, not every client is a perfect fit for EMDR until and unless they are stable in the present. Which means वो जो सवेरे मैंने सारी की सारी चीजें की थी वो प्रेपरेशन में जाएगा. All right. उसके साथ साथ मैं हिस्ट्री लूंगी, मैं उसके स्ट्रेंथ जानूंगी, उसके वीकनेसेस जानूंगी, उसके रिसोर्सेज जानूंगी. I'll try to conceptualize the case कि हो क्या रहा है, कौन से इंफॉर्मेशनल प्लेटू में जाकर के वो अटका है मेरा क्लाइंट. Sometimes with single trauma it's still easy because हो सकता है एक ही इंफॉर्मेशनल प्लेटू में हो, एक ही कॉग्निशन हो, बट विथ कॉम्प्लेक्स ट्रॉमास spread, it's just totally spread. Okay, तो उस सारी चीज को कंसेप्चुलाइज करना कि what's actually happening with my client. If my client is dissociating often, I just can't start EMDR. I have to first stabilize my client. और उसके लिए हो सकता है कई सेशन चले जाएं. But when I realize that yes, this is the final time कि अब मैं उसकी मेमोरीज को रिप्रोसेस कर सकती हूँ, शायद that is the time when I start EMDR. और जब हम EMDR स्टार्ट करेंगे तो हम सबसे पहले एक टारगेट पूछेंगे, क्या टारगेट है हमारा. ओके, वो टारगेट ये हो सकता है that I want to maybe work on my confidence, as simple as that. It can be I don't want to feel threatened. Okay, then I'll ask them. जब मैंने कहते ना पूरा स्टेबलाइजेशन सब कुछ हो गया, अब मैं टारगेट में जा रही हूँ, then I'll ask them about one or few recent experiences when they felt this way. अब उन्होंने मुझे वो recent experiences बता दिए. Maybe they told me that I had gone to deliver a lecture and when I saw such a huge crowd, I was threatened. I was so afraid. That became my first recent experience. I may ask them, are there other experiences in your life where you felt like this? Recent life when you felt like this? तो वो शायद कुछ और बताएंगे. What we do next? एक recent experience को पकड़ेंगे, उसको हम dissect करेंगे. Dissect किस फॉर्म में करेंगे? More or less इस फॉर्म में. More or less not exactly the same way, but more or less the same way. क्या इमेज दिख रही है, उस इमेज को पकड़ के बताओ आप अपने बारे में क्या थॉट आ रहा है, बॉडी की सेंसेशंस देखो, इमोशन देखो, और देखो इसको फ्लोट बैक कहते हैं. क्या लाइफ में पहले भी मेरे साथ ऐसा कभी कभी हुआ था? So they'll remember few more memories. We'll jot them down. All right. उसके बाद once we have gotten a list of memories, we try to reach the touchstone memory. So what is the touchstone memory in terms of EMDR? The first memory from which this trauma began. All right. Then again, we got detail of the memories, the trauma memories. Now we find out what resources do we need more. Maybe हमने stabilization में इतने resources नहीं बनाए थे, शायद हमको और resources की जरूरत है, शायद हमें compassion की जरूरत है, because compassion एक ऐसी एक वो है जो कि trauma survivors में नहीं होता है, self compassion. And इस तरीके से और भी जो resources जो हमें लगता है हमारे clients में नहीं है, हम उसको पहले ढूंढेंगे, पकड़ेंगे क्या क्या नहीं है. We create a safe, calm place too. All right. Once we have created all that, अब हम मैदान में उतर जाते हैं to do the real work, that is desensitization. All right. So assessment के बाद we came to the fourth step, that is desensitization. एक memory को लेते हैं, उसको पूरा process करते हैं. Again, you know, it's like हल्का सा example. Bring to your mind the memory, the worst part, the negative belief. ठीक है. Notice where you are feeling it in your body and go with my fingers या फिर butterfly taps, जो भी हमने decide करके रखा है पहले से. ठीक है. उसके बाद क्या है कि हम लोग taps के बाद what we do, we ask them, what are you noticing? Take a breath, let it go. Which is a signal that I have to take a breath, I have to let it go, and I have to halt. Then, what are you noticing? They may say, I can feel heaviness in my chest. Go with that, with your butterfly taps or whatever mechanism we are using. Will you do the same thing again? Take a breath, let it go. Then we'll ask, what are you noticing? Suddenly, I realized my mom had rushed into the room. Notice, go with that. All right. और ऐसे करते 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 we come to a point जहाँ पे we try कि वो सारा का सारा मतलब वो कहना है now I'm feeling okay में आ जाए. ठीक है. So once it is done, it's not as easy at this as I am saying about like EMDR, but with few clients it sometimes is. किसी के संग बहुत ज्यादा लगना, मतलब कहते हैं ना जिसका अगेन कॉम्प्लेक्स ट्रॉमा है, वहां पे हमको बहुत सारे इंटरव्यूज यूज करने पड़ते हैं ताकि हम उनको एक अडेप्टिव प्रोसेसिंग की ओर को ले जा सकें. So once we have installed, so desensitization happened, जिसमें क्या था कि वो जो नेगेटिव थॉट था दैट आई एम नॉट गुड इनफ, क्लियर हो गया है. नाउ आई आस्क द इंस्टॉलेशन ऑफ द पॉजिटिव बिलीफ. Do the belief, to the positive belief, I am okay as I am still fit, or there is another positive statement that fits even better. कई बार clients बोलते like one of my like Preeti, it's not just that, it's capable, I am capable and strong. For some, पहले it was just capable. So we use it. Now bring the experience and the positive belief, ठीक है, together, and we find out the VOC, the validity of cognition, कि वो 0 से 7 के बीच में कितना ज्यादा उस experience के साथ लग रहा है that I'm strong enough or I'm okay as I am. They may say it's a 6. Hold the experience and the belief, positive belief together and go with your butterfly taps. All right. In this process, they take a breath, let it go. Now what will happen? They'll again say, Preeti, you know, I feel powerful. Or they may say, Preeti, there is something, I can feel some headache. ठीक है, नोटिस एंड गो विद दैट. तो जो भी हो रहा है नोटिस एंड गो विद दैट, नोटिस एंड गो विद दैट. धीरे धीरे करके वो ट्रॉमा जिस तरीके से बॉडी में स्टोर्ड है ना, वो प्रोसेस हो जाएगा. इसमें भी इंस्टॉलेशन में भी कई बार होता है, कई बार तो उसी में सारा हो जाता है, इंस्टॉलेशन में बस स्ट्रेंथन हो रहा होता है, बट समटाइम्स कुछ रेमिनेंट्स रह जाते हैं जो इसमें क्लियर होते हैं. देन कम्स बॉडी स्कैन. ट्रॉमा हमेशा कहते हैं बॉडी कीप्स द स्कोर, और एंड में बॉडी से निकलता है. तो इसीलिए हम बॉडी में फिर जाते हैं, हम पूछते हैं ऐसी. नाउ कीप इन माइंड द मेमोरी एंड द पॉजिटिव बिलीफ दैट आई एम ओके एज आई एम, एंड देन स्टार्ट स्कैनिंग योर बॉडी स्टार्टिंग फ्रॉम द टॉप ऑफ योर हेड एंड वर्किंग डाउनवर्ड्स. एनी प्लेस यू फाइंड एनी टेंशन, एनी अनयूजुअल सेंसेशन और हेवीनेस, टेल मी. हो सकता है अगर वो ट्रॉमा पूरा प्रोसेस हो गया तो बोलेगा आई फील स्ट्रॉन्ग, आई फील ऑल काम, क्लियर. अगर वो कंप्लीटली प्रोसेस नहीं है तो हो सकता है वो बोले कि यहाँ पे मुझे कुछ फील हो रहा है. नोटिस एंड गो विद योर बटरफ्लाई टैप्स, नोटिस एंड गो विद योर बटरफ्लाई. तो जब तक हम पूरा क्लियर नहीं कर देते हैं कि वो बोले मेरी बॉडी में मुझे कुछ नहीं फील हो रहा है, आई एम सो कूल सो चिल, तब तक मैं नोटिस एंड गो विद दैट करूंगी विद माई टैप्स और वट एवर मैकेनिज्म आई एम यूजिंग. नाउ वी क्लोज द सेशन. ठीक है, क्लोज करने के बाद हम क्लोज में ही नहीं छोड़ते हैं. ओके, हम क्लोजिंग का भी 2 तरीका होता है. एक क्लोजिंग द इनकम्प्लीट सेशन हो सकता है, उस 1-1.5 घंटे में मेरा मेमोरी प्रोसेस नहीं हुई थी, तो वो होगा मेरा क्लोजिंग द इनकम्प्लीट सेशन, जिसमें कि मैं उनको, चाहे वो क्लोजिंग द कंप्लीट सेशन हो चाहे वो इनकम्प्लीट सेशन हो, मैं उनको ये बताऊंगी कि यू मे गेट एनी थॉट्स, any insights, dreams, physical sensations, or emotions. ठीक है, just keep a note of that, like in this week, just keep a note of that and we'll discuss about it in the next session. Right? और हम ये सब, क्योंकि होता क्या है ना कि हमारा ऐसा नहीं कि वो 1 घंटा सेशन में बैठे और वो इंफॉर्मेशन प्रोसेसिंग खुल गया तो खुल गया है. So even if I have left the session, my brain is still active. So ऐसा हो सकता है कि वो मुझको उस वीक में किसी ना किसी तरीके से फील हो. पॉजिटिवली भी हो सकता है कुछ नेगेटिवली भी फील हो. जैसे एक बार मेरे क्लाइंट के संग क्या हुआ सेशन में, ये बहुत मजेदार था. अचानक से ना, दैट वाज आई थिंक मे, एंड दिस क्लाइंट इज फ्रॉम दैट पार्ट ऑफ इंडिया जहाँ पे मई में बहुत बारिश होती है. ठीक है, तो हुआ क्या, उस बारिश में बीवी और बेटा दोनों बीमार हो गए. तो सेशन में ये आए, हमने सेशन आधा किया, अचानक से स्टार्टेड टेलिंग प्रीति मुझे बहुत इचिंग हो रही है, बहुत अजीब हो रहा है. तो हम दोनों ने यही सोचा कहीं ऐसा तो नहीं कि इन्हें भी कोल्ड स्टार्ट होने वाला है. तो मैंने कहा चलिए काम करते हैं, थोड़ा सा स्टेबलाइजेशन होता है क्या. मैंने कहा लेट्स डू द सेम थिंग नेक्स्ट वीक. नेक्स्ट वीक आई, प्रीति आपको पता है मेरे को कुछ नहीं हुआ लेकिन मेरी नाक खुजला रही है तब से. So when we met the next week, we worked on it. And I just asked, what emotion is it? कहते ना, just notice this sensation. We sometimes ask questions. What emotion does it feel like? Preeti, it feels like shame. ठीक है, go with that. We went with that. धीरे 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 करके that particular day वो itching चली गई. So इतने अमेजिंग वे में कई बार हमारी बॉडी ने चीजों को स्टोर किया होता है और वो जब निकलती है ना, oh, and EMDR is beautiful. Alright, then re-evaluation happens. So मान लो मेरी मेमोरी क्लोज हो गई है, भले वो इनकम्प्लीट भी थी, लेकिन अब मुझे नेक्स्ट सेशन में मिलना है, तो फर्स्ट आई री-इवेल्युएट. ठीक है, कि पूरे वीक कैसा रहा मेरा, अगर मैं पुराने वीक से अपने आज के वीक को कंपेयर कर रहा हूं तो मैं क्या डिफरेंस देख रहा हूं, क्या मुझे कोई नए थॉट्स, कोई नए इनसाइट्स आए हैं. ठीक है, और उसके बाद अब भी जब उस मेमोरी के बारे में सोचता हूं तो मुझे क्या होता है. ठीक है, एंड देन if the memory has been thoroughly processed और re-evaluation में लगता है कि it's the distress rating is 0, body scan is clear, we pick another memory. But if we realize re-evaluation में कुछ निकला है, we go back. जब तक पूरी body से वो sensation ना निकल जाए, we keep on following the whole process. So this is, I think, EMDR in a gist, जो मेरे को लगा कि the simplest way to help you guys understand the process of EMDR. Is there any question? Yeah, please. Closing the complete session. Instruction दोनों में more or less same है. Incomplete session में हम ज्यादातर ये कि how are you feeling now? You did a good work today. How are you feeling now? कुछ इस तरीके से. Complete session में तो हो ही गया है तो. Depends on your client. It all depends on, like single trauma तो कई बार 2 सेशन में भी साफ हो जाएगा. ठीक है, लेकिन अगर ये कॉम्प्लेक्स ट्रॉमा है तो हो सकता है 1 साल भी कम पड़े, बिकॉज इतना कॉम्प्लेक्स और कितने मेमोरी नेटवर्क है जो आसपास में है. नॉर्मली 90 मिनट्स मानते हैं, बट 60 मिनट्स इज, कहते हैं ना, हाउ यू आर मैनेजिंग योर ओन सेशन, मोर और लेस.
मैम, इसमें पेशेंट को, क्लाइंट को घर में कुछ एक्टिविटीज करने को दी जाती है जब तक वो घर में रहता है, जैसे उसका नेक्स्ट सेशन अगर 1 वीक या फिर आफ्टर 10 डेज के बाद.
2 मेन चीजें हैं. ठीक है, पहली चीज तो यही है कि वो अपना, जो मैंने आपको बोला, वो नोट करो सारा का सारा, और अगर जरूरत हो तो यूज योर कोपिंग स्किल्स. दैट्स इट, नथिंग मोर. यूज योर कोपिंग स्किल्स, और वो कोपिंग स्किल्स हमने स्टार्टिंग के सेशन से तैयार कर रखी हैं, इसीलिए हम मांगू से. हाँ, थैंक यू मैम.
Good afternoon, ma'am. Ma'am, just one question. Any contraindications where we can't use EMDR, like for the patients of epilepsy or any other neurological conditions or any other contraindications?
The only thing is that we need to keep in mind the stability of the client. Stability of the client. अगर वो stable है तो इतना प्रॉब्लम नहीं है, लेकिन हाँ वर्टिगो इतना ज्यादा है जो उसको इतना ट्रबल कर रहा है तो विल नेवर यूज इट. बिना स्टेबल क्लाइंट के, लाइक चाहे वो किसी भी रीजन से अनस्टेबल हो, अगर वो अनस्टेबल है तो वी विल नेवर यूज EMDR until and unless we feel that stabilization has happened.
Okay, so for example, a patient with epilepsy, patient has come to you, is stable. But has there been any literature or your experience wherein it has kind of induced a seizure or
not? Like I haven't gone through any literature, so I would not be a good person to answer this question.
Thank you, ma'am.
Thank you.
May I add?
One more question is here. Yeah, we can use स्टेबलाइजेशन. अगर उनमें रिसोर्स बने हैं और स्टेबलाइजेशन है तो वी कैन यूज इट ऑन एनीवन. Sometimes there are short protocols also. It's not just EMDR. Sometimes there are EMD also. where we don't go to the memory lane. We ask them to come back to the experience, and go with your types, come back to the experience. उससे वो experience desensitize हो जाता है. तो शॉर्ट में वी कैन यूज, लेकिन बॉर्डर लाइन में ज्यादातर ना वो बहुत अनस्टेबल होते हैं. जब तक हम लोगों ने उसको मेंटेन नहीं किया है ना, लाइक उनका वो विंडो ऑफ टॉलरेंस में आना जरूरी है.
Preeti, is it okay if I add something? This is Shalini online.
Hi, ma'am.
Hi. Can I respond to that question just to add to what you're saying?
Yes, ma'am.
So the question is the contraindications, epilepsy or anything. So see, it's always good to take history. If you think epilepsy, any seizure has been triggered with the patient, if looking at any fast rhythmic movements, then EMDR also has the option of doing very slow eye movements. So you will choose that. The second contraindication sometimes is because the trauma can completely get healed with EMDR. And there are situations, for example, if a woman has filed a case of domestic violence, and if you are processing her memories of domestic violence, then what sometimes can happen is that she goes to the court of law and she says, no, nothing is disturbing me because it is not triggering her at all now. So sometimes if litigation is going on for the abuse that she wants to process, we might want to just hold on. And after her case is over, you can work with some of those memories.
Thank you, ma'am. Yeah. You need to, yeah, I think you should. So there's this association, EMDR India Association. They provide proper training. All right. So you need to get trained through it, then you can use it. Just type EMDR India Association. Yes. EMDR India Association, they are providing the courses. I think after every 2 months, they have a new batch. EMDR India Association.
Thank you, Preeti. Now I'd like to request Ms. Rashmi Pandey ma'am to kindly facilitate, and Dr. Rushi to provide her with the sapling. Prerna, okay, Ms. Prerna to provide her with the token of our respect and love. Thank you. A big round of applause for Preeti, please. Lights. Can I request the management to turn the light on? C Block Auditorium management people. I hope everybody's feeling awake and well. Yes? Can we have a bigger round of applause for Dr. Rushi, ma'am, who's the organized chairperson for this conference, this national seminar, as well as she, I think many of us have heard her name and listened to her. She has illustrious career of 20 years in clinical psychology field. She has been head at various institutes and with has been associated with various hospitals, specifically being Dr. Ram Manohar Lohia Hospital before joining us as our director at IBHAS, Amity University. We are very, very privileged to have her with us. We are learning a lot, and it's a pleasure for me to invite her for her topic, trauma-informed care for schools. She has tremendous interest in school psychology and education-based work. Ma'am, please.
So, good afternoon, everyone. Are you feeling because sometimes it's difficult to be teachers, school teachers, school teachers purpose of teaching this topic in the schedule was only that we were just thinking how we can help the teacher. Because ultimately what happened that the childhood early experiences play very important role in the trauma basically that lead to traumatic impact on the brain of the child, and that leads to many mental health issues in the adulthood, right? So that was the whole. It's not moving actually. Can anybody help? So you must be thinking that why to, having this session in the trauma informed care seminar. Any idea? Yeah.
Things are happening,
So
especially with children
why
now.
we haven't invited the parents? Why only the teachers and the school counselors? See, because
Ma'am, because we have first line of
yes. So in terms of caregiving, the parents play a very important role. But school is that's an organization where they are spending more than 6 to 7 hours daily. And nowadays, if you will see the schedule of any child or any adolescent, they will say that hardly we get any time to have interaction with the parents. So, जितना teachers को पता है depth में एक बच्चे के behavior के बारे में, parents will not be aware of those dynamics of a child. You take the example of any anxiety, any fear, if there is any depressive symptoms in the child or any aggression, yeah, most likely the parents, they often report, but the other symptoms, they are usually identified primarily in the school, because the teachers are the one, or the school counselor, who are closely associated with the child. They are observing their behavior for more than 6, 7, 8 hours. So they have adequate time to identify those mental health issues, or they can identify the trauma as well very easily. So it's very much important for the teachers and the school counselors
for being aware of that trauma informed care in the school. We don't always know what our students are dealing with their lives. We need to see their difficulties through a different lens. So since yesterday we are talking about trauma lens, and trauma informed care. So no matter what our role is in the school, it is important that we all adopt a trauma informed lens. So have you ever realized that nowadays, because of so many interventions, the government has also become very alert nowadays. So in the last couple of years, like I've been associated with the Ministry of Education. So we have developed the module and we have implemented, field tested that module on more than 150 schools and the teachers and the school counselors primarily. So what we have done, we have trained the teachers so they can identify the early flag signs of a child for any mental health issue. We have not trained them. We have not labeling the students by saying that, we are giving a training for the mental health disorders or psychiatric disorder. It's just the mental health issues, right? Though we are covering all the disorders, that because the stigma is associated with that, so we are not calling. And then teachers will say that, that is not our job. You please appoint any clinical psychologist or a psychiatrist for that purpose. So, and that actually happened. That why we are going to have this extra training. Initially, there was a lot of reluctance from the teachers. We are already overloaded with so many things. But when they undergone that training, so they found that quite interesting. And they said that it is not only important in terms of, helping the student in a classroom. It is very much important even in our personal life as well, while dealing with our kids at home or dealing with any person. Because whenever you are, aware of those mental health issues, so that is generalized to each and every person of any age group of any gender. So, but when it comes to the trauma informed care, you will realize that even the teachers, they are not very much aware that, so if the child is quite sad in the classroom, so they don't reach to that level, that what actually has happened with the child. And sometimes they just report that there are few kids in the classroom who have become very withdrawal, who are showing very poor performance in their academics, and they are not able to maintain their relationship or friendship, in the classroom. So the poor peer group interaction, the poor teacher student interaction, but they are not able to reach to that level. So what kind of atmosphere should be there in the school, we'll be discussing later in the presentation. But right now we just have to focus from the teacher's perspective or a school counselor's perspective, that we need to change our approach to identify that sensitive part, so there's a lot of sensitivity and compassion is required when it comes to the trauma informed care. So so it was started in the discussion from the Dr. Bandyopadhyay in the inauguration, and many speakers, they brought this issue that rather than saying, what's wrong with you, why are you behaving like that, can't you be, these are the versions what actually the students in the OPD, in the child guidance clinic, they have reported us that, I am behaving like that because, my mother says me that what's wrong with you, why can't you be a normal child? So because she is considering me abnormal, so that's why I'm now behaving like that. So that is generally the approach of teachers also. So we should be very sensitive, we have to be very mindful for our communication, whether we are dealing the children and its adolescents in our OPDs, in our clinics, we are dealing them at home or in the school. So same kind of approach should be adopted. We have to look for the behaviors. What are the behaviors which are quite deviating from the, that normal quantum. So what happened that if you think that the child is quite anxious or depressed or fearful, apprehensive, these are the indicators
that you have to intervene in. So apart from the behavior, what you need to see, you have to see their body language. Sometimes they are not so verbal, so they cannot report you directly. Most of the time, if you will see, you take the data from any OPD, any child guidance clinic, it is very rare, very rare, that the child is coming to you with his or her problem. Usually what happened, they have been either referred by the teachers or the parents. They are bringing them with some problems. And what kind of problems? Not internalized problems, those only for the emotional behavioral issues which are manifested, which are quite obvious in the classroom. So if they are disturbing the class, or if they are not performing good in their academics, generally these are the two indicators why they have been visiting the clinics. But what about the other parameters? If they are depressed, if they are irritable, they are not happy, so they that doesn't attract the teacher or a parent that they need a intervention. They need some kind of support from the teachers or from the counselor or from a therapist. So that was the whole idea, that how to make them oriented, how to make them aware, so they can pay attention to everything, that the behavior of a child, the non-verbal behavior of a child, and then the overall environment they have to see, that what is the overall environment at home, how is the parenting style at home. So if a child is coming with the behavioral issues, usually what happens, that we always look for the parenting styles, right? How is the interaction pattern between the parents? And that is the reason that every time, the most important reason for dropout in the child and adolescent cases, what is the reason for the dropout? Anyone who is dealing with these age range? Parents denial, yes. Neglect,
not being heard.
Basically, they simply say that, we went with the hope that, they are going to have some intervention with my child. But here, they are just doing the counseling for me. So it is only us who have to. So if they are taking session for 1 hour, so they will take session half an hour for us. So they cannot even tolerate that part. Why to spend that half an hour? So why to bring that change? Why we have to bring that change in ourselves? Why not only the child? So that is often, primarily, that is the only problem, that is the lack of awareness, that lack of understanding into those. Another thing is that trauma lens, what you need to do, you have to explore. You have to explore that what actually has happened to the child. Why he is behaving like that, and what kind of help you can provide to the child, right? And then you have to look for the unmet needs. What do you mean by unmet needs here? Emotional needs. So if there is any sort of neglect in the family, that is also a kind of abuse. So we talk so much about the verbal abuse, physical abuse, or sexual abuse, but very rare we give attention to that emotional abuse. But in India also, if you will see, in every second or third family, the children and adolescents, they report that kind of abuse. So you will find that abuse everywhere, and that is also one of the important reasons for their trauma, and that further emerge to various emotional and behavioral and academic issues for the child. And then, of course, through that lens, we can provide them the support. Coming to the adverse childhood experiences, we have I think now by the end of the session, it's not required to go into the detail. All of you are much aware that what kind of adverse childhood experiences are there, which are very common. But coming to the school, see, physical abuse is very common. Even the sexual abuse is also very common. It is hidden, it is underreported. Emotional neglect is something which usually, that is ignored by even the clinicians. So whenever you are taking the history, that is very important part, that you have to go into the detail of that history. And coming to the mental illness in the family or any kind of addiction within the parents. So these are the other common factors which also play very important role, which are considered to be the adverse childhood experiences. And apart from that, the parents say that, we are not the one who are saying anything to the child. We are fighting among ourselves. So it's a matter between husband and wife. So we are not saying anything. So they do the argument, but they doesn't realize that child is getting affected. So witnessing violence is also something which is very important. And that these all adverse childhood experience have been linked to the risky behavior, the behavioral issue, academic issue in the child. They play important role in their low self-esteem. Of course, if they will not be confident, they will not be having good coping strategies, they will have low self-esteem, then those childhood experiences affect them more than expected if you will compare from a child who is not who is not having that much of emotional regulation. So coming to the school part now, can you tell me that what kind of experiences are there in the school which play very important role, or which are considered to be the very common traumatic factors for a child? Bullying, yes, bullying. So I'm just coming to just tell me that Raghav is a 14-year-old. Just listen carefully and then tell me that what can be the probable reasons for all this behavior, or how you can diagnose the situation. So Raghav is a 14-year-old boy having difficulty in academics. The teacher used to punish him often for his poor performance, and this is the real case I'm giving you, it's not a hypothetical case. The teacher used to punish him often for his poor performance in the academics. He was often caught being angry with classmates also. Teacher used to think that intentionally he's performing poor in academics, as in general he was having average intellectual functioning. This classmate, one of his classmates started making fun of him. Gradually they started pushing him during the break, teasing him, throwing objects like pencil, chalk, paper on him during the class hour also. Which made him felt very angry and irritable during the class. And often he used to get punishment from his teacher for not completing his homework and getting angry. His younger sister is also very bright, and she's very bright in studies. And also she used to be appreciated by the parents and the relatives for being good in academics. And parents were getting critical toward him day by day and used to humiliate him in front of others for his poor academic performance. He has no friend in the whole class. I think many of you must have seen these kind of many cases in your practice. So can you just let me know that what do you think is Raghav is facing? Yes? What? Just learning disability. Anyone else? Very nice. Yeah. Good. Anyone else? Feeling of rejection, emotional abuse, poor self-esteem. Yes, very nice. Yeah? Yes, scapegoating. So can you see that there are so many pressures from the outside world? Chota sa Raghav, or kitni sari, there is so much of criticism, so much of bullying from the parents, bullying from the teachers, bullying from the peer group. So can you just imagine the situation of that child? And that is so common. You won't believe. I'll tell you one real life experience. I will not name the name of the school. So there is one patient mine. She is now, she has just completed her class 12, but she was into severe depression since class 5 or 6. So she just came to me 1 year back, and the mother said that, she is having above average IQ, but in spite of that, she is very poor in her academics and all. She doesn't want to do any work at home. Also, she is being ridiculed or humiliated or exploited by the grandparents, parents, sibling, because she is so slow. Nobody is able to understand what is wrong with the child. And, she has spent all her life, all her schooling years like that only. With the low performance everywhere, and by having critical comment or facing the humiliation, exploitation from the outside world, whether it is the siblings, it is the teachers, parents, relatives, grandparents, from everywhere. And when she was talking to me, she was during the session, she told me that, ma'am, what used to happen when I was in class 6, because I was very fat. So one day my teacher said that and I was not good looking also, because I'm very fat, I'm not very good looking also. So people used to make fun of mine. So my teacher used to tell other, the students in the class, if you will not perform appropriately or if you will not complete your homework, I will let you sit with this girl. So that used to happen quite often in the classroom. And, even the parents were not empathetic for the child. And that was one incident, I felt so bad that, what kind of citizens we are. I mean, it's not only my responsibility as a mental health professional. That should be the responsibility of everyone. All the stakeholders have to take a collective responsibility. So then only we can take care of the health of a child or adolescent, who are the future of our nation. So that kind of, treatment we are giving to them. And I was more surprised to listen the name of the school. That is one of the reputed school of Delhi. That this is the situation. So if there is some child, 11 or 12-year-old girl, who is having dissociation in the classroom, so teacher reported the principal, and they just बोला कि जाओ भाई अपना बांधो बैग, और पेरेंट्स को बुलाकर बोलते हैं कि बच्चे को हटाओ स्कूल से. She is not mentally well. She is having some mental health issues, and we are not able to keep her in our school anymore. So then, we took the help of a department of psychiatric social work. So we approached the principal, conducted certain awareness sessions, some workshops in their school. Thoda darana bhi pada that we will report that further. Then if you will not understand, or if you will not, be sensitive of this, and if you will not be empathetic for the situation. So this is the situation of our country. So these are the few cases we have come to know because they have been reported in our OPDs. But I believe there will be much, much more than those cases which are underreported. They are not getting admission just because of very, very, even if they are not diagnosed with any psychiatric disorder, they are just disturbed because of some reason. So they just deny the admission, or they will just they will give threatening to the parents, so that, they will not be able to keep the student in the school. So I think, so that was the whole idea, to make teachers aware that, it's not only the referral. So one is to make them aware that, what kind of that how they can play an important role while identifying the flag signs, so that they can refer the student to the mental health professional. One, what is another role? Another role is, don't you think that teachers also play some important role when so it's not all the cases they have to refer to us, being a clinical psychologist. They can handle very well in the classrooms. If they are, so what is required? Awareness is required. Sensitivity is required. Compassion is required. Right? And of course, empathy is required.
So then for bullying also, if there are certain teachers, so you can also spread this information to everyone, and probably you will be aware that how help the system. You have to make very strict rules against the bullying. Then you should be able to recognize that whether it's a case of bullying or if they are exploiting the child, then you have to report. Now, as per the CBI guidelines, there should be a committee in the school, anti-bullying committee. So you have to report to the committee, you have to respond adequately, and you have to enable the child to refuse if such kind of, why I'm bringing this thing, because this is also very important that the other students in the classroom, they should also be aware and quite sensitive about this issue of bullying. So even if they are witnessing, they are seeing somebody is being humiliated or being bullied, so they also need to be report. And that's how they can teachers can play very important role by replacing the aggression with the acceptable skills. I'll come to those skills also. So can you suggest any other ways of helping a bully, a child with bullying, or to helping any victim in the classroom? Yes. Yes, very, very important. Yes. It usually happens that if I am a victim, so many of my adult patients, when I taking the history of your childhood, so they tell very sweetly that, initially I was the one who was the victim in my class, and then I started bullying other people. Yes. Any other strategy? What you think that can be? Yes. Yes. Can you explain it furthermore?
Yes. But they are not speaking or intervening in the process. So bully, takes over. So this is a power game which keeps on happening.
Yes. So how much time we still have? It is 4, because 4:30 you are having again a session from Dr. Shalini today about the ethics and limits of talk therapy. So I will not go into the detail. So that is how you can help the victim, basically, that how they can support themselves. What is recommended in the school, that we need to promote an atmosphere with confidence, trust, and safety. Then during the parent-teacher meetings, these issues should be taken into consideration. There should be focus on the protective factors. That is important, because during the parent and teacher meetings only, you can bring this issue to the surface, that how much important this is to have a good atmosphere in the family. I mean, the good parenting style, good interaction pattern between the parent, then good interaction pattern within the sibling and from parent and children, and of course the prevention and redressal of mechanisms for bullying, and then the educational initiative by the school. Coming to the protection of child rights. Usually, this is a myth. We think, अगर आप हमारे देश की बात करेंगे and you will interview any of the parents, so they will say that, we are providing each and everything to our child. We are providing them food, we are providing them clothing, we are providing them shelter. Not only that, ma'am, they have access for education. We are providing them everything. So क्या कमी है बच्चे में? So that is not enough. So what are the other needs of a child? What are the other rights of a child? They are not aware of that. They have a right for freedom from prejudice and discrimination. Often being a, educator or being a professional, we often forget that thing. So forget about the parents. What are the other things which are required when we talk about the child right? Love and, so they also have a right for love and care. Yes. हमारे घर में नहीं होता, usually हम deny कर देते हैं. They have a right to listen. They have a right to heard. कितनी बार हम deny करते हैं वो rights.
Even that happens from all of us. So if I'm busy and my daughter will come, see, Mama, I want to discuss this thing. So I'll say, no, we'll discuss this later on. Or we pay very little attention to something, bacha hai bol raha hai. But no, we should not take them lightly. We should listen to them adequately. That is also the basic right of a child. We have to understand that. So those are the things which should be paid attention from everyone in the country. So keeping children safe is everyone's responsibility. It is the responsibility of the mental health professional, of the policy makers, educators, teacher, principal, school counselor, everyone, parents, everyone is responsible there. To address, yes. Yes, so that is being implemented in almost all the schools in Delhi. Almost all the schools, because I have seen, I know many schools in Delhi. Hanji? Yes. So they have adopted that. So the situation in Delhi NCR is much better. If you will compare the schools in other parts of the country, apart from the metropolitans, right? To address trauma, we must address the STS approach. So that means creating a sense of safety, meaningful relationships or connections with the child, or teaching them self-regulation and emotion regulation. So these are the fundamental principles of trauma-sensitive schools. So comprehension of the prevalence and impact of trauma, right? Another is the trauma-informed lens, what you know already. Ab to shayad sabko rat gaya hoga that what is that lens. Then using relationships to heal and build school connectedness. So, what kind of a relationship a child is having with the teacher, that plays such an important role. I'm telling you, I'll just give you one example. One of my cousin, her daughter was also, she was having many issues. So they contacted many therapists, many clinical psychologists in Canada, but it was not working well. Matlab, 10 session, 15 session le liye. Now, Rushi, you tell me that, now I thought that, now I have to help her. So I just, when I was about to start the intervention, then I came to know, now the intervention has already been started, perhaps, and it's working quite well in 2-3 sessions. And who is taking the session? The teacher is taking the session. So now COVID-19 has taught us that how we can change the roles. So the teachers have taken the role of a parent, or parents are taking the role of a teacher after the online education. So that teacher, that girl, she has so much connected with, she so feel connected with the teacher that she told me that I don't trust anybody in the entire world except for my teacher. So she listened to everything. So that is about the trust building. So it's not about the parents, from where, we can build up that part. We always talk about the attachment styles or the parenting styles. So, but it is also, so that's how, that the role of a teacher becomes so important, because they are the role model of the child. So when my daughter was very young, I'll give you one personal example. So kabhi hota hai na, teacher are so overburdened. So koi spelling galat hua, so they just ignored that and they put a tick mark on that. So I said, no, this spelling is wrong. So the correct spelling is this. No, how can you say that? My teacher has corrected it. So then who are you to say that? So they have so much of trust and confidence on their teacher. So they can make fun of you being a parent, but they will not make fun of their teacher. So when they have a lot of, trust and respect and connectedness with their teacher, so I think that's how the role of a teacher that becomes so important. So this is all we have already covered. So now coming to the intervention part. So this is the 3-tier approach, which is adopted all over the world. So if you will see in the, bottom of the triangle, so this is the tier 1. So which is a universal intervention for all the students for the promotion of mental health and well-being. So what kind of intervention those can be? So now, Hanji? Yes. So nowadays, if you will see in every school almost,
most of the school in Delhi NCR, they have adopted this approach of life skills. I'll come to that also. So this life skill approach, mindfulness exercises. So we used to practice those life skill approach and mindfulness practice. What we did that it was somewhere in 2016, 15 or 16, 17, there were few dissertations. So we had given those topics to the students and they used to go to the schools. They used to target the class 9, 10, 11, 12 students. So when they used to demonstrate those mindfulness exercises and considering them quite important and different from the normal routine. So that worked very well with the students. So, those are the few things which can be adopted by the school and that can be implemented or required by the for the whole school. Then if you will go above that is the tier 2 intervention. Those are the secondary interventions. Those are given to only some students who are at risk of those issues. So if the teacher is, having that belief that this is a student who needs such kind of special intervention, so that you can provide those intervention in a group. And so as you'll go upward, it will be quite narrow approach. Those are the students who are actually having some serious mental health issues, or those may be inclusive of some trauma. So those specialized services are provided to them that can be provided by a person who is trained in that, or they can refer that chunk or that population to the mental health professional. So it's I hope that is quite simple, that what we need to, adopt in all the school. So this is the whole life skill model, which is given to each and every child and adolescent in the school. So if you're, making them empowered in their decision making or problem solving abilities, you're enhancing their coping strategies, they are having good emotional regulation, they are having good communication pattern, they're having leadership skills, all these are the skills. If you are training the child in that, so the chances are very less that they will be affected by those childhood traumatic incidents or experiences. So we have to make them empowered to deal with the adversity of life. Of course, parenting is more of a cultivated art than a biological inheritance. It means continual nurturing. So it's a lifetime investment, and it's a lifetime exercise. So when a woman is pregnant, so she thinks that, oh my God, when this period will come over, I'm too much of, stressful because of this pregnancy. Then she think that, oh, this is the walking stage of my child. So all the time I have to be so alert कि कहीं गिर ना जाए, कुछ बिजली में हाथ, electricity में हाथ ना लगा दे. Then the schooling, then career, then फिर उसके बच्चों, फिर not only the mental health of the child, the mental health or issues of their grandchildren. So this is a lifetime process. What I'm saying that keeping those parenting workshops in the school, organizing those workshops is also equally important. So that is also the role of a teacher, that during the parent, we call it PTM, parent teacher meeting, but we are not taking the name of a child. So there should be the interaction, parent, teacher or child's interaction. So all of three of them should sit together, where the teacher can discuss the issues of a child in the classroom, then the mother can tell something about the behavior at home, then together they can take the advice of a school counselor or a psychologist, then they can make some plan about this. And of course, we, apart from the safety, choice, trustworthiness and empowerment, these are the things that we have already discussed. I think we have to ensure about the physical and emotional safety of every child. So trauma informed classroom is where they are maintaining a predictable schedule, and that is equally important for the home also, because if someone was discussing in their session, so if there is no predictability, then also they feel unsafe. So if there will be predictable routine, that give them a quite you will see that behavior in a child with autism also. So if the structure is disrupted, so they feel that's a very threatful for them. They feel quite unsafe. It's not only with the autistic child, it happens with almost all the children. So boundary setting is also equally important. As far as important is giving them safety and providing them all the compassion and being empathetic. Then we need to offer the choices for participation that empower students to feel sense of control over their life. So one of many of my clients, they used to say, बच्चों की बात कर रहे हैं कि I hate my mother because she always wants to control my life. So I said that you are giving her license to control your life, na? If you are able to control your schedule, so you just make your schedule, you just paste on your table, on study table, and you just follow that. There is no role your mother is going to play in your life. So because you are giving them license, that's why they are getting over interfering. And then of course providing them emotional safety. So that's all. So if children live with criticism, I think you must have. Now it has become quite. This was my old slide. So would you like me to read this, or you have already read that quite often? So we can skip it. So 100 years from now, it will not matter how much money you made, what kind of car you drove, in what kind of home you live. What will be important? What will be important? So the world will be a better place because you made a difference in the life of a child. So whether we are a mental health professional, or we are a teacher, or we are a parent, whoever we are, कोई भी stakeholder हो सकते हैं. If we are making a difference in the life of a child, then it means, then only we can have that sense of achievement. And the higher order Maslow की जो वो need होती है ना, need for self-actualization, that will be fulfilled. We borrow this word from children and we owe it back to them. Anybody who wants to interpret this? गांधी जी ने कहा था, we borrow this word from children, we owe it back to them. Yes, you can. This is the last slide. Huh? Yes. Anybody else? Now you really need a cup of tea. So any question? Any question? We have only 10 minutes. Dr. Shalini Anand is very particular about her timing. So, Hanji.
I have designed socio-emotional learning modules for my city schools, but I face a lot of challenges.
The other people, whoever wants to go for tea, I think they can go. Whoever wants to have an interaction, they can sit. So we can save the time by that matter, right? It's okay, Sonia? Yeah, Hanji.
So, ma'am, I faced a challenge in the sense that schools never wanted their parents or customers to to participate in those workshops or seminars because of the same thing, because they are doing business.
Yeah.
So, how did you face this challenge?
Yeah, that was very challenging initially, but what we did, if you will go, see, that's what is your approach basically. If you are going and convincing the teacher, the principal or the management, that how you can make a difference in the life of a student, then they allow you to do that. They allow you, but you have to, work very hard for that. You have to make some visits. But once they are convinced, so they will invite you very often to have workshop with the children, have a workshop with the parents, separately with the teacher. Sometimes the teacher will say that, we ourselves are going through a lot of, stressors in our life. So you please plan one session with us. We want to have a session for stress management. So that's how you can help every stakeholder in the school. You can have workshop for staff. You can have workshop with principals.
with teachers, with school counselor, with students, everyone.
Thank you so much, ma'am.
Yes, please, yeah. Jo.
Connected with Ministry of Education also.
Hanji?
You told earlier that you
Yes.
are connected the Ministry of Education.
I am
also.
one of the expert member of the mental health.
My question is, what is the future possibilities to implement the school model or school counselors model in other states also?
Yeah, it's very soon, because if you will see the state of Delhi NCR, you will realize that the situation has changed quite a lot. Now, many of the school, primarily when I saw just few years back, there were only 10 or 20% of schools who were having the counselor or the psychologist in their school. Now that situation is totally different. Apart from the government school, many of the government schools are also having, but private school, to almost every school is having their special educator, counselor, or a psychologist who are taking care of that. The teachers are being trained. They are the resource then they conduct the training for the other people. So that's how when we are changing the state of Delhi or NCR. So I think very soon, because many of the workshops we have conducted not only with the schools with Delhi NCR, I would like to tell you, we have conducted the workshop with more than 30-40 schools of Navodaya Vidyalaya and the Kendriya Vidyalaya also. So those are the government school and from all over the India.
Yes, sir. Thank you.
Yes. हाँ जी बिल्कुल, most welcome.
मैम एक्चुअली मैंने अभी एमसीडी में ज्वाइन किया है, तो मैम एक मेरे स्कूल में बच्चा था, उसका थोड़ा सा लोअर आईक्यू है एज कम्पेयर टू, तो थोड़ी शैतानी करता था क्लास में, वो होता है बच्चों में। तो जो उससे पहले जो उसका टीचर था ना, उसने उसको मतलब कि लाइक ऐसा सिचुएशन में क्रिएट कर दिया कि वो सभी टीचरों से डरने लग गया। तो मैंने उसको इतना मारा पीटा, तो वो बल्कि उसको लगा और वो काफी डरता था। तो मैं जैसे ही ज्वाइन किया मैंने, तो मेरे को सस्पेक्टेड लगा कि बच्चा डर रहा है, टीचर मेरे से ही डर रहा है।
You are a counselor?
स्पेशल एजुकेटर।
You are a special educator.
हाँ।
Great.
तो मैंने ऑब्जर्व किया, मैंने उनके पेरेंट्स से भी बात की, मैं बच्चा डर रहा है बहुत ज्यादा, क्या बात है? तो उन्होंने बताया कि आपसे पहले एक टीचर था, उसने इसको इतना मारा कि ये सभी टीचरों से डरता है। तो अभी 6 महीने हो चुके हैं।
और आप जो बता रहे हैं ये कोई नई बात नहीं है, अगर आप देखेंगे सो these are very common incident which are happening in our country.
उसके बाद क्या हुआ, वो किसी भी टीचर से ना तो जैसे गुड मॉर्निंग सर, गुड मॉर्निंग मैम, कभी नहीं। जैसे लाइक एक टीचर वॉक कर रहा है तो स्लाइटली चला जाता था और एक भाग भी जाता था किसी का उसको देख लिया तो। और लाइक अब मैंने उसके साथ इतना ट्रस्ट रिलेशनशिप, जैसे वो मैंने उसको बोल रखा है, बेटा मेरे से नमस्ते नहीं, मेरे से हैंडशेक करा कर, तो आते ही मेरे से हैंडशेक करेगा।
Very nice.
और कभी बार तो उसका मन नहीं करता, पर मैं उसको पकड़ के कर लेता, माँ तू ही आ जा मेरे पास।
बहुत अच्छी बात है।
अब टीचर्स खुद कहते हैं कि आपने इसके अंदर इतना चेंज ला दिया, वो हमसे भी करता है कि सर नमस्ते कैसे हो।
Just give a clap to this special educator. Yeah. So that kind of approach should be there with yes. Just wait for some time. Sundar is coming with the mic.
Ma'am, actually, I am doing my PhD in educational psychology. So basically, I'm doing from BITS Pilani. So our team had participated in the debate of the new education policy. And it was under, I think, Dr. K. Kasturi Rangan, wherein it was shown that there was a total neglect on the school bully system at that time. I mean, social inclusion as a part was not taken up in the first draft at all.
Yeah.
And it had to be submitted thoda alag se ki just in UP there are 40 lakh disabled people. That was the trend that we had got, 40 lakh disabled people who were subject to social inclusion in school itself.
Yeah.
40 lakh students apne aap mein. So when we started with the social inclusion factors, and when we started on the team started on the research of social inclusion, what was found was that a lot of students at their end. They are not able to discuss what is happening with them along with their peers. Like uh, the bully factor, rather than coming from the teacher, it comes from the environment and the peers itself.
Yeah. So that is the situation all over India.
Right.
So if you will, I mean, exclude Delhi NCR, you will see that the situation is very pathetic in certain regions of India. But I think people like you should raise these concerns.
Yeah.
You should write about these things, and then only we can improve the overall situation across.
Yes, ma'am, definitely. We are currently in process of developing
Great,
a paper
very nice.
that is getting its recognition worldwide, and that is basically on the fact that how can we develop a total module which can fight this school bully system altogether.
Very nice.
So that it is affordable in other schools also.
Is there any other suggestion or question, or should I wind up this? Yes. Because if you will tell them individually, they will deny and they will be very, it will not be acceptable to them. They feel very offensive. So what you can do, that you can organize certain awareness workshops like this. So what kind of support you are expecting? Just let me know. Yeah. Okay. So you are in which school? Sultanpuri. And what is, I mean, just a government school or a private school? It's a government school. Yeah. You take my email ID from here and you can write your concerns, whatever kind of support is required. So now after COVID-19, there is a scope of having online workshops also. So we can guide you also how you can organize those workshops, how we can help the school management and the principal while adopting that approach. So we can help you from, every angle. So what kind of, so you can just write us any kind of support if you're expecting. Yeah. Anyone else? So I think we are going to wind up the session. And you people, all of you can have your cup of tea. This is already 4:31. So I think all of us should reassemble here after 10 minutes. So by 4:40, we are going to start the session. So just have a quick tea, please. Thank you. Thank you.
Our last academic session, and we have the privilege of having Dr. Shalini Anand ma'am with us again online. I think we did have an introduction yesterday, but to refresh ourselves, Dr. Shalini Anand ma'am has completed her post-graduation from Delhi University and has completed her MPhil and PhD in clinical psychology from NIMHANS, Bangalore. Ma'am has been practicing psychotherapy for a very, very long time. And, she's a known name in the field of trauma-informed care, as well as ma'am has had association with Tata Institute of Social Sciences, Christ University, Montfort College, and various other colleges, as well as a lot of therapists have been trained under her and hold her in high regards. Ma'am, we really are privileged to have you, and this is a very important topic that we are looking forward for. Please take over. Thank you.
Thank you so much.
I would be very happy if I can see the faces of the participants, if that possible. So should we start? I can see that some people are yet to join, right?
Yes, ma'am. Ma'am,
should we wait for 5 minutes?
If we can wait for 5 minutes, that'll be great. We actually had broken, like we had a,
Yeah.
a break
So
for.
you can tell people to come.
We have.
Quickly, and we'll wait for 5.
Just ask them to return back. Yes, ma'am.
Okay. So let them come.
We are going to start the session. Please be seated. Settle down quickly. Dr. Shalini Anand has joined. She's there? Okay. So, very good evening, Dr. Shalini. If you are there, can you hear me?
Yes, I can. My camera is on.
Yes.
Am I visible?
So, the thing is,
Oh, that would be wonderful.
So now we can, I think all the participants have joined after having a cup of tea, so we can start the session. Thank you.
Thank you. So, good evening and welcome everyone. I hope everyone is refreshed and energized after a cup of tea. And I hope to have a very active participation from you after your cup of tea. There might be a little bit of physical activity that you may need to do. So if you want to put down your bags or something, that would be helpful. Okay, so the topic that I'm talking on today is limits of talk therapy. So all of us who are trained in clinical psychology, I assume everyone is from the field of clinical psychology here. So we are all trained in psychotherapy, mostly from the talk therapy perspective, that we sit across the table with the client and we are talking, we are asking them, how do you feel? What do you think about it? And what would help and what would not help? What do you think has been better? What do you think can be better? And things like that. So we usually talk to the clients, right? The world has moved beyond talk therapy. And my purpose here is to introduce you a little bit, show you a small window to the perspectives which are beyond talk therapy. Okay, so a usual trigger warning that sometimes we give examples. I try to avoid giving very disturbing examples, but some examples can be triggering for us. So please exercise your own self-care and exercise caution. Please feel free to walk out if something is triggering you or disturbing you. Ideally, it won't be, but if it is, then please feel free to take care of yourself first. So what I am presenting is a very short summary of this topic. And beyond talk therapy, there is a lot which can be done, but we are presenting just a short summary of that. So what I'm presenting is not at all everything to do with what can be beyond talk therapy. And what I'm presenting are not my original ideas. These are just my understandings of what people in the field have done. The stalwarts, the great people in the field have been doing for decades. Okay, so remember your self-care first. So let's start with one small exercise. Okay. So, which is why I had asked you to remove your bag or don't hold too many things in your hand. Ideally, put your phone away if possible, unless it is absolutely an emergency. So I want you to think of one memory, any one memory from your adulthood, from your childhood, maybe the day you got admission in MPhil, maybe the day you got some prize, or maybe the day you met someone who really loves you, or any such memory which fills your heart with happiness, pride, or joy. So feel free to keep your eyes closed for about 30 seconds to 1 minute and just bring in this memory in your mind. And as you are thinking of this memory, tell me if you notice anything in your body. It doesn't have to be something very strong. It can be something very mild, very fleeting. Do you notice anything at all in your body? Some examples could be you feel a little more open, a little more closed in your body, a little heavier or a little lighter? You feel some space is created, or you feel something has closed in? You feel like something is flowing or something has become blocked as you think of this happy memory? I'll be happy to hear even one or two responses if anyone wants to respond. Or even if you notice that maybe a little smile comes on your face, whether outwardly or inwardly. Does anybody notice anything at all? What do you notice? Anyone responding, or should I go ahead?
Hello.
Yes, please.
So, ma'am, the memory, I had a memory, the sensation was in a heart, and it was a very filling kind of a memory. Felt that something is flowing and the heart is filling up.
Okay.
That sensation and the
All
feeling.
right. Okay. Thank you for sharing. So, I request the mic person remains somewhere nearby and not somewhere very far away so that people can respond quickly when needed. So what happened was we did a very, very brief thing. We can't even call it an exercise. One very small thing you thought about and you are feeling one person has responded. Maybe not everyone felt something, but maybe some of you felt something. So what we are trying to find is that what happens in our body is not just because of what is happening physically. You have a memory of something. You just thought of something and you imagined something and you're feeling something in your body. So there are many examples of how we talk about bodily sensation. Yes.
Hello, ma'am.
Yes.
I also thought about a memory. It is a pleasant memory, of course, with my mother. And after that memory, I feel a little heavier in my heart and little bit palpitation.
Okay. So do you have any idea when you are thinking of a happy memory, why it is feeling heavy and why do you have palpitations?
Yes.
Okay. So I'll just tell you. So, when we think of a happy memory, sometimes it may not be a completely happy memory. Suppose we have a memory of someone whom we are missing, who's not around now, or any such reason, then it can become mixed up. Okay, so the instruction was something which is only filling your heart with happiness and joy and okay. You want to say something?
No, ma'am, you are absolutely right. This memory of mine is about my mother, and I don't have my mother anymore.
Yeah.
So
I'm sorry to know that.
No problem, ma'am. So because of that, maybe the emotions are
Exactly. Yeah. So, which is why I gave examples like if you remember when you got admission in your MPhil course or, something which is less likely to be mixed, which is more likely to be a relatively more pure joy or happy. But so what you have shared is also very helpful. Thank you. Please sit down. So again, the other thing that I wanted to give the example of was that when we feel sad, again, we feel something in our bodies. So that is a very important learning to know that when we are talking about limits of talk therapy, we have so many phrases which we say, I had butterflies in my stomach. My hands and feet are cold. I have cold sweats. or any of such sayings that we have. Even in Hindi, we have पैरों के नीचे से धरती निकल गई, right? So the sensations that we feel in our body are very, very real, related to different memories or experiences that we have. And when we are trying to learn about limits of talk therapy, I can tell you that talk therapy also relies a lot on cognitions and logic. Now, if we say that what is the logic of feeling this sensation or that sensation, it may be a very difficult question to answer. We are sensing in the body what we are sensing. And it's important for us psychologists to learn to access the bodily sensations which we are usually not very familiar with. Okay, that was just a very small, tiny exercise that we had. So, a few basics about trauma. Don't worry, I will not bore you, since yesterday all of us presenters, including me, have told you definitions of trauma and trauma lens and this and that. So, I will not go over the whole thing again and again. So, but something which probably you may or may not have covered. So, one simple working definition of trauma can be anything that is too much, too soon, too fast, or it went on for too long. So, any experiences, any traumatic experiences which are too much, okay, like, witnessing domestic violence for a little child is too much, or seeing an alcoholic parent is too much for a little child, or suddenly a parent going away. Of course, a parent dying when we are still very young, at any age, losing a parent is very difficult. It is too much at any age. But when someone is still a little child, it is actually too much. Too soon, some things are inevitable, they will happen, but when they happen too soon, too early in life, that can be traumatic for someone. Too fast, without any warning, without any awareness, like, even examples of natural disasters, which I think Dr. Sujata was talking about yesterday. Anything which comes without any warning, too fast. And it stays for too long. So, you have learned about examples of what is chronic trauma and complex trauma. So, chronic trauma is something which stays for too long. It may not be something very severe, even if it is something seemingly mild, but it stays on and on and on and on. That can have a slow and steady impact on the brain, and it can become traumatic for the person. While the same experience, if it had happened and if it had come to an end, it may not be traumatic for the person. All these come under the category of feeling overwhelmed. The brain, the nervous system has got overwhelmed. So all these are too much for our nervous system to handle, especially if we can't reach a successful resolution. So what happens in the end also matters. If we are able to arrive at a resolution, something is able to come to an end, then it may be still not traumatic. But if we are not able to arrive at a resolution, then it can be very traumatic. And the opposite is also true, that especially neglectful experiences which may underwhelm our nervous system, that nobody is looking at the child, nobody is paying attention to the child, nobody is hearing out the child, people sometimes told me that they had an extra class at school and both parents are hale and hearty and both parents had vehicles. And after the class got over, the school was locked and this child was the only one which remained outside the school, and both parents had forgotten to pick up the child, and that happened over and over again. So, feeling so unimportant and unseen and unheard can be underwhelming experiences for the person, and those can also become traumatic. And yesterday we spoke a little bit about how any of these experiences, if they are repetitive, how much they can shape our beliefs about ourselves, how they shape our beliefs about I am worthy, unworthy, lovable, unlovable, I matter, I don't matter. The world is all the CBT beliefs, beliefs about the self, about the world, about the future will get shaped by experiences which happen over and over again. So this already you know. We also covered briefly yesterday, and you must have already been knowing, that childhood experiences, especially early childhood experiences, affect us much, much more than later experiences. If you have any doubts about why, please feel free to ask me. But to briefly answer that, the brain is still developing. Anything which is still developing, if that is getting impacted, the impact happens in the structure of the brain and the function of the brain in a very deep way. Whereas when the brain is completely developed, and if the brain had developed in a healthy way, after that, when some experiences happen, they cannot affect us so much. So just to give you an example that, that the term PTSD, the diagnosis of PTSD was first of all used with war veterans. And even before it was named as PTSD, it was called shell shock. Now, so then some people had this curiosity that many people go for war and for combat. How is it that not everyone is developing PTSD? So it was found that people who develop PTSD actually already had trauma in their childhood. They already had complex trauma right from their childhood, and those who do not develop PTSD are also disturbed. You see so much of bloodshed and violence happening in wars. It is disturbing, but they are less likely to develop PTSD. Okay, so that's why childhood experiences affect us much more than later experiences. Then we have the concepts of big T trauma and small t trauma, which also you might be knowing. Can someone tell me if you know about it? Then I can move ahead. Does everyone know about big T traumas and small t traumas? Okay, so then I will go ahead. So just one more thing, which again you must be knowing, but just to emphasize that small t traumas, I sometimes use the example of 1 kilo of an iron weight versus 1 kilo of potato chips. So potato chips are very light, but if both are 1 kilo, they are both equal. So we can't say iron is heavier than potato chips, because small t traumas can keep adding and adding and adding, can become as much or even more than big T traumas. And the second factor is that small t traumas very often receive a lot of invalidation from everyone else. Think that, हाँ तो क्या हुआ, इतना ही तो किया था. They have not beaten you, they have not starved you, they are not alcoholics, they are not doing domestic violence, your parents have at least not died, they have not at least killed each other. So there's all of this invalidation and minimization of the small t trauma experiences like emotional neglect or emotional abuse. Especially emotional abuse and emotional neglect come under the ambit of small t traumas, and the person feels very alone because nobody is able to understand their experiences, that they have felt so unseen or so neglected or emotionally manipulated. All these come under emotional abuse and neglect. So because of these, the person can feel very lonely, very ashamed. I am only trying to hold on to these memories. They were not so bad, not so difficult. The person may feel guilty, may feel anxious and sad, and may have a lot of self-blame that I am causing my own problems. Now, it has been found that presence of small t traumas makes us much more susceptible to get affected by later experiences in life. Now, when we become adults, there are actually a lot more challenges that we face in our lives in terms of higher education, in terms of dealing with romantic relationships, in terms of dealing with bosses or mothers-in-law, fathers-in-law. So many experiences can be difficult experiences in later life. But if there has been a history of small t traumas, then those later experiences, which may not seem so challenging to someone who's not had small t traumas, someone would find it much more difficult to deal with even small challenges in life. Okay. Now, this is another small exercise that we will do. Again, does everyone know about this? Then I can move ahead. Everyone knows the hand model of the brain? Does everyone know that? Okay. So, all of you put out one hand like this. And put your thumb in between and close your fingers over it. Okay. Now, this is a very rough simulation or artificial model of the brain. This is called the hand model of the brain given by Daniel Siegel, who's a psychiatrist and one of the renowned trauma therapists. Now, how this becomes a model of the brain is because it's actually based on a very old theory of neurobiology given by Paul MacLean. It is called the triune brain model, which you must have studied in your physiology courses in BA or MA. So how this is a brain is, we have a very large brain and we have many billions of cells and many trillions of interconnections between cells, as you must be knowing. Now this top part, the fingers, if you lift this up, if you lift this part, this is like your frontal lobe, your cerebral cortex, like a lid on top. Okay? And this thumb, which is in the middle, is like in the middle of the brain, so from here to here. Okay? So this is your middle brain. And this part, the lower part, is your lower brain. So this is a very simple model of the brain to understand a very complex structure that is our brain in a very simplified way. And why is it important? We will understand that. Now so we are dividing the brain into three sections: higher brain, middle brain, lower brain. Also called as human brain, mammal brain, reptilian brain, thinking brain, feeling brain, and sensing brain. Okay? And this is, as you know, the limbic system is in the middle brain. So your amygdala, thalamus, hypothalamus, all the limbic system is in the middle. The upper part, the fingers, are the cerebral cortex, your frontal lobe. Okay? And under normal, healthy situations, hopefully, if you are feeling alert enough after the cup of tea, if you're not too sleepy or too tired, then when we are feeling alert enough, then all these three parts of the brain are in sync with each other. Okay, they are able to work in tandem with each other. We are able to think, we are able to feel, we are able to sense, we are able to be aware of everything. Now, when we are disturbed or triggered, then what happens is that this frontal lobe, the higher brain, kind of gets disconnected. Okay, so almost like when you have a pan in which you're boiling water or milk and you put a lid on it, when it boils, the lid will fly off, right? So somewhat like that, this higher brain gets disconnected from the lower two parts of the brain. Now, what does the higher brain hold? The higher brain holds all our intelligence, in the sense that all the logic that we have, all the analysis that we can do, all the shoulds that we have, all the readings that we have done, so all the understanding of the world we have, what I should do when I'm feeling anxious, all those tips and tricks this part has. But when we are triggered, this is the part which gets disconnected. So now what we will say, or what we hear many of our clients say, I know what I'm supposed to do when I'm anxious, but when I'm anxious, I just forget to do everything. We've heard that? Have we heard that? Or when somebody is struggling with addictions, they say, I had decided, decisions are here. So I had decided I will never drink again, or I will never smoke again, or I will never go for gaming again. But when I get the craving, I just can't control it. So cravings are in the limbic system. Okay? Now, I told you that there are these three parts of the brain. Sometimes we further divide them into just two parts. So the thinking brain and the survival brain, these two together become the survival brain. The limbic and the lower brain become the survival brain. Now tell me a simple thing. When there is a competition between doing the right thing versus the survival, who will win? Survival wins or doing the right thing wins? Survival will win, simple thing. Because if we are not surviving, then what is the right thing or wrong thing? Now, this part, the lower part of the brain, which is responsible for survival or whatever it believes is required for survival, takes over when we are triggered or when we are disturbed. So, what the right things we know, whatever healthy cognitions, positive thinking, all that is here, but that gets disconnected from the brain. Okay, so we are slowly building the case for why we need to move beyond talk therapy. So, your higher brain also holds language. Where is language? Everyone has studied neuropsychology. Where is language stored? Higher brain, right? So the lowest part of the brain, this lizard brain or reptilian brain, your brainstem, cerebellum, they are responsible for everything that a newborn baby can do. Eating, drinking, sleeping, knowing that it's wet or dry, cold or hot. Also balance. If the baby is falling, there's a startle response. So everything that a newborn baby can do, this part is responsible for that. Right? And so this part is almost ready, almost developed when a baby is born. Slowly in the middle childhood, so all the neurons are there mostly when we are born. Most of the neurons are there, but the interconnections are yet to be formed. The interconnections of the frontal lobe are forming till we are anywhere between 21 and 25 years old. Till then, our brain is not fully ready. Okay? Now, slowly till we reach adolescence, our limbic system is more or less ready. Now, what do you see in adolescence? There is a lot of risk taking sometimes. There is a lot of thrill seeking activity, novelty seeking activity. Higher brain has thoughts about consequences of what I'm doing. How would it affect me? Save for a rainy day. Don't drive too fast. Don't. So all those good and bad do's and don'ts are here. Like a grandmother's voice, save whatever money you have, don't spend everything. So adolescent brain, the limbic brain has more of thrill. You have money, spend it now. Okay. Only with time, slowly, this part which has wisdom also develops. So what I'm saying is, even in the adult brain, ideally all of them are working in tandem. We are able to take turns. Okay, today I'll do the wise thing, today I'll do the thrill thing, today I will just have whatever fun. Now let's look at some of the interconnections between trauma, attachment and neurobiology, which we have already started talking about. So there's a newborn baby. A baby is born. A baby is dependent upon adults for everything. Everything. Food, shelter, clothing, changing when their nappy is wet. That we are all aware of. What we need to also be very, very clearly aware of is that the baby is unable to regulate their own emotions. The baby's nervous system is not capable of doing what we call auto-regulation. Regulating oneself, it is not able to do. So, what do we do? Now, the baby is dependent on an adult for emotional regulation. Very important information for us to remember. Ideally, an adult who's typically a mother, but not necessarily, mostly a mother, or any other consistent primary caregiver regulates the baby's emotional states. The baby is crying, so somebody has to come and soothe the baby, maybe rock the baby, speak in a soothing tone of voice, some soft voice, touch the baby in a loving way, some rhythmic touch, rhythmic movement is usually very regulating for the baby. So either rock the baby in your lap or rock the baby in a cot in some way. If you rock the baby, usually the baby calms down. So when that is done, it helps the baby's homeostasis. You all know what is homeostasis. In regulating the emotional state. Now, if most of the times when the baby is disturbed, somebody is able to regulate the baby over and over and over and over and over and over again. Slowly, what happens is that the baby is able to feel more regulated. Oh, I will become disturbed, but yes, I know that emotional disturbance calms down. Again, I will feel disturbed, but it calms down. Again, I will feel disturbed, again, I will calm down. So the baby's nervous system is registering that, okay, becoming emotionally disturbed is not a big deal. It is not a permanent thing. There will be someone who will help me calm down. Okay. Now what happens is that when there is no attuned parent, or the parent is more emotionally dysregulated than the baby, you will very often see that if amongst the mothers who have their own unresolved trauma, if the baby is crying, the mother is crying louder. You've seen that? Yeah? Mother is crying loud. Oh my God, what happened to my baby? Oh my God, what happened to my baby? Now, the baby is like a sponge. The baby is absorbing what's happening. Right? Now, the baby is absorbing that, oh my God, this is some very crisis situation that my mother is disturbed. That means it is a catastrophe, a calamity happening. So the baby is absorbing that my becoming emotionally disturbed is such a disastrous thing that it will never get better. In fact, I will have to console my mother. So gradually, as not a little baby, but as the baby grows and becomes a child and adolescent, they learn that I have no space for my emotions. I have to keep calming my parents. And that this pattern is likely to lead to a preoccupied or ambivalent attachment style. I'm sure all of you might be aware of attachment styles, something or the other you must have studied about it. So these patterns make it is like setting the stage for the development of preoccupied or ambivalent attachment, in which the baby will learn to become hyper in all situations. On the other hand, if there is an adult who's expecting the baby to calm down on its own. Yeah, what is it? Okay, take food and go. Okay, so they are kind of expecting, they're being very cold and mechanical almost. And once in a way, all parents will do all these patterns. Once in a way, I'm talking about a consistent pattern. Then the baby is slowly developing into becoming a child with avoidant or dismissive attachment style. Okay, in which they will think emotions are bad. Feeling any emotions is a sign of weakness or it is bad. And they may also slowly develop into a very mechanical person. And the third possibility is that if the child is feeling scared, terrified over and over again, either somebody is hitting the child, or somebody is hitting somebody else, or people are screaming and shouting very often, and the baby is very startled very often, or scared very often, or terrified, and the child is slowly, as the child grows, they are likely to develop which attachment style? Which is the third kind of insecure attachment style? Okay. Disorganized or fearful attachment style. So when any of these are happening, it is not possible for the child to learn to regulate their emotions in a healthy way. Okay. So in case of trauma, that is hyperarousal or hypoarousal, which are some of the examples that I gave you, there is blockage or unhealthy development of these nervous neuronal circuits, especially the right brain. So right brain is responsible for regulating emotions. So there is a lot of turmoil happening in the right brain. This kind of early trauma, this regulates not only emotions but also interpersonal emotional distance. So slowly the baby has to grow up and go to school and interact with siblings and cousins. So this child who has not received a healthy kind of parenting is likely to be a child who will either bully other children, or will get bullied in school, or will be excluded by other children, or will not be able to perform academically. I think Dr. Rushi had presented very beautifully various things that a child can go through. So all those are likely to happen, and the seed of that is in very early childhood. In fact, in infancy, you will see the seeds of that. So these effects happen not just in infancy, sometimes these effects can happen even prenatally. So if the mother is carrying her own unresolved trauma, the HPA axis, that is hypothalamic pituitary adrenal axis, which is the axis which regulates all our endocrine system, will be very dysregulated. This I have already told you, mother's own unresolved trauma, as well as if she's undergoing stress right now, will have a lot of effect on the baby. So baby will be impacted by both parent stress levels, and if it is a joint family, then any grandparents, any uncles and aunts, anyone's stress levels will be absorbed by the baby. Especially if nobody is soothing the child after that, nobody is resolving that afterwards. So the baby is absorbing the environmental stressors and is also absorbing how adults are resolving their conflicts. If they are not resolving their conflicts or they stop talking for days and months, then the baby is absorbing, the child is absorbing that this is the way to resolve conflicts. So all these attachment traumas can impact at a very deep neurobiological level. So Daniel Siegel, who has also given us the hand model of the brain, which we just learned, he has written this book called The Developing Mind. He states that early childhood experiences with caretakers allow the brain, especially our prefrontal cortex, to get organized in specific ways which form the basis of later interpersonal functioning. So you will find that some of us or our clients have difficulty in interpersonal functioning. It can be improved. Remember, everything that I'm talking about, it's not like a doom or doom and gloom kind of a situation. Everything can improve. But the thing is to first recognize and accept that this is happening. So the right hemisphere is affected in many ways. I will not read out in what all ways. Let's watch a small video and wake up by watching the video, hopefully. Why is the video unavailable? Okay. Is anyone aware of the still face experiment? Uh, Can I get some responses, please? Is anyone aware of the still face experiment?
Yes, ma'am.
Okay, can you briefly say what it is?
So, it is about the baby.
Mm.
Yeah. So, there's a baby playing with the mother, and mother is trying to communicate, and suddenly makes a still face, and he tries to understand what's happening. Why is the mother not responding? And slowly and gradually, he walks up the ladder to the dorsal-vagal and gets disturbed. And at the end, there's a little sign of dissociation also, but then because of the ethical considerations, the mother comes back and responds and soothes.
Very good, excellent. So dorsal vagal, so what do we see? What do we see in the child? We see, I mean, the baby is pointing here, then the mother looks there, and the baby is making some noises, the mother is making the same noises. She's kind of echoing and mirroring whatever the little baby is doing. And suddenly she becomes, having this kind of a face. No expression, not looking where the child is pointing, not making the noises, not smiling, not frowning, nothing. It's just a blank face. And it's an experiment of a few seconds. Few seconds. The experiment was done by Ed Tronick, if you want to go back and read up. And the baby becomes so distressed in those few seconds. And as this friend of ours told us, that for ethical considerations, the experiment was done just for a few seconds, and it made the point that it wanted to make. And Ed Tronick goes on to say that thankfully this is an experiment, and the mother comes back, and every child is not so fortunate, and there are children who have to go through this forever and ever, that there's no expression, and parents are sometimes just doing all the duties, fulfilling the role of health, education, food, shelter, clothing. But what the baby needs, even Harlow's experiments have shown us that the baby monkey goes and drinks milk from one particular wire monkey, but doesn't want to stay there any longer than they are. As soon as they are filled, they go to that bull monkey where they can cling. So which means that there are many other needs which are not fulfilled, for many, 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 many of the people, whether we like it or not. Okay. Now, different kinds of attachment trauma happens with all of us and with our clients. Examples can be having to care for parents. So we know the concept of parentified child. Anyone who's had to be over concerned about the parents becoming upset and becoming very caring for the parent, and that good child syndrome, and all the TV series go on about, oh, this child is so good. I feel so disturbed when they do that, because that very good child is very often a parentified child and is developing a preoccupied attachment style, and it's not at all healthy. Or examples like in which one parent is not protecting the child from the other parent's frightening behavior, whether it is physical abuse or sexual abuse, whether you believe it or not. There are families in which either their own father or some uncle or grandparent is doing regular sexual abuse, and the mother knows about it and keeps quiet about it. And the amount of trauma that the child goes through, not just by the parent who's abusive, but much more so by the parent who has stayed quiet, the effect lasts for a long time. Or if the parent is not able to soothe the child at the time of emotional upset, even if they have not caused the emotional upset, somebody else may have caused. Again, we see so many people who have been called names by relatives or family members. You are too thin, you are too fat, you are too dark, your nose is big, your hair is this and that, and parents are watching or joining the fun, and parents have not interrupted in that and come to the rescue of the child, and that can also be a big betrayal. Once or twice if it happens, it doesn't affect so much. Remember, any of these examples that I'm talking about are regular patterns. And again, the worst is when the child is consistently frightened by parents' behavior, either because of physical abuse or shouting and screaming or throwing things or something or the other. So any of these three kinds of insecure attachment styles can develop, which I will not go into the details. You should be knowing about them, or you can read about them more. Now, there are many myths we have. So first of all, will someone tell me what are the different types of memories that you know? Quickly tell me. Types of memory. Have you heard of something explicit, implicit, episodic, semantic? Are these words familiar? Somebody speak up, please. Forgot. Okay. So broadly, two types of memories. One is conscious or explicit. One is unconscious or implicit. Within conscious or explicit, we have semantic and episodic. Okay. Within unconscious or implicit, we have emotional memory and procedural memory. Okay. So very broadly, these four types of memories are there. Only two of them are conscious, semantic and episodic. Semantic is after this lecture, when you go back home, what is the definition of trauma? You may be able to rattle off, oh, trauma is this and that. We have heard it for 2 days, we know what it is. So all the information that we are able to remember, who's the president, who's the prime minister, whatever information you know, that is all semantic memory. Episodic memory is your own life's autobiographical memory. Okay? So if we have a coherent narrative of our own lives, that means we have an episodic memory or of one particular event or, you know, my first day in college. Okay, so you'll be able to say what. So that is your episodic memory. Then we have implicit memory, that is unconscious memory. Unconscious memory is emotional memory. Emotional memory means I don't remember what happened or I may remember. So whether I remember what happened or not is explicit memory. But I remember I felt this is emotional memory. Procedural memory is, we all know examples of bicycle and swimming and this and that, all those are procedural memory. So, body memory or what you felt in your body or what you feel in your body now when you think about that. So, the first exercise that we did is your implicit memory, your unconscious memory. So, you have something in your body which is storing the memory of anything that has happened, good things and bad things. Okay? Now, the first sentence that I'm saying here is that it's a myth that infants do not remember experiences. Sometimes you see parents fighting and shouting and screaming in front of a little baby or doing whatever they are doing. Sometimes, you know, some adults come for therapy bringing their little baby in the session. Oh, this baby won't understand. But the baby is absorbing the emotions of what's happening around. So implicit memory is very, very much there. I'll give you some few very simple examples and you will understand. Do you remember who taught you to walk first? You remember who taught you how to walk? You don't remember, but you remember to walk. You didn't forget to walk. Your body remembers to walk. Do you remember when you first learned to eat your food on your own? You don't remember, but you remember to eat your food. You don't remember when you learned to read or write, but you remember to read and write. Okay, so all these are examples of implicit memories that you have. So similarly, every experience that a baby is going through, the body is holding those memories, even though we may not remember that we remember. We remember that we remember a very small percentage of things. There are lots of things that we remember, but we don't remember that we remember. Now, what happens in talk therapy is we are talking about what happened in your childhood. Person says, I don't know. Other person says, nothing happened. Then we say, okay, nothing happened, because if something had happened, this person may have remembered. Not always true. Okay, so there are many examples which would help you know that you have a lot of implicit memory. You may not remember that you remember this. Our experiences are in the form of sensory information. Sensory information, what we can see, hear, touch, taste, smell, which are imprinted on our brains. And these patterns or imprints create memory. This is very important to understand. A lot of memory that we have is pre-verbal. It's not just non-verbal. It is pre-verbal. It is memory which we have from the time when we did not have the language. Because we did not have the language and we did not have enough of our frontal lobe developed, that means the language and the frontal lobe were not the eyewitnesses of that experience. So when we ask our linguistic system and our cognitive system to tell us what happened or what we thought or what we think about it now, it is like asking somebody what happened during a murder if they were not the eyewitness during that murder. Am I making any sense? Am I making any sense? Okay, how many people are actually listening? Tell me. Or are you done with trauma in the last 2 days? Am I making any sense? All right, I assume that I am making sense and go ahead. So you know that the name of a very, very popular book is The Body Keeps the Score. You should read the book if possible. It's a very easy read and it is the best. It is one of the best sellers for decades and many non-mental health professionals have also read the book. So it's a very easy read and a very good book. So this is a phrase which makes a lot of sense. This is the body keeps the score, because if at a direct or even indirect reminder of something, the body has a reaction. Okay. One person here who remembered her mother has a heavy heart. Somebody who remembered a happy thing is feeling a lot of space. So there is a reaction in the body, like we can have an increased heart rate. If you just think of someone who shouted at you suddenly, if you just think of that, you might have an increased heart rate. Or if you think how maybe you had a breakup, you might have a sinking feeling. Or you were ditched by your boyfriend or girlfriend, you'll have a sinking feeling. The chances are that that experience still affects the person in some way or the other at a non-cognitive, non-linguistic level. It affects us at a very deep level. So, attachment interruptions like feeling abandoned by a parent forever or even at any one or two or few important occasions, and abuse and neglect are more common and more understandable examples, which I don't have to tell you anymore. Especially such experiences in infancy can lead to lots of implicit memories, which will have their memory stores in the body, and repeatedly they will elicit lots of physical reactions. So these memories are stored and can be triggered in later life. These triggers can manifest as mistrust or fear of interpersonal attachment. You'll see sometimes, people feel like a victim in all situations, whether they are a victim or not. So there must have been a victimhood feeling in their early childhood, which they had no control over. So that feeling has been stored in their bodies in form of implicit memory. And that keeps playing in different situations, whether objectively speaking, they are a victim or not. Part of the problem may be that the person has absolutely no cognitive awareness of the sources of their fears or that they were betrayed in infancy. Now, this is why when you try to do cognitive therapies or language-based therapies, your efforts will be very, very difficult. Okay? How much time do we have? We'll watch one small video. Hopefully this will work. Is this audible?
Yes, ma'am, it is audible. Video? There's no video on the screen right now. Sorry.
There's no video?
No, ma'am, there's no video on the screen right now. We have your presentation on.
Yeah, 1 second.
You'll have to share the screen of the video. I think.
Okay.
Yeah. So if you can share that screen, then we'll be able to see it. Yes, ma'am, we can see the video, though it's on pause. We can't hear the video.
You can't hear?
You'll have to share the audio of the computer also for us to be able to hear that.
Now?
Yes, ma'am, we can hear the video.
I'm going to go off script here and admit something. I used to be the on-call social worker for Safe Haven. Moms and dads would drop their babies off at fire stations and I would get the call. And no matter how fast I drove, by the time I got there, that baby would be wrapped in a warm blanket, some firefighter's arms, crowd around it. Why are you telling me this? You were 5 days old when your mother abandoned you. Your brain may not have a memory of her pulling her hand away from you, but your body does. And your body felt the same way in that diner when she pulled away and left you alone. That's why it hurts so much. Your body felt the same way it did when you were a baby, all over again. And you were surrounded by love. Still are.
Lose yourself inside the silhouette.
Okay. Are we back to the slides?
Yes, ma'am, we are.
Okay, was it visible and audible?
Yes, ma'am, very well.
Yeah, so this is from Grey's Anatomy, which I'm sure many of you already watch and are aware of. And if you're interested, it is episode 5 of season 16. You can go ahead and watch again if you want. So, like they said in the video, that we may not have a memory of that, but the body remembers. And see, something which has happened recently in which someone went away and she's feeling so disturbed. And it is not because she's oversensitive or she doesn't know that the cognition of knowing that this is not such a big deal, I'm sure she also knows, but the body remembers that sense of abandonment, that sense of someone pulling away, and she has the same reaction. You know, anything that you see anyone becoming too sensitive to criticism or too sensitive to any abandonment, too sensitive to anything, sometimes it is because they have had that experience in their childhood and they had no control over it, and it is stored very much in the body, very raw, and but may not be so much in the explicit memory. It is very much part of the implicit memory. Okay. This I have already told you, so I will not tell you. This is just a sketch of Peter Levine, one of my most favorite trauma therapists who has done a lot of work on somatic psychotherapy. If possible, read more about it, learn more about it. And what he's doing here is one of the hugs he has given. So we can all do that. So take your right hand and put it under your left arm. And take your left hand and put it on your right arm. On your right arm. And just hold yourself tight. This is like a hug to yourself. So what Peter Levine says is that our rib cage is like a container. And when we can hold ourselves, sometimes it helps us feel a sense of containment, a togetherness. And this can be one of the small ways in which we can sometimes feel a little calmer when we are very anxious. Okay? So now coming to why do we need to move beyond talk therapy? Till now I have kind of setting the stage. So there are different approaches to help clients after trauma, and in terms of the brain, these approaches can be divided into bottom-up approaches and top-down approaches, which you might already be aware of. So top-down approaches, the most popular one, millions and millions of research studies are there. Cognitive behavior therapy, and then we have a newer version, MBCT, then we have TFCBT. They are all top-down approaches. They basically work on how to help people think differently, how to think differently, whether you call it rational beliefs, negative belief, positive belief, or something to do with the beliefs and cognitions. CBT and all the variants of that, whether it is DBT or trauma focused CBT also, they are all top down approaches. They start with the higher brain. They start with the fingers, okay? And they hope that the effect will go down to the deeper structures of the brain. Trauma is stored in the lower parts of the brain. Trauma is not stored in the higher parts of the brain. So addressing the higher parts of the brain, especially when we only address the higher parts of the brain, we will find roadblocks and roadblocks and roadblocks. And we will feel frustrated because we won't be able to reach anywhere. Whereas bottom-up approaches start from these lower parts of the brain. So approaches like EMDR, sensory motor psychotherapy, somatic therapies, when there is comprehensive resource model, to some extent yoga is used as an adjunct, then you have brain spotting. All these are bottom-up approaches because they start from the bottom parts of the brain. They do not rely on language. What do you think? What do you feel? What do you understand? What do you want to say? What do you want to think? Why do you think so? All those are questions which we are addressing only to the higher brain in top-down approaches. Bottom-up approaches do not do this. Okay? So what do bottom-up approaches do? They work on how to help clients cope with their raw emotions and defense reactions which are stored in the lower parts of the brain. Okay? Now, solely relying on language is neither needed nor helpful in actually dealing with trauma, in actually doing some meaningful work. It is neither needed nor very helpful. So all the traditional models of psychotherapy which require the telling and retelling. Earlier model was let the people talk and talk and talk and talk about what happened, and then it was like catharsis and chimney cleaning, and so they'll, as if it will get emptied and then they will feel free and it will stop hurting. I don't know how many people have actually stopped hurting. It may feel lighter at that time. Does it treat the trauma from the core? No, it does not. Even finding an interpretation or insight, does it treat the trauma? No, it does not. So these methods have not typically been found helpful, and in fact they can be re-traumatizing because when the person is talking about it, see, we did the first exercise for half a minute. I asked you to think about it. When you thought about it, you felt some openness or some lightness in the chest or stomach or somewhere, right? When you are thinking about that traumatic experience and you're talking about it, you are reliving it, your body is reliving it, your mind is reliving it. So that is re-traumatizing. And one basic principle of trauma therapy is avoid re-traumatization. Safety first is the slogan. So re-traumatization is not safe. Okay, so talking and talking and talking about trauma is very harmful and definitely not helpful. Now, because accessing trauma, okay, tell me when somebody was hitting you, what was happening? Okay, tell me. Oh, they wanted to talk about it, so I kept listening. But they want to talk about it because they are reliving it in their mind. So they will say that they want to talk about it. But want and need are two different things. They may want, but is it needed? Is it actually helpful? So as trained mental health professionals, we need to know what is actually helpful and what is not. If the clients knew everything that is helpful, then we are not needed. Right? So accessing trauma can happen much faster than one can contain, more than the brain can contain. So it will make the person break down. If you are having sessions with anyone who comes every time and cries and cries and cries and goes back, then this is exactly what's happening. They are getting re-traumatized in every session. Telling the story might make us feel better temporarily. It might make us feel better. It does not help us get better. It does not treat us. Feel better and get better are two different things. Approaches that rely solely on language or thought miss out on the somatic or bodily experience, which is of primary importance in working with trauma. So talk therapies are highly dependent on our conscious memory. We learned that there is something called unconscious or implicit memory. A conscious memory is very often colored by the should we carry. So there are n number of motivational speakers. Think positive, think of the hope, think of everything that is going fine in your life. Now, the last thing they want to hear when they come to us is we also saying, oh yeah, some things have gone wrong, but there must be many things which have gone right. Why don't you think about it? So it is very hurtful to hear that from someone else. So people may on their own talk about everything that has been going right because I should think positive. They will focus on the should and their language will be colored by the should. Talk therapies or top-down approaches address the higher brain, only the higher brain, through language, cognitions, interpretations, and so on, which often do not have the desired healing impact on the lower parts of the brain because the trauma lives where? Higher brain, lower brain, where does it live? Okay. I was asked to give you only 5 questions. I wanted to give at least 20 questions. So this would have been one of my questions. So while trauma deeply affects our core beliefs, yesterday also we were talking about it. I'm sure you already know in CBT, Beck and Ellis and everyone has said core beliefs, how they are formed is because and only because of our early childhood experiences. So even though our core beliefs are affected by early childhood experiences, if we address only core beliefs only through talk therapy, it will not be helpful in restructuring core beliefs. If you think it has been helpful so far when you are doing CBT, I'll be very happy to know about that. Trauma and dissociation go hand in hand. Does anyone know why? If you can quickly answer, otherwise I will only answer. Is the mic available, please? Anyone wants to say how trauma and dissociation go hand in hand? Yes, please.
Hello.
Yes,
so,
please.
Ma'am, trauma and dissociation are associated. Like, trauma puts in us into this fight and flight mode, and we want to survive. And sometimes dissociation helps us survive better.
Okay, absolutely right. So just to elaborate on what you are saying, so there are situations in which, especially when we are young children, we don't have many resources, and there are situations in which we cannot physically move away. You know, getting beaten every day, or even witnessing fights every day, or facing emotional neglect or emotional abuse every day. Once I was visiting in Delhi one orphanage. There were many children. There was a 4-year-old child, 4 years old child, who had run away from his house in Bihar and he's landed in Delhi. He was 4. And in whatever broken language and with his accent, he's telling us that everyone was beating everyone up and he just kept walking and he reached a railway station. He boarded a train and he got off on the New Delhi railway station, and there are these rescue teams and they brought him into the orphanage and he reached there. He left home, but many children are not able to leave home. Now, when you're physically trapped and stuck, remember, the brain is a very friendly organ. The brain makes us survive, and brain does everything to protect us in one way or the other. By hook or crook, it will make us survive. So what the brain does, okay, physically you cannot escape, mentally I will make you escape. So that mental escaping is dissociation. Whether it is fight or flight or fawn or freeze or collapse. Any of these which may happen as part of dissociation. So trauma, when there is trauma, a very natural way in which people cope is through dissociation. Now, why are we talking about this in talk therapy? Why we are talking about this is that when we rely on talk therapy only, when we rely only on language, what the person is saying, the words they are saying, may be the narrative of one part who wants to be seen as a good child, as a good client, or any one part. It is not the narrative of the entire system. There may be one angry part, there may be a very sad part, there may be an addicted part, there may be. So, when you are hearing the narrative, it may be coming from one part who is front and center in the session. I don't know if I'm making sense in this. This is in the simplest way that I can put it. So, again, relying on only talk therapy is not helpful. Now we look at what are bottom-up approaches and what they do. So most people, just imagine, any people in the society, in the world, what do they try to do? Okay, forget about it. Now whatever has happened, you please try to forget about it. It's very common advice that people give to each other or people give to themselves also. Now trying to forget about it, if it helps, well and good. Does it help? It doesn't really help. You can do temporary distraction, you can do temporary things, but does it? There will be times when you can get triggered and when you're least expecting it, you'll get triggered. So trying to forget, trying to not think about it, or trying to change one's beliefs may sometimes help, but most of the times it does not help. So in such situations, bottom-up approaches are very helpful. So these approaches focus on the client's raw emotions and defense systems by working with clients to modulate their bodies. We work with the somatic system. We don't work with language. We don't work with what do you think, what do you feel, what do you want to say, what would you like to do. All those are based on language. Instead of that, we work with the bodies. So somatic psychotherapies like sensory motor psychotherapy are very helpful. A bottom-up therapy integrates the whole brain. So it is not that it will not do any talking. So it's not like it is against talk therapy, but it believes that only talk therapy will never be helpful. So it integrates the whole brain, left brain, right brain, and the top and bottom. And just as I said, dissociation and trauma go hand in hand. The opposite of dissociation is integration. So, when we are able to integrate the entire brain, when we are able to integrate the entire central nervous system, that will help us slowly move away from dissociation and come together. I've had clients, I don't even tell people, this is like they come up with this. One client told me that this is after many sessions. How are you feeling? So she said, I want to tell you something. I don't know whether I'll make sense or not. I said, okay, tell me. She said, when I started coming for therapy, I used to feel like I am many islands, loosely connected with some gel. This is the verbalization of dissociation. This is nothing but dissociation. And now I feel like some of those islands have connected together and the gel between them is also thicker. So it's easier to travel between the islands. It's such a powerful analogy that she gave me. I did not say this to her. She's herself coming up with this. Another client told me, again, when we were about to terminate therapy, she says that I don't know, she's a fully healthy bodied person. She says that I used to feel very disjointed. It feels like slowly my arms and legs are coming and joining me now. So these are the kinds of verbalizations you will hear when you can see that dissociation is reducing and integration is increasing. And I have I have taught CBT, I have done CBT for decades, but the effects that I see of now using the body methods, I have never seen those wonderful effects with CBT. So in trauma-informed therapy, the emphasis is placed on healing the attachment wounds. We play a lot of attention to attachment wounds because we believe that trauma emanates from attachment trauma. We try to access and utilize the bodily realm, the somatic realm a lot, and we work with dissociation. Rather than discussing things, analyzing things, or making sense of things, which are what we do in talk therapy. So top-down approaches, these are all the approaches that you are all very familiar with. Psychoanalytic therapy, CBT, acceptance and commitment therapy, rational emotive behavior therapy, then self-management and recovery training for addictions and behavioral problems, motivational interviewing, behavioral plans, behavioral contracts, SFBT, DBT, and some of them have their trauma-informed variants. Like there is trauma-focused CBT. So use them if possible, but even a trauma-focused CBT is a top-down approach, not a bottom-up approach. Bottom-up approaches are somatic experiencing given by Peter Levine, whose hug sketch we saw. Sensory motor psychotherapy given by Pat Ogden. Sorry, this is a spelling mistake. Pat Ogden. Eye movement desensitization and reprocessing, which Preeti just gave you a brief about. Internal family systems therapy given by Richard Schwartz. Expressive arts therapy, which you heard about in the morning. And brain spotting, which is just 20 years old. It just had its 20th birthday last month or something, given by David Grant. I am trained in brain spotting and eye movement desensitization reprocessing. So I use an integration of all these different kinds. Then there is dance and movement therapy, which is also a bottom-up approach. So all these are different bottom-up approaches, which can be very helpful in utilizing and working with trauma. What are the possibilities beyond talk therapy? So we work with the bodily sensations, as I told you. We work with parts. I told you that there are different parts. When there is dissociation, there would be an angry part, a sad part, an abandoned part, maybe a scared part, maybe a lonely part, maybe. So you work with parts. You can work with one part at a time. There are different parts-based therapies like internal family systems therapy. There is ego state therapy. So there are different therapies which are focused on working with parts and dissociation to heal the trauma, and they're very, very effective. Then we can use different imaginal methods. So guided imagery you are familiar with. So we do resourcing. Preeti was giving an example that she said love to one client and the client broke down. So what you will need to do is you will need to do resourcing. You can use guided imagery and build the resource of love for this client, a loving figure for this client. Then you can use imaginal methods for grounding, for containment. You can create a container, you can create a safe place, you can create a safe haven, you can create anything that you want using imaginal methods. There's a lot of scope using imaginal methods. We use metaphors. Now, metaphors do require language, but metaphors are understood by lower parts of the brain. So they are very effective. Okay, and sometimes clients would use metaphors. One of my clients, I remember, used the metaphor, I am a dustbin, she said. Now, yesterday we were doing one small little exercise in which how to rephrase something. I'm not sure how many of you were there. But when a client gives a metaphor, sometimes you stay with that, but very gently you can also rephrase it. Another one of my clients gave a metaphor, I am a seed, but it's broken. She went for an expressive arts workshop and they asked each of them to draw anything that they think they are. So she drew a seed which was broken. And the next day she came for the session, she brought her chart to show to me. So and then she had tears in her eyes. They asked us to draw and I drew this. I thought I'll show it to you. I am a seed which is broken. But it had a lot of colors. There was yellow, there was some different colors. So I said, yeah, so I'm glad you are a seed. And as you know, the seed does get broken to sprout itself. So does it seem like you're sprouting? and she suddenly looked at it as a different angle. But see, you have to be cautious. Don't rush to make it positive, because it sometimes becomes like, you're just doing what everyone else does. So you have to be very attuned to the client and decide what may work that time. So use metaphors, combine them with imagination if possible. That always works better rather than just using words. Now, this is something which is useful in all therapy modalities, but I pay a lot of attention to this, the therapist self. So if the therapist believes certain things, they will have a lot of effect on whatever therapy we are doing. We cannot put our beliefs away. And which is why in India it is not at all mandatory. In most of the developed countries, it is mandatory for therapists to undergo their own therapy. Because until and unless we resolve our own trauma, until and unless we are aware of our own beliefs, directly or indirectly, our beliefs will keep having an impact on our therapy process. Just a last couple of slides. So some of the crucial points to remember in working with trauma: the lower parts of the brain understand the tone in which we say. So the same thing when you say in a tone which shows your compassion, your attunement with the client, your facial expression, your non-verbal communication, the lower parts understand these much more than logic and just the words that you are saying. And in therapy, see, language and logic both are in the left brain and higher brain. Right brain to right brain communication is actually where therapy happens. What is the therapist thinking and feeling about the client? What are the therapist's beliefs and feelings about the circumstances of the client? If I don't say this to the client, but if I just think, oh, this woman, she's always having headaches, that means she is just somatizing, or whatever beliefs I have. If I have even a judgment in my own mind, my therapy cannot be effective with this client, because I need to work with my beliefs, and the beliefs get communicated right brain to right brain. And all good therapy happens right brain to right brain of the therapist to right brain of the client. Therapist's genuine beliefs can be very therapeutic. If I genuinely believe that no matter what trauma has happened, it can get treated. If I actually believe that, not just in my words, but in my heart, I believe that, it will be therapeutic. Because the way I will work will differ. What I do with the client, how I do with the client, my presence with the client will be very different, rather than if I think the opposite. An emotionally regulated therapist is very important. Just as I gave you the example, if the baby is crying and if the mother gets, oh my God, why are you crying? What happened? That is very dysregulating for the baby. So when I said we use a lot of attachment theory in our work, if a therapist is getting flustered about different things, that is very dysregulating for the client. And a well-regulated, a well-contained therapist is actually very regulating and very stabilizing for the client. A therapist's consistency, structure, predictability, compassion, and so on are very therapeutic. So have a regular fixed slot for therapy if you are seeing clients in therapy. If you see them every Thursday 10 a.m., it is much easier for people to spend their entire week knowing my Thursday 10 a.m. will come. There's like a definite end to the week, because there is a predictability that my therapist will be there. Please never forget sessions. Please never give double appointments. Please never disappear. You can tell them that you can't come, but don't do that also too often. I have clients who come and tell me that, this therapist used to either forget, or they used to just call at the last minute, I'm not coming today. I mean, see, if you're saying that waiting for that Thursday 10 a.m. would be very helpful, imagine waiting for that Thursday 10 a.m. and every Thursday 9 a.m. getting the call that, or even more than twice in a lifetime getting that call is very destabilizing. That means, again, it can trigger the belief I don't matter and other things are much more important. So in therapy, no matter what goals we have in trauma therapy, one of the basic core goals is to heal the attachment wounds. So to repair whatever attachment trauma has been there and to slowly facilitate an earned secure attachment style. So whichever of the three insecure attachment styles the client may have had, whether it is preoccupied or avoidant or disorganized, we can facilitate an earned secure attachment style. It is very important, more important than discussing anything. And thankfully, it is possible to do this. It happens. It will not happen in your 10 sessions, 15 sessions, but it happens eventually. Always have hope no matter what has happened. Rigorous methods of trauma therapy can help treat psychological disorders. I feel very distressed when psychiatrists treat psychologists as, talk to the counselor, you will feel slightly better. And if they have the belief that only medicines will actually treat and therapy will only be a little supportive therapy, I find it offensive. And sometimes I have even requested psychiatrists to stop the medication if it was not needed and say that please leave the client to me, and the client has gotten better. So trauma therapy is not to just feel slightly lighter and slightly ventilate and feel better and then go back and have the same symptoms. No, not at all. It treats psychological disorders, which is much beyond feeling better. Trauma-focused therapies can help in treating physical illnesses also. I have clients who have had migraines for years, who have had PMS for years, who have had asthma for years, and different IBS for years, and it is better without any medication because their trauma has lifted and dissociation is much better. So physical disorders do get treated. I'm not even saying they can get treated. I'm saying they do get treated. Then again, we very often have been taught, whatever is a trait the person has had, that will never change. Whatever was a trait, when we are saying trauma can be from infancy or even prenatal trauma, but if we can treat the trauma, even whatever seemed like traits of that person, they can get treated. It is often said that trauma is not in the event, which you have heard enough number of times since yesterday. It is not what happened, but it is what happened inside of us as a result of what happened. And the slogan that is used is the past is present. So if in the past we have had experiences of abandonment, we will feel abandoned more often. If we have had experiences of being manipulated, we will feel manipulated very often. So whatever has happened in the past, the body is still holding those experiences and they are still present. The old saying, time is the best healer or time alone will heal all wounds is not true. It is not true. Things which have happened with people decades ago still trigger them. So time does not alone heal. There are very effective methods of therapy which can heal. But this is good because no matter how long ago someone has gone through trauma, there is always hope. So I stop my presentation with that, and if there are any questions I can take, this is my email ID in case anybody wants to contact for further training which I conduct. I hope I did not take too long. Are there any questions or everyone's in a rush to go back home?
Are there any questions? We'll just take one or two questions due to the paucity of time.
Good evening, ma'am.
Good evening.
Okay. So my question was, first of all, thank you for such an enriching session. My question is that a lot of times, a lot of us are still new to incorporating trauma work into our therapeutic practice. And so it can feel like, there's a lot of training required. There's a lot of unlearning and relearning required to be able to do this work in an informed and competent, effective manner. So, what would be some ways to kind of step into this and incorporate it in our practice, at least like to initiate that process?
So, unfortunately, in the MPhil training program, there's hardly even any mention of the word trauma, or maybe just a couple of mentions, maybe while treating the client with BPD, you might have heard. That's all you may have heard. There are training programs internationally. There are people like Janina Fisher and other people in the US conduct. I conduct one foundation course, which used to be 30-hour long course until last year. This time when I announced, mostly it will be a 60-hour course, because it used to be mostly foundations, and this time we'll club foundations and skills mostly. Then there are specific trainings in different courses, in different modalities, like somatic experiencing training happens, internal family systems therapy training happens, EMDR training, brain spotting training. So you can choose whichever modality you like. Ideally, you should be trained in the basic understanding of trauma and learn more than one modalities, because it's best to integrate different models, because different things work with different people, and you have to learn some parts based work, you have to learn some somatic based work, and you have to work on your own self, your own beliefs. Then you will really find trauma therapy so effective that it is so beautiful.
Right. Thank you so much, ma'am. This has been really wonderful. And I think we all have gained a lot of knowledge and understanding about how talk therapy can be limiting. And there are so many approaches that we need to kind of combine together. But basic knowledge of trauma definitely needs to be at the base of everything. Thank you very much for joining us. It's been
Thank you.
Great pleasure.
My pleasure.
2 sessions from you. Thank you very much, ma'am. And
Thank you.
we will continue. We need one group photograph. We are missing you, ma'am, on that group photograph. But one group photograph of all the participants. Can we all kind of come together here in the, with the backdrop to take a group photograph? Please, everybody, very quickly. Yeah, ma'am. Ma'am, can you please just stay? We'll put you on the screen so that we have you also as a group.
Sure.
The IT team, can they help us get a more larger view of ma'am? And everyone, quickly. And we some people have to leave. We've been getting requests of winding up quickly. So can we just do this as quickly as possible? Please get up and come in front. Some people can go up. Yeah. Please come on the stage. Everyone, quickly, can we, we'll just have to work a little faster. Let's wake up. Also, just together. Please come in front. We'll have to kind of come together. Aajo, jaldi. Some people may like one row, 2 rows on the stage, please. आ जाएंगे. Please come. सारे ही हैं mostly. There are hardly few without RCI number. Please come. कुछ bed आगे एक और. Can we go one more? Can we go a little behind and one more row? Please go. Yes. Can I request IT department to kind of broaden the screen? Screen. आ जाइए. चलिए. Yep. Come a little here. That's all. We need a group photograph. That's all. It needs to go to RCI. That's a requirement also. बस यहाँ पे खड़े हो जाइए, इधर आ जाइए, इधर आ जाइए, इस रो में भी आ जाइए. You know, we can come here. Yes. Please come. Yeah, the volume needs to get reflected. We are saying we have 200 participants. We need to show 200 participants roughly. Please, can you all join here? Yeah, wherever you are. Yeah, that's okay. Yep. And the camera will make sure. When can the photographer let us know if it is done? Then we support. Yeah, one more. आगे आ जाए. Yes, please come in front. आगे आ जाओ. 1 minute, one second, please. Thank you everyone. Thank you, ma'am, for being.
Thank you. All the best. Bye bye.
Bye, ma'am. Hopefully, we will meet in person very soon also.
Yes, hopefully. Bye.
Bye, ma'am. Yeah. All right, can we just go back to our seats for a minute? So we'll be calling 10 names. Come and collect your certificates, and we'll do it quickly. If you know the list, we are going to go by the list. Can we please sit down? Can we please sit down? Mika Malhotra, Lizu Kaur, Sanchali Ghosh, Paridhi Talwar, Basvavanti Das, Tanisha, Monica, Dr. Deepika Srivastav, Miss Aditi, Miss Arzu Wadhwa. Can you please come in front? And Apsa, can we please? It'll be easier if we all sit down and just quickly come as your name is said. The first 10 people. Mika nahi hai. Okay. Paridhi Talwar. Yeah, please. Just be here. आप आ जाओ इधर. अच्छा ठीक है, फिर बाद में ले लेना. आदित्य का यहाँ रखा है. ठीक है. संचाली. Quickly. Next, Riddhi Arora, Ratnakar, Mr. Ashutosh, Mr. Sajid Ali, Miss Hemlata. Sorry, it's going to be Mr. and Miss confusions for me. Miss Anali Das. Hanji. Okay, stage pe chale jaye, please. Sure. And okay, now photo of these people, those of you who have certificate, can you go on the stage, please, quickly? Yahin se chal. Sonali Das, come on the stage. Okay, Sonali का दे दो. Order में ही. जल्दी order में ही दो. ठीक है. आप सोनाली आपका नाम आज रत्नाकर हाँ हाँ जी ओके just give us 5 minutes हाँ आप हाँ ओके हाँ जी खड़े हो जाओ आप पीछे आ जाओ ना खड़े हो जाओ पीछे यहाँ पे खड़े हो जाओ आप लोग ओके
कौन होगा
इस टाइम में
ले आओ आई एम वेटिंग फॉर यू
आप आज से बाजू थोड़ा सा जो फोटोग्राफ हो रही है तो जल्दी जल्दी कर लो ठीक
हाँ मैं ऑर्डर में बुला रही हूँ ऑलराइट मिस्टर उमेश मिस शिवाली मिस्टर शुभम डॉक्टर बबीता रिद्धि का हो गया वो नहीं है हटाओ उसको नहीं है वो I think Sajid Ali has been given, Ratnakar has been given, Mr. Ashutosh has been given, Mr. Shahid Ali, Mr. Umesh, Sonali Umesh के साथ है, Mr. Umesh, Shivali Devgan, Shubham Vats, Babita Prushti, Shipra Singh, Swati Omar, Antima, Monica Kumari. Please make a queue and come up. ऊपर आ जाइए. Yeah. Okay. Miss Jyoti, Mr. Manav, when we say your name, can you say yes so that we know you are here or not? Okay. Can you please come and take a photograph? Excuse me. You'll have to wait. Miss Jasmine Dua, Miss Disha Dank. Miss Iram, Miss Iram. Faiz Shameen. Iram. Miss Akansha Sharma, Miss Bhavna Chaurasia, Miss Apurva Saxena, Mr. Surendra Kumar Chopra, Miss Prerna Khanna, Miss Jebu, Mr. Jebu, Apurva Saxena, Mr. Surendra Kumar Chopra. So please. Miss Prerna Khanna. Okay. Mr. Jebu, Miss Ashi Khanna, Miss Sophia, Miss Suman Pal, Miss Alka Gupta, Mr. Mohammad Ali, Mr. Rahul Dabas, Mr. Ayush Chandra, Mr. Vikas Dabas, Dr. Dipti Yadav,
Miss Sanjana Kumari. Can we take a photograph also, or we are not taking photo? Now, please, all the ones with the certificate, please take a photograph also after. Miss Divya Bansal, Miss Sanjana Kumari, Miss Poonam Sharma, Miss Shirley Raj, Miss Nidhi, Miss Supriya Bhushan, Miss Ikra, Miss Sunaina. Can you just wait, please, for a photograph also? Divya Bansal, Miss Sanjana Kumari, Miss Poonam Sharma, Miss Shirley Raj, Miss Nidhi, Miss Supriya Bhushan, okay, Miss Ikra, Miss Sunaina, Miss Ayushi Tyagi, Miss Payal Gupta, Miss Himanshi Khanna, Miss Mahika Sharma, Mr. Bharat, Miss Tamanna, Miss Debanjali Basu, Please come. Wait for the next one. Wait for the next round. Miss Madhuri Jain, Miss Kalyani Pandey, Miss Lavlina Sharma, Miss Priyanka Kumari, Miss Surbhi Gupta, Miss Pranali Mukherjee, Miss Anu, Miss Sukriti Das, Miss Priti, Miss Preeti, Miss Aprajita Dikshit. Can you just wait for a photograph now, please? Miss Anu, Preeti Dangwal, Miss Aprajita Dikshit, Miss Simran Kaur. आगे चले जाओ. Miss Mridula Kant, Dr. Anita Malik, Miss Divija, नहीं है. Miss Megha, Miss Siddhi, Miss Minu, Miss Harpreet Kaur Arora, Miss Shivangi Agarwal, Miss Priyanka Thalega, Miss Sukriti Dhingra, Miss Girja Sharma, please come up front. Miss Siddhi Gogia, Miss Minu, Miss Harpreet, Miss Shivangi, Miss Priyanka, Miss Sukriti, Miss Girja Sharma, Priyanka Thalega. Sorry for the pronunciation difficulties. Please bear with me on that. Okay. Divija Malik. Minu. Miss Harpreet Kaur Arora. Harpreet Kaur Arora. Miss Shivangi Agarwal. Miss Priyanka Thalega. Priyanka Thalega. Miss Sukriti Dhingra. Miss Girja Sharma. Later. Okay, photograph कर लो.
Miss Nikita Sharma, Miss Aruna Maheshwari, Miss Shilpi Gupta, Miss Priya Singh. Mr. Arnab Ghosh, Miss Pooja Bhatt, Swati Bhang. ये है ना 2 मिनट रुकना. Miss Swati Bhakchandani, Miss Naina Sharma. Please raise your hand or yes, at least so that we know you're around. Miss Naina Sharma, Miss Megha Kalra, Miss Shraddha Banerjee, Miss Hema Mehta. Yes, please. Miss Manisha Verma, Miss Neha Singh, Miss Aditya Bhatt, please come. Trisha Walia. नहीं आप ये Trisha. Okay. Next round, Miss Varuni Sethi. Miss Varuni Sethi. Miss Kakashi. Miss Divya Khattar. Mr. Lalit Sharma. Miss Sahar Seeth.
Miss Pallavi, Miss Seema Sharma, Sakshi Gupta, Pallavi, Sakshi Gupta, Pooja Jaiswal, Sumaiya Khan, Sumaiya Khan, Tanushri Deka, Ayushi Gumbar, please come. आ रही है वो आयुषी है विशाखा कोहली, जो नहीं मैं यहाँ रख रही हूँ, यहाँ से उठा के दे देंगे, है ना. खुशी कौशिक, हुमेरा आसिफ, जैस्मिन कौर, छोड़ दो. Dipanjana Chakraborty, please come ahead. Ishita Bhatt. हम लोग को भी थोड़ा कन्वीनियंस हो. लो चलो आकांक्षा, तुम्हें बहुत जल्दी थी. कृति एस पुंजाल. कृति भी चली गई है, छोड़ो. दीपांजना का कहीं देख लेता. मीमांसा जा चुकी है. चलो. खुशप्रीत कौर. हाँ है एस मुंजाल. खुशप्रीत कौर. अलका सांकला. आराध्या अवस्थी. स्नेहांकी चट्टोपाध्याय. आराध्या अवस्थी. स्नेहांकी चट्टोपाध्याय. अलका सांकला. ज्योति लक्ष्मी त्रिपाठी. आई थिंक शी इज कमिंग. कामना भी आ रही है. कामना. शौर्य गुप्ता. शौर्य गुप्ता. प्राची अग्रवाल. प्रांची अग्रवाल. ज्योति ग्लोरी परनाड. राधिका राधाकृष्णन. राधिका राधाकृष्णन. सुमन कुमारी. सुमन कुमारी. श्रेया शर्मा. सायंतनी मुखर्जी. दे दो श्रेया शर्मा का. सायंतनी मुखर्जी. तमन्ना सिंह. Tamanna Singh, please raise your hand so that we can identify that you are coming. Tamanna. Please. Ankur Singh Kapoor. Yeah, good. Tanvi Paluja. Tanvi Paluja. Please come. आ रहे हैं बाहर में से उठा के दे देना. ईशा करण. प्लीज कम. ईशा करण वो भी आ रही है. आभा खुराना. प्लीज कम अहेड. हाँ. अंकिता विश्वास. प्लीज प्लीज स्टैंड ओवर हियर. यू कैन गेट क्लिक्ड. इंदु मल्होत्रा. इंदु मल्होत्रा, प्लीज रेज योर हैंड. Yeah, good. Gavneet Kaur, please come ahead. Akshita Sharma. Akshita Sharma, are you there? आ जाओ. अक्षिता को दे देना. सृष्टि जाजू. सृष्टि, are you there? आ जाओ फटाफट. गुरसबीन कौर, प्लीज कम. सृष्टि इधर है, दे दो. गुरसबीन कौर, प्लीज गेट क्लिक्ड. कनिका निर्मल. कनिका निर्मल, आर यू देयर? प्लीज कम अहेड. सलोनी ढींगरा. सलोनी ढींगरा. प्रियंका भट्टाचार्य. प्रियंका भट्टाचार्य. सोनल चड्ढा. Sonal Chadha, are you there? Sonal का नाम बताओ इधर नहीं है वो. Shreya Malik. छोड़ दो ज्यादा आवाज मत दो. दिव्यांग शर्मा. दिव्यांग शर्मा दे दो. चलो हम लोग कहीं साइन भी नहीं करवा रहे हैं. दिव्या डावर. कल कोई फिर से क्लेम कर सकता है. सिमरन मलिक. सिमरन मलिक, are you there? Please come ahead. Mehjabeen. Miss Mehjabeen. Are you there? Miss Mehjabeen. Miss Mala Vohra. Mala, please come ahead. Nikita Jain. Nikita Jain, are you there? Parul Kathoria. Parul Kathoria. Miss Drishti. साइड पे रखो. मिस दृष्टि आ जाओ. कमल चोपड़ा. मिस्टर कमल चोपड़ा. मिस अपूर्वा कृष्णन. अपूर्वा कृष्णन, आर यू देयर? Trinka Arora. Trinka, please come. Soumya Pahwa. Soumya, come ahead. Apurva Chaudhary. Apurva Chaudhary, yeah. Tanya Bakshi. Namrita Gupta. Namrita Gupta. नहीं है. श्वेता पाठक. श्वेता पाठक. आंचल चौधरी. मिस आंचल चौधरी, प्लीज रेज योर हैंड. या गुड. साक्षी त्यागी. अपर्णा गुप्ता, प्लीज कम. राहुल शर्मा. राहुल शर्मा. Yeah, he's there. यहाँ से उठा के देना. तू आगे चली जा. नेहा गहलोत. मिस नेहा गहलोत, प्लीज कम. रूही मित्तल. रूही आ जाओ. यहाँ रख के हाथ दर्द हो जाएगा. अनमोल धीमान. मिस अनमोल धीमान, आर यू देयर? प्लीज कम अहेड. शौर्या शर्मा. या. अमित कुमार. अमित, आर यू देयर? या. टेक इट. मैम के साथ ले लो. द्युतमा शर्मा. द्युतमा शर्मा, प्लीज कम अहेड. सुमेधा. मिस सुमेधा कटपलिया. Hope I have pronounced it right. Miss Sumedha Katpalia, are you there? सामने जाओ. Sumedha Katpalia, are you there? Please come ahead, ma'am. Sneha Hajra. Sneha Hajra. नहीं. Vibha Rungta. Vibha Rungta, are you there? सब पीछे आ जा रहे हैं. बोलती हूँ, आने दो. Vasundhara Chaudhary, please come ahead and collect it from ma'am. Dr. Rushi, stand beside ma'am. Miss Aditi Chandra Srivastava, are you there? Come here. Ruhi Maheshwari. Ruhi Maheshwari, are you there? Please come ahead. Vidushi Duggal. Vidushi Duggal. हरनीर कौर, मिस हरनीर कौर, उधर से आओ, मैम के पास से लेना, ऊपर आओ। रेवती, मिस रेवती, अनुष्का मोदी, अनुष्का आ जाओ, आर यू देयर? स्टैंड इन द लाइन एंड गेट योरसेल्फ क्लिप्ड। रिया जोसेफ, रिया, आर यू देयर? कम अहेड। शिबा Samsuddin, शिबा Samsuddin, आर यू देयर? नहीं। मिस अमीशा, मिस अमीशा, आर यू देयर? Not present. जितेंद्र सिंह, मिस्टर जितेंद्र सिंह, वो आ रहे हैं, प्लीज कम। अभी तो पूछा, हाँ भी नहीं बोला। आरुषि गोयल, आरुषि गोयल, आर यू देयर? ये हमारी, अच्छा, शेफाली चोपड़ा, मिस शेफाली चोपड़ा, आर यू देयर? प्लीज कम। इनका ना फिर से रिकरेक्ट होने गया है, आप समझा देना। हाँ हाँ। मिस वृंदा गौर, वृंदा गौर, आर यू देयर? प्लीज कम। शुभम शर्मा, शुभम शर्मा, प्लीज कम अहेड। वृंदा गौर, या शुभम शर्मा, आई थिंक ही इज नॉट देयर। श्रीकांत गोगी, श्रीकांत, डॉक्टर अनिता मलिक, डॉक्टर अनिता मलिक, आर यू देयर? मिस दिविजा मलिक, दिविजा मलिक, अपराजिता दीक्षित, अच्छा, डॉक्टर अरुणा महेश्वरी, मिस मिरांडा, नहीं, एक बार अनाउंस कर देते हैं ना, मिस मिरांडा देखो आ गई, वो बोल दो, बोल दो। डॉक्टर बबीता तो नहीं है। मिस्टर हाशमीन अब्दुल्ला, हाशिम अब्दुल्ला, यस। इरफाना खातून, तो आप हाँ ले लीजिए प्लीज। आपकी वाइफ है कहाँ? अच्छा, आप रह गए, आपकी वाइफ चली गई? ठीक है, ठीक है, कोई बात नहीं, हो गया। शिवाली देवगन, शिवाली देवगन, शिवाली। मोहम्मद आदिल, प्लीज। हाँ हाँ, उनका नहीं करो।
सबका बंद हो देख लो नहीं करना पड़ेगा कैसे नहीं
Good evening to one and all present here. In this 2-day seminar titled Trauma Informed Care Robust Theory to Practices, accredited by RCI, on behalf of Amity Institute of Behavioral Health and Allied Sciences, I, Rashmi Pandey, feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. I express sincere thanks to our respected founder president, Sir Dr. Ashok K. Chauhan, who has always showered his blessings and has been an inspiration for all of us. My heartfelt thanks to our respected Chancellor, Sir Dr. Atul Chauhan, for providing the platform to hold such academic deliberations. I thank our respected Honorable Vice Chancellor, Madam Professor Dr. Balvinder Shukla, for being the guiding light in all the endeavors of IBHAS. I also thank our mentor, Dr. S.K. Srivastava, who has always stood by us and motivated us to strive for excellence. Our respected Dr. Jayanti Pujari, Ma'am, Dean Rehabilitation Sciences, for her continuous encouragement and support. Dr. Rushi, Director IBHAS, for taking the initiative of organizing the event, and my esteemed colleagues for their unwavering support. We have been privileged to have the esteemed presence of esteemed speakers whose valuable insights and expertise have enriched the event. I extend my heartfelt appreciation to each of the speakers for accepting our invitation and enlightening us with their knowledge and experience. I would also like to extend my thanks as well as acknowledgement to all the staff, from media personals, from ASCO, media people, from IT department. Our special mention to our staff, Mr. Sandeep, Mr. Sundar, and a very, very special mention to our senior section manager, Mr. Pawan, who has worked day and night to figure out the details of the entire program. I would also like to thank our hospitality team and our trainee volunteers. I extend my deep gratitude to the audience whose enthusiastic participation and unwavering attention have made this event truly memorable. Your presence here today signifies your commitment to continuous learning and intellectual growth. Thank you once again.
Not least, I would like to express my gratitude and thanks to Ms. Rashmi Pandey, who is the chief coordinator and the organizing secretary for this national seminar, and for the whole organizing team, Ms. Sonia, Predna, Mr. Pavan, Sandeep, Surendra, Dr. Deepika, Dr. Deep Chand, everyone who have worked so hard for organizing this event.